All right. Very good morning, everyone. And I hope you enjoyed your travel here to Vilnius, to the great venue, the Palace of the Grand Dukes of Lithuania. So from my knowledge, this is the first time when the organizers decided to make a conference with the invitation of all the stakeholders that are interested in our healthcare system. Let me introduce myself. So my name is Tomas Lapinskas. I'm not the host of this amazing venue. I'm just a doctor, as many of you are here, a cardiologist, but also I'm representing one of the hospitals, the Hospital of Lithuanian University of Health Sciences, Kauno Klinikos. So I think that today we're going to have a great presentations, as well as amazing discussions, panel discussions. And therefore, I invite you to freely discuss and share your opinions, insights about our healthcare system. So as every conference, probably we should start with welcome speeches. And afterwards, I will present a short agenda, how we're gonna work today and what the presenters will be. And the first speaker, and I would like to ask and to invite to welcome you here, is Aurimas Pečkauskas, the Minister of Health of the Republic of Lithuania.
Thank you, Thomas. Your Excellency, the Ambassador of Japan, distinguished members of Lithuanian Parliament, honorable Vice Ministers, esteemed professors, doctors, and heads of healthcare institutions, ladies and gentlemen. I would like to personally thank you for taking time out of your busy schedules and welcome you to the International Conference, Advancing Healthcare, Integrating Management, Data, Financing, and Innovations for Better Outcomes. The idea to organize this conference arose from Lithuanian delegations' recent visits to the United States, Singapore, and Japan. The insights and experiences gained during those visits have sparked significant interest and underscored the critical need to explore how healthcare is managed and delivered in these countries. As a representative of the executive branch, I am often haunted by observation that macro decisions, such as balancing the budget, regulating services, quantifying the volume of services, often lose sight of the patients, the doctors, nurses, the heads of the health facilities, and their needs. Critics sometimes justly say that all of them must live with the abracadabra that is born in the government offices and meetings. Implicit in this criticism is a desire to live more simply. We all want simple solutions. Patients want clear treatment paths and fast services. Doctors want the least bureaucratic treatment process and the greatest possible freedom in decision-making. Managers want unlimited material and human resources. I must sadden you, but life, and therefore the healthcare system, will never be simple. Science is advancing, the frontiers of medicine are expanding. Diagnostics are becoming more accurate, and health policy decisions must consider more and more criteria, not only rational, but also emotional ones. It is fair to joke that the complicated title of this conference is a sign of our difficult situation. Probably few of you would repeat it without a glance at the program. The goal must be different. To borrow a quote from Jack Dorsey, co-founder of Twitter, now known as X, my goal is to simplify complexity. I just want to build stuff that really simplifies our basic human interaction. What is true for the world of technology is true to our world of health. Technology and data empower us to make complex things simpler. That must become our focus in this conference today and in everyday life. Dear friends, this conference also offers a different kind of chance. It's a great opportunity to talk and understand each other. We have a whole Lithuanian healthcare ecosystem, both vertical and horizontal, in this room. It is not often that decision makers, health system administrators, health facility managers and administration, doctors, inventors, and data analysts come together in one place. Different perspectives are enriching, but more importantly, speaking from different perspectives creates a common interest in getting along. This is what I wish for all of us gathered here today. Despite our different experiences, different positions, different angles of approach to the healthcare system, to listen to each other so that we can build a healthcare system that is convenient for the patients, the doctors, and the managers. I wish you all fruitful discussions and encourage you to actively participate in the sessions. It is through our collective efforts that we can create a more robust, innovative, and responsible healthcare system for the benefit of our society. Thank you all.
Thank you, Minister. And now I would like to have here on stage the representatives from the large healthcare institutions that are a very important part in providing healthcare services in Lithuania. So first, I would like to welcome here Director General of Vilnius University Hospital Santaros Klinikos, Tomas Jovaiša. Please.
Thank you very much. Good morning, everyone. Firstly, I'm immensely grateful to our distinguished guests who took a lot of effort to come here. So thanks a lot for agreeing to travel literally around the world to come and see us and to share your experiences. I think our Minister has already covered most of the points, and there's hardly anything to add to this. I think one thing is certain: there isn't a perfect healthcare system in the world. We know that for sure. But there are many different healthcare systems, and there's a lot that we can learn from each one of those. And the truth is probably somewhere in the middle. So if we carefully pick the best bits out of everything, we might just come up with something that works for us. It may not be perfect for someone else, but it may work for us. And I truly hope that this meeting and the discussions that we will have during this meeting, that this will trigger our next debate on how our Lithuanian healthcare system should be designed, how it should be run, how it should be financed, and what we are looking for and what goals we are setting for ourselves. So I truly hope that this will be this trigger point. And I also ironically hope that we will disagree. And disagreeing means that we will have discussions, that we will try to prove things to each other, that we'll try to unpick the details that we may or may not like. And I hope that we will have a lot of discussions and a lot of debate and a lot of different opinions during the panel sessions. Hence, they are designed into this conference probably much longer than in your usual medical conferences. Because in these debates and in these discussions, we are more likely to find truth than just merely in the presentations. So I would ask everyone to think of what you find interesting, or what you agree or disagree with in the presentations, and please raise your hand and raise those questions and discuss those questions during the panel session. So I wish everyone a very fruitful and interesting day, and I truly hope that this is one more little step towards creating a better healthcare system in Lithuania. Thank you.
And now for the opening remarks, I would like to invite Professor Renaldas Vilkevičius, Director General of the Hospital of Lithuanian University of Health Sciences, Kauno Klinikos. Such a long wording.
Thank you, Thomas. Your Excellencies, Ambassador, our Minister, our guests from foreign countries, my colleagues. I will tell very simple things. I will tell about origin of this meeting, of this conference. We started maybe 2 years ago, and I'm happy that in this hall we have 2 persons who started conversations about possible visit of Kaiser Permanent. we have Bruce Wallman, and our NT doctor, Alina Kuzminine, a young doctor who started to become manager of new outpatient department. And she came to us and told, look, I don't have enough knowledge how to run the department, and I need to learn. Okay, look at the opportunities around. She has a friend, Lithuanian origin, working at the Kaiser Permanent. Sent email, get message back from medical director of Kaiser Permanent, Bruce Wallman. Dear colleagues, look, recently we have at Kaiser Permanent 2 ministers, Minister of Luxembourg and Minister of Netherlands, health ministers. Maybe your Minister of Health, Arūnas Dulkys, can find opportunity to come to the United States and to see how we are working, what kind of payment system we have in Kaiser Permanent. Maybe you can learn something from us. And we started sending letters to our embassy, Lithuanian embassy to United States. Please help us to organize a visit of our minister. After some months passed, our former minister, Arūnas Dulkys, write to me, Renaldas, please send all these conversations to our health ministry, to people responsible for foreign affairs. They will do their best organizing visit of the minister. And next, it was autumn 2023. Minister Arūnas Dulkys invited 3 gentlemen from 3 university hospitals from Vilnius, Kaunas, and Klaipėda to join him together with our Chancellor Jurgita to visit United States and important to see the best Kaiser Permanent, Johns Hopkins Hospital, also officials of the health in Washington. And idea was raised by us sitting in the bus at the evening, coming back from Johns Hopkins to Washington, D.C., asking minister, what will be next? After your visit, we will come back. We will be full of memories. We remembered nice ideas, but what will be next? In my career, I have very good teachers. One of them, now he is Vice Minister of Foreign Affairs, Egidijus Meilūnas. Most of you know him. He was serving as our ambassador to Japan, later to Ireland, and now he's Vice Minister. And he teach me that you should, when you will come back, you should continue, because these short 1 hour, half an hour meetings will just a beginning. You should be active. You should write letters. You should invite your friends. This is right way to have some new value for your hospitals. After, Egidijus, he is a physician, pediatrician. Why he helps maybe us open some doors. Sometimes it's difficult to open even for the Ministry of Health of Lithuania. And during these trips to United States, to Singapore, to Japan, we feel that Egidijus is looking at us, what we are doing after the visits. not during the visits, but after. And when we meet together, he always is asking, what kind of results after your visits do you have? Our ambassadors to these countries after our visits also are asking, what you have after your visits. And why we have the conference? The conference has two parts. These all two parts are very important. I will not talk about today because previous minister and my colleague from Santa Hospital tells about the conference. We have fantastic our speakers. Professor Yamamoto traveled more than 20 hours from Japan for these 2 days. Very important is second day, visits of our best hospitals. Because after these visits, maybe our friends, our colleagues, we will know better about us, what we are doing. And maybe after this, we will establish real collaboration. It's our hope. And I hope we will succeed. Thank you again for all of you who are here in this room.
Many thanks, and thanks for disclosing the story behind and how the conference came to the reality. The next speaker would like to give you a warm welcome from the seaside. So I would like to invite Audrius Šemaitis, Director General of Klaipėda University Hospital. Please.
Thank you, Thomas, and dear distinguished guest, dear minister, and dear ambassador, dear guests from Japan, Singapore, America, and obviously all the friends from Lithuania. It's my absolute pleasure and delight to see you here, and I would think that we need to call this conference "How We Survive in Modern Society," which I think is going in a very frantic and crazy way. In a three different, we are being pulled in a three different directions. If we see from the patient's point of view, I remember, let's say, 10, 15 years ago, if you say to the patient that the patient will hear answer in 3 or 4 days or after the test, they will be delighted, you know. A few years ago, if you say you need to wait a couple of hours, they will be over the moon. But now they would like the answer to be heard in a second with instant gratification. On the other hand, they would like that this care has to be of superb quality. So from a third side point of view, I mean, if you look from the society in general, from the healthcare institutions, they would like to spend less and less money, so the money has to be cost effective. So, I mean, the only way to survive in this frantic environment is to cooperate, to discuss, to be together, to find the optimal solutions. And to add to the complexity of nowadays, I think we're living in the times when there is so much information available, so much data, so many figures, how we process these figures, how we put this into practice, and what conclusions we can make from these figures. And this is the arena where artificial intelligence is coming into the place. And I'm sure we'll hear plenty of these topics during these discussions. So I would like to wish everybody fantastic deliberation, fruitful discussions, and I would like to wish all our guests from all over the world to have a fantastic time here in Lithuania. And I really hope that this is this is only a start of our cooperation. This is the first meeting, and I really look forward to meeting number 2, number 3, and number 10. Thank you.
Well, that's a great wish. That means we are just starting with the first conference. So the last but not the least, I would like to invite for the welcome speech Valdas Pečeliūnas, Director of National Cancer Institute.
Thank you, Thomas. Distinguished guests, Ambassador, Minister, a lot has been already said, so it's difficult to add on, but I just remember our spring trip to Singapore and Japan, and that was not just like team building experience for a healthcare institution's management, but also, at least for me, an opened experience. So I've been looking for a quote to sum up today's conference, and that's what I've chosen. It's not the strongest species that survive, nor the most intelligent, but those who are most capable to adapt to changes. And yes, it's Charles Darwin. And I believe that these words could perfectly could perfectly describe also systems and organizations. So I believe that today's conference topics are very relevant to today's challenges of our healthcare system. The main challenge, I think, is increasing prices due to aging population and advancing new technologies, which are expensive ones, and we need to implement. We need to acquire these technologies for our patients. And again, we need to implement these challenges, so we need to innovate. And today's conference perfectly relevant to this topic, and I believe that many answers will be given during today, and I think many questions will be raised. So I would like to take a chance to wish all the participants fruitful conference and engaging discussions. Thank you.
Thanks. I probably fully agree that we don't need to reinvent the wheel, and that's why we are trying to look at the best solutions, what we do have in the world, and maybe to adapt by using the biodesign approach, just trying to identify where's the problem and what could be the most suitable and potential solutions to solve it. All right, so we are finished with the welcome speeches, and I would like to give you a bit understanding about today's program and how we created it. So I will only announce the list of speakers before the coffee break, but please don't go away even after the lunch, because till the last panel discussion, we have very, very interesting invited speakers to be here on the stage. So not everyone what you see on the list, there will be many more people invited for the panel discussion. So keep holding here. So we will start first with the panel first, which is dedicated for management, financing, and economics in the healthcare, and have amazing faculty, as you can see already, traveling from all over the world, especially from States, Singapore, and Japan. And during the first panel, we have 4 speakers, and afterwards we'll go for the coffee break, which will be here. All right? And then we will come back and we'll have a panel discussion of this session. All right, so I would like to invite the first speaker, the Bruce Wollman. And if you don't mind, I will read all your. He's an Associated Medical Director, Government Relations, Medicare Strategy, Radiation Oncology, Health Utilization, Pharmacy, Genetics and Pathology, Laboratory Services at Kaiser Permanente. Is it right? Perfect. Please, so Bruce, I'm inviting you on the stage, and I will try to upload your presentation.
All right. Okay, good morning. Again, my name is Bruce Wallman, and I'm an Associate Medical Director for Mid-Atlantic Permanente Medical Group, Kaiser Permanente in the Mid-Atlantic States, which is Washington, D.C., Maryland, and Virginia. And I'm going to be, the title of the talk this morning is An Introduction to American Healthcare Economics. Of course, the subtitle, I think, is a little more appropriate, which is How Not to Care for a Patient Population. So, I think of this picture when I think of American healthcare. In the United States, it is illegal to park your car in front of a fire hydrant. Makes sense. The fire engine needs to come and plug in to get the hose to put out a fire. But in this picture that I took, they took the liberty to say, right in front of the fire hydrant, in the red, compact parking only. You should only park a small car in front of the fire hydrant. And that's American healthcare. I'm not a psychiatrist, but it's crazy. So first things first, whenever I speak to a group, I like to think of myself in the position of the audience. And if I were you now, and seeing the previous speakers who are fantastic running large medical institutions, I would have one question, and that is, who is this person? Why am I here talking to you? Very briefly, so I'm a diagnostic radiologist by training, X-ray, CAT scan, MRI. I did most of my training in California, in the United States, at Stanford University. And I'm a medical director for Kaiser Permanente, starting in Northern California, and then moving to the Mid-Atlantic. Now, the next question is, why am I here in Lithuania, in Vilnius, speaking to you all? So here are a couple photos that I take on my commute to the office every day. A couple of buildings that may be familiar to you. And working in Washington, D.C., I actually find fascinating. The reason is, at least in my government relations work, I get to meet interesting people from around the world. For instance, here is a tweet, or now I guess an X post, from the Embassy of the European Union in Washington, D.C., talking about an event they had. And you can see in the picture is all the ambassadors to Washington from all of the EU countries. But if you look carefully, I don't know if any of you are diagnostic radiologists, in the very back and to the left, if you zoom in, there's yours truly, standing in between Christian Priek, the ambassador from Estonia, and Maris Selga, the ambassador from Latvia. So it's been an honor and pleasure to meet with them. And I've also had the good fortune of meeting with Ambassador Audra Plavite from Lithuania. And again, as we discussed before, I've had the honor to host the delegation from the Ministry of Health to Kaiser Permanente in Washington, D.C. And I've also enjoyed greatly coming to Vilnius and meeting with the Ministry of Health here in Lithuania. That was a few months ago. But again, the most important thing for me personally about Lithuania is in this photograph. That's me as a young boy with my great-grandmother, who was a Litvak, who her husband, after the Russo-Japanese War, said, that's it, we're leaving, we're moving to the United States. And my great-grandmother had a daughter, who also had a daughter, who had a son, and that's me. And so it's really an honor to be here in Lithuania, remembering the memory of my great-grandmother. Now, American healthcare economics. There's a phrase in English that says, a picture is worth 1,000 words. So how could I talk about American healthcare economics in 1,000 words? And that's this picture. So you can ask, this fine gentleman having a heart attack, how did we get into this mess in the United States? Maybe he needs a cardiac MRI or a CT angiogram, but let's think about how we got here. So we think about healthcare insurance since 2001 in the United States, And we can see as time goes by, more and more patients are spending more of their own money on healthcare premiums. They're spending it for insurance, spending it out of pocket themselves. Oftentimes, patients don't visit a doctor because it costs too much in the United States, or don't pick up medicine because it costs too much. As we can see in general, going through time, if you have insurance, even if you have insurance, but if you don't have enough insurance or don't have insurance at all, you're more likely to go without needed care, or you can have a bill that causes debt. Interestingly, the #1 cause of personal bankruptcy in the United States is healthcare bills. It's sad. Now, we have some august medical institutions here in the room, but think about this, at least in the United States, what do consumers want? Do they want the choice of hospitals or prestigious institutions? In the United States, we can see that's at the bottom of the list. What American citizens really want is low monthly premiums to be able to afford healthcare insurance that covers themselves, their dependents, their children, their family. That's what American healthcare patients want. And why is that? So we can see, again, going through time, the cost of healthcare is more and more expensive. But we can think about, what are we spending in the United States on healthcare? The EU average is in the dark blue. It's about $6,000 annually per person. In the United States, we spend twice that, $12,000. So you can say, well, okay, America is, I guess, a relatively wealthy country. It's, I guess, reasonable they spend twice as much. So, but if you take a look, let's say, at the EU, in general, yes, the wealthy countries spend a little bit more. We can see Lithuania is in the middle there, right on the line, right where you should be in comparison to the other country. Of course, at the far left, the richest is Luxembourg, but the other L country in Europe. But America is in the green dot. We are richer, slightly more, but we spend way more money than we should compared to every other country. But what do we get for our money? America first, America #1, hooray. If we look at what should we be getting out of healthcare, and that's living longer lives. So here's a chart about life expectancy over time. The blue is the first world average, and the light green is America. We have the lowest life expectancy of any first world country, despite spending the most money. And this brings me to what I like to talk about, €5 versus €500. Or in America, $5 versus $500. If you want to spend €5 for a Hesburger, okay, you're spending a little bit of money, you're getting a hamburger, okay, you accept that. If you want to spend €500 on a Michelin-starred meal, which now, congratulations, Lithuania has Michelin-starred restaurants, okay, you're spending more money, but you're getting arguably a better quality product. But again, in the United States, we're spending €500, the most of any healthcare, with the lowest life expectancy. That's spending €500 at Hesburger, that's just crazy. And that's where we find ourselves in American healthcare, economically. Now, how did we get there? There was a bank robber. His name is Willie Sutton, and I joke he was one of my professors of radiology. But they asked him, Professor Sutton, why did you rob banks? And his answer was simple. It was, because that's where the money is. Okay. So where is the money in American healthcare? We have big corporations, big pharma for pharmaceuticals, manufacturers that make equipment in radiology or whatever else. And for them to make money, they need to sell stuff, very American, very capitalist. So they come out with new products and they want to sell it. But how can they just sell it? So in academics, they want to do publications, do research. So it's very easy in at least American academics to say, hey, there's a new MRI machine, there's a new drug product. Let's see how that works on a certain disease, and let's publish on it. It's good for my curriculum vitae to get more publications. So that helps. And then the real world of United States medicine is fee for service. Outside of Kaiser Permanente, doctors get money by doing stuff, by doing surgeries, by making prescriptions, by doing everything. That's how doctors make money. So when I moved from California to Washington, D.C., I need a mortgage to buy a house. So I visited the banker. And the banker says, "Hey, Dr. Woolman, what do you think about this Obamacare, Affordable Care Act kind of thing?" I said, "Well, actually, I personally like it. I agree with it." He says, "Really? That's odd. Almost all the doctors I work with hate the Affordable Care Act." So I said, "Well, how do I explain this to a banker?" So, okay, let's say you get diagnosed with advanced cancer and you need to have a major surgery. The surgeon does a good job and cures you. For that surgery, the surgeon gets paid once. Okay. But let's say the surgeon does an incomplete job and has to operate on you twice. That surgeon gets paid twice. He starts thinking. I said, but let's say you were a member of Kaiser Permanente, where we focus on prevention and screening, and we catch your cancer early enough that you don't need a major operation at all. From your perspective, that surgeon doesn't get paid. But where would you rather get your care? And I forget that story because he stands up and says, "Excuse me, Dr. Woolman, I'll be right back. I have to talk to benefits at the bank to get Kaiser Permanente available to our employees." So, American healthcare economics. The average American family cannot afford the average American healthcare insurance premium. We can't tax our way to solve this problem. There simply aren't enough rich people, even in America, to get to that point where we're spending twice our GDP percent compared to everywhere else. And so the delivery system is going to have to change whether the doctors like it or not. So what are ways the delivery system can change? You can bend the curve, do reimbursement reform. You could charge the patients a lot more, dramatically. Or you could have the government says, that's it, for an MRI, this is all we're paying. And personally, as a physician, I think reimbursement reform is the way to go. So what do I mean about reinsurance? So Obamacare, Affordable Care Act came out, trying to do more population-based payment. The delivery model should be compensated on outcome. How well is the patient doing? Not just how much stuff are we doing for the patient. And I feel physicians need to lead that charge. Otherwise, business, the government, will do things that we don't like. With Obamacare, the Affordable Care Act, 30 million Americans in 2014 gained health insurance. There were regulations for you had to, even if you had a pre-existing condition, diabetes or cancer, the insurance company couldn't say, no, we're not going to give you insurance, all reasonable things. So then let's talk about Kaiser Permanente. About 80 years ago, there was a doctor, Dr. Sidney Garfield, who came to the Kaiser steel plant that was building battleships for World War II. And he was in charge of caring for the employees. However, the employees would get paid on a Friday. Friday night, they'd all spend all their money getting drunk and fighting, and they wouldn't have money to pay him to take care of them. So he said, tell you what, I'll charge all of you 5 cents a week, and whatever happens, I'll take care of you. They pay him in advance, and he realizes, it's better for me that the patients are prevented, they're not getting injured. So he went to the factory floor, found loose nails they were tripping on, hammered down the loose nails. And he realized it's not only in the patient's best interest, but in his best interest to have prepaid health care. So about us in the Mid-Atlantic, we are 1,700 physicians taking care of 800,000 patients in Washington, D.C., Maryland, and Virginia, a $5 billion a year company with 35 medical centers, 14 hospital partners, and 8,000 employees, nurses, pharmacy techs, imaging techs. How do we see value? Actually, so I'm a mathematics major, so I like the value equation. It's service and quality divided by cost. So anything we can do to increase service to our patients, increase quality of care, or decrease cost provides value to our patients and our members. So how did Obamacare, how did the Affordable Care Act work for us? So for the first few years when I came to DC, we focused on, again, service. We focused on quality. Right now we have the country's leading breast cancer screening rates, diabetic blood pressure control, high blood pressure control, and we had a stable patient population of about 500,000. The first year as Obamacare rolled out, patients could get insurance with us. We went up to 520,000, then 570,000, and again, now we're 800,000. And our issue is handling the growth of the patients, making sure the patients are getting what they're paying for. And we couldn't hire doctors fast enough, but we finally got to a great place to make sure the patients are getting the care that they need. Now, why does all of this matter? So actually, I had a very good lunch with the new European Union ambassador, Jovita Nelupienė. Of course, she happens to be a Lithuanian. And she asked me a question at lunch. She said, what's the next major advance in healthcare? And so that got me thinking, what have been the major advances in healthcare over the years? So if you look at American life expectancy, in 1820, sort of the baseline for human history, it's about 40 years old. Okay. By 1900, we had sanitation, clean water. That gained us another decade, almost to 50. In 1960, we had antibiotics. Again, people wouldn't die from a normal minor infection, and that got us to almost 6 years. Then by almost 2000, thanks to vaccines, we were preventing major illness, and that got us 20 years of life expectancy. But since 1998, what have been the major advances in healthcare? Maybe you can think of MRI, robotic surgery, amazing technical stuff, but all that got us an extra year of life expectancy in the United States. All of that technology, an extra year. So again, the question Ambassador asked me, what's the next major healthcare advance that can really push life expectancy to the next level? And finally, I came up with the answer, at least in my own mind, and that is integrated population health. Taking care of a population, not fee for service, but actually taking care of the population. And why do I say this? We actually looked at our patients in Kaiser Permanente and Mid-Atlantic states, and our patients live 6 years longer than patients in the community. Why? Simply because we're taking care of them all as a population. It's not fee for service, doing things because we can bill for it. It's doing the things for our patients. And not only that, turns out actually our underrepresented patients in America, our patients who are black, live 10 years longer because there's such a discrepancy in healthcare in the United States. So again, going back to the very beginning, if you, having a compact parking in front of a fire hydrant, that's just crazy. And what's the problem with a crazy system? Is that human nature is people will do crazy things. Here's a large van parked in this compact parking lot spot in front of the fire hydrant. So I'll leave it with that. Thank you very much for your attention. Ačiū, arigato, sheshieni, and thank you very much. Appreciate the time.
Thank you. Thank you very much. It's a very inspirational talk. So I think that the questions we will allow at the panel discussion, because all the speakers will sit here in front of you and you will be able just to ask the questions, and please do that. So now I would like to invite the next speaker, is Kwek Sui Chai. It's Chairman Medical Board from the National University Hospital in Singapore.
Thank you.
You're welcome.
Good morning, Minister, distinguished guests, friends from all over the world. Thank you very much for your kind invitation to Lithuania. Today I have been asked to talk about the challenges and how Singapore is trying to improve the healthcare for our citizens tomorrow. And I'm just going to start off by showing you a little picture. From Singapore to Lithuania is about 13 hours, but unfortunately there's no direct flight, so we have to lay over for about 4 hours and add on that to Frankfurt before we come here. But be that as it may, I'd like to introduce to many of you who may not have had the opportunity to visit us in Singapore, that we are a small city-state situated on the equator and with a land area of just about 750 square meters, but a population of about twice of yours at 5.7 million people. We have one of the longest life expectancies in the world, with an average of 83 years. But there's a challenge. We have an aging population, and today, about 1 in 6 Singaporeans is more than 65 years. And by 2030, which is barely 6 years from now, this is expected to increase to 1 in 4. Coupled with a declining fertility rate, this then becomes a double whammy. But thank goodness for a very low infant mortality rate and one of the lowest in the world of less than 2 per 1,000 live births. We see this, again, a picture of, I guess, Dr. Bruce's introduction in a slightly different manner. On the x-axis, you can see here that we have life expectancy in years, and on the y-axis is percentage healthcare spends in terms of GDP. And Singapore is on the lower right quadrant, which is a long life expectancy at a low GDP healthcare spend. Compare that with the United States and the United Kingdom on the top left-hand corner. And even in parts of Asia, they were doing pretty well. Again, the same slide, but superimposed on this are our concerns of burden of chronic diseases that will plague many aging Singaporeans. The problem of diabetes is one of major concern. We also have hypertension, hypercholesterolemia, and obesity as major concerns of the ministry. But we are able to have good health outcomes at low expenditure because of, I think, a few factors. First, our Ministry of Health in Singapore is always proactively thinking and worrying about healthcare challenges. We predict, plan, and implement changes to meet evolving healthcare needs. We also firmly believe that having a high-quality, skilled healthcare workforce is so important and critical to providing good health to our residents. So a long-term investment in quality healthcare workforce. And 3, promoting good health and delaying the onset of chronic diseases will go a long way to reducing the burden of healthcare. And finally, this is important because we need to have a good, prudent healthcare financing system in order for us to sustain these efforts. If you look at the way we do things in Singapore, our leadership and organizational structure, our Ministry of Health, very much like yours, would set the direction and goals, and it provides subsidy to the majority of the residents of Singapore. The acute care is being held by the public healthcare institutions in partnership with community partners, such as nursing homes, rehab facilities, and that we have a small group of private healthcare providers who will look after the perhaps top 10 to 15% of Singaporeans who are rich enough to be able to afford this. We are also very much invested in training and education because we firmly believe, again, reiterating the point that investment in healthcare team is so essential. So we are self-sufficient in providing for our medical students, dental students, nursing and pharmacy students. If you ask me what are 3 healthcare challenges that I would state up front here, that number 1 is the exponential rise in healthcare costs. Number 2, the need for a good, high-quality manpower and healthcare team to look after our residents. And the third, an aging population. First, I'd like to talk a little bit about the exponential rise in healthcare costs. And this is, we heard, due to an aging population, a longer lifespan, and the longer people live, the more chronic diseases they will have, the more comorbidities. And that inflation, not just about general inflation, which has gone through the roof in recent years, but also medical inflation. The cost of expensive technology, the cost of numerous advanced investigations, and also the price that we have to pay for exorbitant treatment. In driving the healthcare transformation, Ministry of Health in Singapore looks at 3 important areas. 1, and we heard also from Dr. Bruce, population health. How do we prevent disease? And the longer we can prevent disease and delay the onset of chronic diseases, the better would be this for the country. How do we preserve health and function? How do we get the primary care to ensure care continuity, coordination of care, and to provide a comprehensive suite of medical care to our residents? And when our residents require treatment in acute hospitals, how do we achieve that value-driven outcomes and achieve better outcomes whilst reducing the cost? So this is one picture that summarizes what I've been talking about. When a resident requires acute care, he comes to a hospital setting. We need to be efficient in the way we do things, reduce waste, avoid unnecessary treatments, investigations, medications, interventions, and then reduce the length of stay and move the patient out to the community in as short time as possible. We also need to have our community partners help look after our patients and keep them healthy, to reduce the need for them to go to hospital unnecessarily, to the emergency room, to the specialist outpatient clinics. And this cost avoidance, again, will help to reduce unnecessary spends. Over the years, we have dabbled with different payment models, and you can see here the fee-for-service. We heard about the perils of fee-for-service from Dr. Bruce earlier on. Pay for performance, bundled payment, and capitation. So the very many models means that there's no one model which is perfect, and each model has its advantages and disadvantages. In 2023, we settled on a capitation model where healthcare providers receive a preset amount for each resident enrolled over a specific time period, regardless of the actual number and nature of the services provided. Now, this is good insofar as it incentivizes preventative health by reducing costs and managing health and keeping individuals out of hospital. So we look at the ability for a capitation model to provide cost control to a certain degree, and especially to focus on prevention and in maintaining an efficient healthcare system. But there are, of course, also disadvantages in that providers may incur loss, and again, the amount of payment is dependent on volumes. In a technologically advanced setup as it is today, how do we maintain that cost effectiveness? So I think, again, 3 important principles: collaboration and looking at quality and affordability, focusing and enhancing quality and safety as the basic tenets of what we do in healthcare, prioritizing delivering value to ensure sustainability and affordability. Where there is a lot of medical technology coming up, we need to hope to harness the potential of medical technology to aid us in detecting conditions early. When we detect conditions early and we treat early, the outcomes are much better, and it's of course much cheaper than treating diseases and conditions in the very advanced stages. We need to also manage rising costs by ensuring that whatever we do and whichever technology we use is evidence-based. So to this end, the Ministry of Health in Singapore has set up an agency for care effectiveness to evaluate technology that comes in, and also to guide decisions based on clinical and cost effectiveness. And this is, again, very helpful to us working in hospitals. We may have very sexy tools coming on, exotic, for example, MRIs, expensive equipment, investigations, and so on and so forth. Which of these are evidence-based? Which of these provide that value for money? Manpower. We know that healthcare providers are a team which moves beyond doctors. So whilst we have a medical school, 2 medical schools, in fact, that train up to 500 doctors every year, that we are still needing nurses, allied health professionals, pharmacists, and so on. And we know what competition there is globally for nurses. We have seen the need grow, and just post-COVID, many of our nurses have been poached by other countries. And this, again, highlights a problem, that in a globally competitive world today, that people are free to move, and we need to be mindful of that and provide the best working environment for our healthcare workers. How do we optimize our manpower? The very, very precious manpower resource that we have. And here we look at 3 different areas. One is using technology and automation in order for us to increase productivity, and looking at job redesign and development to enable our healthcare providers to work at the top of the license. We need to upskill them, train them, and allow them to do meaningful and purposeful work. And this is what we have tried to do in many of the roles of nurses and also our allied health workers. We also want to get rid of stupid stuff and remove unnecessary work, to automate repetitive work, and to simplify time-consuming processes for us to work more efficiently and more meaningfully. So medical workforce transformation, as you can see here, is the drive for sustainability by optimizing manpower needs based on competencies and training a strong core for doctors, generalists, geriatricians because of an aging population, and palliative care specialists. We want to ensure that the career pathways of the people that work in healthcare are well looked after, not just doctors, but also other healthcare team members. And we want to provide that training and to allow for the development of the careers. If we help to look after them well, manage the workload, and also ensure a good work-life balance, this will go a long way to keeping our happy and satisfied healthcare providers in the local workforce. So we're hoping to look at this healthcare workforce of the future, work redesign, and I spoke about task reallocation, upskilling, so that people can practice at the top of the license, appropriate specialization, more apex positions to encourage people to allow them to climb the career ladder, and more opportunities for professional, personal, and leadership development. We want to make sure that we work well together as a multidisciplinary team with greater diversity to shift away from the previous physician-dominated teammates and interactions to providing an alternative workforce where non-professional staff can also be tasked to do some non-clinical work and relieve the burden of our healthcare team. In terms of process, we want to simplify. This is very, very important, and do away with redundant work processes and unnecessary complexity that frustrate many of our healthcare workers. In so doing, we hope to raise efficiency and increase productivity. Where technology is concerned, we want to leverage automation and technical solutions for tedious and repetitive manual work. We want to harness technology and AI to support and complement that human touch. And by default, it's digital. And this digital as default strategy is something that we hope to do in a hospital. Where system is concerned, we want to ensure that there are policies that prioritize staff well-being and to ensure that staffing numbers are appropriate for the workload. And here we're not talking about excessive. Appropriate is the key word, with training pipeline in progress. So what will all of these changes mean for a healthcare workforce of tomorrow? Job redesign to enable our staff to reach the full potential and to realize their aspirations. There will be greater autonomy for the team, leading to greater contribution of the work. In terms of processes, work is more manageable and, most importantly, more meaningful. Technology would help to reduce the tedious, repetitive manual work that frustrate many staff. And hopefully the system will have fewer obstacles, but more enablers to support our staff. What about our aging population, and what can we do in Singapore for this? Healthcare infrastructure, constructing more healthcare facilities and nursing homes, looking at elderly-friendly programs with initiatives to promote aging, active aging. We also need to continue to screen and detect diseases early so that we can treat them at a lower cost and with much better outcomes. Wellness programs so people live an active, healthy life in their golden years. And of course, we can't run away from that financial support with schemes to help the elderly access healthcare and long-term care. Many of the things that I've mentioned today may be relevant to what we're doing in Singapore, but I believe are also challenges and possible solutions for different healthcare systems in the world. When we talk about elderly care services, expansion of elderly care services and facilities, including home-based care, so now we put a lot of emphasis on home care, hospital at home, telehealth, telerehab, and so on, community care centers, and then end of life and aging. So when people live to a ripe old age, how do we help them age in a gracious way without pain? And I think that that's the key that we're trying to drive at. For the healthcare workforce, we would hope that there's going to be a larger and more specialized workforce to meet our increasing needs of tomorrow, including geriatric specialists, nurses, and caregivers. And then I talked about technology integration, hopefully with assisted living facilities for elderly, smart homes equipped with sensors, AI ensuring safety and well-being of our elderly, and then health promotion. Continued emphasis on health promotion for the elderly is just as important, and disease prevention to reduce that burden of chronic diseases and to reduce healthcare spends. So in the past, for example, when we looked at population health in 2023, there were many end-of-life patients who were being cared for in hospitals, but moving forward, we hope to transition care to the community, even at home, where patients can die at home if they prefer, and we send our medical teams to the home palliative care teams to reduce the pain and to help the families look after their dying loved ones at home. EOL care based on patient preference and moderated healthcare costs. And we feel that that's a good way of helping our citizens, our elderly patients, go in a very gracious fashion. There was limited healthcare capacity with fragmented community support in the past, and in moving forward, we hope to focus on integrating specialist care, growing community capabilities, and promoting resident-led health initiatives. So people help to look after their own friends in the community. An engaged, health-literate community is what we hope to aim at. And then we talked about how important the financial systems are and resourcing, obviously to revise resource gradients and update our financing models to begin and allow for that workforce transformation. So we want to enhance community care support. We want to have flexible funding and a workforce that is aligned with our changing new models of care. Healthier SG is Healthier Singapore, and in 2022, our Minister of Health, Mr. Ong Ye Kung, presented a white paper on Healthier Singapore. 3 basic tenets of this model. Keeping the population healthy by promoting healthy lifestyles. How do we exercise, even in the golden years, that appropriate level of fitness, exercise? How do we look after ourselves, reduce sugar intake, reduce salt intake, promote a healthy lifestyle? How do we enroll our citizens all with primary health care so that they can get the appropriate, timely screening, vaccination? And how do we anchor care in the community by reducing avoidable admissions, unnecessary emergency visits, unnecessary visits to the specialists, which are very costly? For that, we need to build the capability in the community doctors. And how do we deliver appropriate care? Again, reducing unnecessary investigations, consults, and treatment. You saw this equation. By the way, Dr. Bruce and I didn't pre-discuss what we're going to talk about, but I think that some points are good and we should talk about this. Value is quality over cost, and again, we want to put in the S bit of it, patient experience and appropriateness of care. What do I mean by appropriate care? Here we talked about reducing unnecessary tests, medications, and expensive technology that do not give better outcomes or do not change patient management. I think it's important here that we need to understand that I'm not saying that technology is bad and technology is expensive. We're talking about the appropriateness of use. So medications, investigations, expensive technology that don't change management, can we drop those? Streamline treatment protocols and processes to shorten waiting time and length of stay, to promote standardized and evidence-based best treatment. And a lot of times, physicians like to have their own preferences, but are their preferences evidence-based? Is it standardized? Is it consistent? When one patient goes from physician A to physician B, do they get the same standard of care? Here we talk about consistency and evidence-based standard of practice. Appropriate medications, not unnecessary medications, and we find that today sometimes many of our patients have a whole long list of medications that may confuse them, lead on to medication errors, and many of which are not even necessary. Reduce adverse events and complications, and this again, like I mentioned earlier on, is something that underpins all of good outcomes. Using some generic instead of branded medications, choice of implants to be evidence-based. There is a lot of medications, treatment modalities, and implants out there in the market. Again, we heard about how pharma and industry have a role to play in this, but we have to be mindful of appropriate use. Here I'm not talking about not utilizing state-of-art treatment and protocols, but the appropriateness of it. Allowing procedures and surgery that can be done in the outpatient day setting to be done so, and not to require admissions, and reducing unnecessary tests and long lengths of stay is something that we work hard to do. And navigating the current system in a technologically advanced period, we have telemedicine, Internet of Things, robotic surgery. Robotic surgery is not cheap, but in certain areas, it's very good, especially for deep-seated surgery. Medical records, again, it's not cheap. We just went on to Epic. It's very expensive. But how do we harness it to pay for it? I think that's important. Using AI and data analytics, again, we want to ensure that we use this appropriately to predict, for example, detect disease early and to treat and plan early. Again, treatment early means savings in terms of cost as well as increase in outcomes. Vaccination and public health tracking, and we've got to continue to do this for all ages. And in shaping the future of healthcare, 4 important components, looking at our workforce, innovation, that's the new buzzword today, evolving, changing models of care to keep up with changes over time, and system enablers. So again, in charting the future, we have, for example, expanded our telehealth services for video consultations, remote monitoring, e-prescriptions, tele-rehab, and so on and so forth, using AI in diagnostics, healthcare, Internet of Things growth, and then genomic medicine, personalized medicine. Remote health monitoring has caught up, and of course, promoting healthcare startups. This is an example of an enabler that we developed in-house, our app that allows patients to make all sorts of changes to their appointments, look at the medications, labs, pay the bills, receive instructions from the doctors, and so on and so forth. And so finally, in conclusion, that Singapore's healthcare system has matured over the years to deliver world-class care to our residents. We will continue to face challenges, no doubt, in the future, like many other healthcare systems will, among which escalating healthcare costs, a rapidly aging population, and manpower constraints continue to plague us. But to prepare for these, we will invest in our people, in our infrastructure, and our technology, and harness the potential appropriately. We want to set a whole new standard for healthcare leadership, aiming for excellence, and we want to navigate healthcare evolution by embracing the challenges and the opportunities ahead. It is important that we continue to focus on value-based outcomes, which you will hear from the next speaker very soon, in order for us to achieve better care at lower costs. We want to empower our healthcare team to adapt and to excel in an ever-changing environment. And we want to leverage technology to enhance the care delivery to our patients and to increase operational efficiency. We hope to prioritize preventative care with community-based initiatives. Future projections must encompass expansion of elderly care services in Singapore, an enhanced healthcare workforce, the integration of technology, and the promotion of health and wellness, whilst fostering a holistic approach to population health. And policy adjustments and funding mechanisms are so essential to sustain healthcare needs amidst today's rising costs and demands. Our proactive approach underscores our commitment to addressing these challenges whilst prioritizing both individual and collective initiatives in alignment with our principles of a healthier Singapore. Thank you very much for your kind attention.
Very elegant presentation. I really enjoyed while listening, and I really like this holistic approach to entire healthcare ecosystem. It's really nice. So our next speaker I would like to present is Diamond Murphy, and he is Chief Value Officer at the National University Hospital in Singapore. So
Thank you very much.
Thanks for coming.
Thank you. Thank you, Minister, Ambassador, colleagues, for inviting us today to talk to you about what we're doing in Singapore. We don't profess to have all the solutions, and we've only just begun our own journey in value-based healthcare, but we're quite happy to come and explain what we're doing so far and tell you how we have arrived at where we are. You might be wondering why an Irish orthopedic surgeon is telling you about Singapore. I have been working in Singapore for the past 17 years as an orthopedic surgeon, and then for my sins I was made Group Chief Value Officer to lead up this value-driven outcomes system of data collection and usage that I'll explain as we go along. So again, you'll see many slides repeated here between Bruce's and Prof. Quick's slides. Singapore, as you can, I'll stop moving maybe. So Singapore, little red dot in the South China Sea, 90 times smaller than Lithuania, okay? But there are certain comparisons. When we look at our population, is this to do with my... Certain comparisons between us. We have about double the population, as pointed out, as Lithuania. Do you want me to try reset again? There we go. Okay, we've doubled the population, but when we look at our actual, population, sorry.
Everything's good.
Okay, but every time I touch, it's not somewhere else. Okay. But when we look at the actual population. Nope. Sorry. I'll just get another connector. It's this one here. There we go. It's okay. Thanks. We'll try now. So our population is quite similar, okay? We have about 20% of our population is under the age of 20, and we have about 63% of Singapore population is between the ages of 20 and 65. And then we have something similar as an elderly population. And our median age is about 44 for Lithuania, it's 42.4 in Singapore. But that's relatively high for our region. Most of our neighbours have a younger median health. So, why are we talking about value-based healthcare in Singapore? Okay, and I'm going to explain what we're doing at a local level, what we're doing as regards measuring value and how we use data, a little bit about national level, and what are the next steps forward that we see in Singapore. So, from a Singaporean point of view, Singapore is well served from a medical point of view. We have 28 doctors, 78 nurses, and 5 dentists per every 10,000 population, okay? So we have lots of doctors, lots of nurses, lots of dentists, and the population, they pay about 30% out of pocket for their medical care, okay? Which isn't bad when we look at our regional neighbours. If you look at Singapore and the amount of infrastructure we have, we're relatively small island, but we currently have 13 general hospitals. And by 2030, we will have 15. And by 2035, we'll have rebuilt 2 of those 15. Okay, so all the time we're advancing. And Singapore is divided into essentially 3 healthcare groups. And NUHS essentially looks after 1.2 million of the population, which is on the western part of Singapore. But we have a central part and we have a southern part, which are also run by individual health clusters within Singapore. And Singapore has been shown to have very efficient healthcare system. When you look at the various different publications, they'll say Singapore is in the top 10 for healthcare efficiency and health outcomes. Maybe secondary only to Japan for longevity. But Singapore may be spending less per head of population than other countries to achieve the same life expectancy. So the question is, why should Singapore be worried? We've got lots of hospitals, we have lots of doctors, lots of nurses. Why should we be worried? Okay? Because we've looked around the world and we see what's coming. It's not a light at the end of the tunnel, it's a train heading at us. Okay? And our life expectancy is increasing exponentially. So our healthy life expectancy currently for men is 80.7 and for women is 85.2 years. But the healthy life expectancy is much less. So for men, our healthy life expectancy is about 6 years less than their life expectancy. And for women, it's nearly 9 years. And this is where a lot of healthcare spending is incurred, is in the final years of life. Okay? So the idea is to try and keep patients and our population as healthy as possible for as long as possible. We know with chronic, elderly population, we're more prone to chronic disease. And it's estimated that our chronic disease such as diabetes, heart attack, cancer, and stroke will all be increased by 2030. And patients who have any of these conditions, diabetes, running into the complications, so then they run into problems with eyesight, kidneys, vascular problems. That has a knock-on effect on the general population and on the families that then have to care for their loved ones. Same applies to heart attack. So you may have somebody who was previously of working age who now is incapacitated and can't return to work. Cancer, stroke has huge effects on the population, the rest of the family that may have to stop working in order to care for their loved one who is unable to work anymore. So it's not just the effect it has on the individual's care needs and the finances afforded to that individual for their medical care, but the knock-on effect it has on the population. As Prof. Kwek alluded to, Singapore's population is in decline, has been in decline since 1960s. The grey area in the centre, that was when we had a policy of no more than 2 children. But even at that stage, we were in decline. Currently, our fertility rate, I think, is dipped under 1. I think it's 0.9 last year. So it's the lowest it's ever been. So we have less people, I'm afraid to touch, less people. Can try again. Okay, so in about 2018, we flipped our population. So we have more people over the age of 65 than we have under the age of 15. And what this means is that we have less people who are working, who will be putting money into the national coffers that pays for MediSave, MediShield, and the finances for running our healthcare services. So by 2030, we'll have 2.6 people working for every patient over the age of 65. And this reduces down to 1.5 by 2050. This is how our health services are, by and large, they're paid for. The population, citizens and permanent residents pay into a fund every month, and then this fund is used then for medical services. So at the top you have government subsidies, so most of the population will be able to avail of subsidies. And then there's a basic health insurance that's also covered, which is the MediShield Life. MediSave is sort of their savings in a government account that they can also use part of to pay for their healthcare. And then it's like a safety net for patients who don't have enough. Then there's the MediFund that can be drawn on to pay for the difference for patients. But we've seen our projected healthcare costs increasing. So in red is the government health expenditure per year, and the blue is the total. So that includes the insurance company's portion. And you can see that there's almost a tripling of total health expenditure from 2018 to 2030. And that's both in the total healthcare expenditure and also in the expected government healthcare expenditure. And what we're trying to do is blunt that curve, okay? So we don't want it to be going up exponentially. And how do we go about doing that? So when I arrived in Singapore 17 years ago, I was told about the Holy Trinity of healthcare in Singapore. And Holy Trinity to me, St. Patrick and the Shamrock, I could understand. But in Singapore, the Holy Trinity is cheap, fast, and good. So healthcare, I was told you could have cheap, fast, and good, but you could only pick 2 of those 3 for healthcare. And we want to have a system that you can have the whole 3 all the time. And if you think of it cheap, that means cost, okay? So you want to have something that's at a reasonable cost, a sustainable cost. Good, that means quality, okay? And then fast, access to care, okay? That you can have an efficient system of care, okay? So even though they were talking about it 17 years ago, cheap, fast, and good, essentially they were giving the qualities of a value-based healthcare system, even though they may not have fully understood it at the time. So even though we have a good system, how do we maintain this system? So we have to plan ahead. We want to ensure that we maintain quality. We can't lose quality for the sake of cost containment or cost cutting. We look around the world at our friends and our neighbors to see what they're doing. We've gone to Europe, we've gone to America, we've gone to Japan to see what they've done, and we learn from them, and then we bring back a new word I learned recently, like, adaption, which is adopt and adapt. So we take ideas from other places and then we adapt it to our local system to try and make them work for us in Singapore. And that involves taking advantage of the tools such as technology that we have on hand, and the resources include the people that you have on hand. So in Singapore, in National University Health System, we have essentially built our own AI systems. We built our own value-driven care system. We haven't used from the, you might say, off-the-shelf systems that are available. And then the whole time we must remain patient-centric. There's no point in doing this, having this great system, and forget about who we're dealing with or who we're treating. The patient has to be at the center of everything that we're doing. So I'll just talk about the steps in the implementation that we've done, okay? You've already heard about Porter and the equation, the value equation, where value is determined then as the patient outcomes achieved per dollar spent. And we've all spoken about it. And it's important that when you're looking at quality, you're looking at the quality elements, which is the clinical elements plus the service elements. The patient voice must be part of this equation as well. And when you have a true value-based healthcare system, then it's of benefit to the 5 Ps: the patients, providers, payers, partners, and public. So patients, they will have lower costs and better outcomes, okay? For the providers, it means that the hospitals are happy because the patients are happy and they have achieved better care efficiencies. For the payers, which tends to be the government and insurance companies, they have stronger cost controls. They have better idea of what it's going to cost them year on year for this care. And they also have reduced risks because with improved quality, you should get decreased complication. Partners are industry and vendors. So if the partners are coming to us and saying, we offer this service or this drug or this new technology, but it's going to improve your patient care by X, then you're more liable to take it on board, as opposed to saying, well, it improves blood pressure by 2 milligrams of mercury or millimeters of mercury. And then the public. The public ultimately will benefit because this pushes the equation, the health equation, upstream. So you're getting population health, you're keeping the patient as healthy for as long as possible, so they benefit from having better health for a longer period of time. And then we have this whole strategy is based on having a system where you can pull data, so you have an enabling technology platform, and then you have these 5 pillars. And what I've been involved in the past 7 years is measuring outcomes and costs for the patients. And we learned this again from traveling abroad. So we actually went to Utah because they had publicized their system of value-driven care in JAMA. So our senior executives went over, met with Dr. Vivian Lee at the time. She kindly explained how they were operationalizing this system within their hospital's unit. And then a group came back and we set up our own value equation, taking on some projects to see whether we could apply the same ideas to NUH, National University Hospital. And again, looking at quality, patient experience, and patient-reported outcomes, so you have the patient voice, and looking at the cost to the patient, or cost to the hospital for the treatment of that particular patient. So what that involves then is deciding what you're going to look at, whether you're going to look within a single department at a single condition, defined cohort of patients. You can also look across departments at the same condition being treated by different departments, cross institutions, and then eventually across the nation and internationally. So this gives you a system of benchmarking to see, are you doing the right thing for the patients? And we can measure the clinical indicators, same in the clinical indicators across the country, and we look at clinical quality and safety, we look at appropriateness of care, and we look at the patient-reported outcomes and the patient experience. And once we have that and we look at the data, we can produce various different reports. So we produce reports for the individual doctors caring for the patients where they show how they are doing compared to their colleagues. We also are able to show the heads of department the year-on-year quality and cost trends. And then for the senior management, we can show how the hospitals are doing or benchmarking same condition from one hospital to another. And we do the analysis through Fishbone, behavioral insights, plan, do, act, check, act. And then we can come up with changes in the clinical pathway. So for total knee, we saw that our patients, we wanted 0 transfusion post-total knee. We saw too many of our patients were being transfused after a knee replacement. By doing this, we saw that they had low HB before their operation, so by improving their HB before operation, we reduced the rate of transfusion. By removing drains, by giving tranexamic acid. So changing the clinical pathway improves that. We saw that our level of DVT prophylaxis was not 100%, and we wanted it at 100%. And again, by educating the nurses just to show this must be done for every patient, again, we're able to drive that up. And then finally, our length of stay. We wanted patients to stay less than 5 days in the hospital. And that was a question of starting in the clinic and advising the patients that they would be in hospital for less than 5 days. You set the expectations, and that was done through education. Educating the staff in the clinic so everyone was on the same page when they spoke to the patient as regards the length of stay. We've gone from 5 days. I know in the States they go home the same day, but we're now at 3 days, we're pushing down to 2 days. So it's a graduated system, we're building up our community support, so eventually they can go home on the same day following total knee replacement. Okay, so, and this is how we have this continuous loop or improvement loop, where we change the clinical pathway and then we can measure what's happening, and then we report it back again to the clinician champions, to the doctors on the ground, and then we follow that around again in a circle. So it's a continuous system of improving the pathway. So how do we use the data? We don't use it in a punitive way, and that's the first thing we set out, is that we were not going to go around whacking people and saying, you're missing this KPI, therefore you're not going to get your bonus this year, etc., etc. So we did it more in an advisory capacity, that we would share this information everywhere. We share it with the heads of department, with the clinician champions, with the clinicians on the ground, and with senior management. And we do so in a way to encourage them to look at their own results and to change themselves rather than for us to tell them how to change. Essentially, it's done through peer pressure, because they look at their results, they look at what their colleagues are doing, and then they want to be better than them. Okay. So for the clinician champions head of department, we give them the results every half yearly, and it shows the performance at department or project or clinician level. And we can deep dive into the cost buckets to see exactly what's driving the cost for those things. So that we would give them various different Tableau dashboards, but this is one that shows, this is where we started the VDO project, and then you can see increase in quality and a decrease in cost. And then these bar graphs showing the various different cost buckets throughout the year. And then I say we can deep dive into those to look and see what exactly is driving the costs. And for the individual clinicians, we give these, as I say, individual reports. Initially, it was just done against the mean of their colleagues, but they wanted more information, because as soon as I gave them this report, they say, well, my patients are sicker than your patients. Okay, I look after the worst patients in the hospital, so that's why my results, my patients stay longer. So we broke it down, and we give them a breakdown of their patients by comorbidity. So the Charlson Comorbidity Index, we'll give it to them by the frailty score, we'll give them by the ASA score, so that they can have a look through theirs, and then they have a true reflection of their patient load compared to their colleague. And then we give them how they are ranking, or not ranking, but how they are doing compared to all their colleagues. So they will be told, as you can see, these ones, that they all have individual numbers. They're not told who the other numbers are. They say, this is you, and then you can see how you're comparing against the others, okay? And then we will meet with them and discuss these ones on an ad hoc basis. We also use it as a sandbox. So a sandbox where you can change your clinical pathway and see what results it's having. So this is one of our professors, Prof. Subar. He heads up our very low birth weight unit in NUH. And he's just pictured there with the, I suppose, the smallest baby. It was 7.5 ounces at birth on the day that that child was going home. But what he had done was he had gone through all the various different systems within his unit. How do they take blood? How do they give antibiotics, etc., etc. Looking at complications that they were having, such as line infection, things of that nature. And it changed the pathway. And then we were able to tell them relatively quickly what effect that was having. Was it having a decrease in its complication rates, which fortunately it did. So we can give that feedback, not quite real time, but in a relatively quick time, so as to see the effect of what they're doing and make sure that it's having a welcome effect on the patient's care. Upstream, we briefed the chief executives, CEOs, CMBs, CFOs, directors of operations. We do that on a quarterly basis, and for the HODs, group chiefs, half yearly. And this is the sort of thing we show them. So as you go to the right on the x-axis, you're improving quality. As you go up on the y-axis, you're decreasing costs. So you want to be on the top left quadrant, or as you're looking at, sorry, top right quadrant, you want to avoid the bottom left quadrant, okay? So this is doing well on the top right, and you can chart these projects or conditions on a yearly, monthly, whatever basis you want to see the trend that's occurring and try and intervene early if you see that the quality is decreasing for whatever reason. Being in the bottom right quadrant is not so bad because, okay, cost is going up, quality is also going up. So this may be that you've introduced some new technology, some new system, new method of treatment. So the cost has gone up for it, but if provided that you're getting good quality for it, it's also acceptable. And then, as I say, we can benchmark between hospitals and between conditions. And we can look at see where we should have right sizing of care. So if one hospital has got superb quality, but is doing that operation or looking after those patients for thousands of dollars less, then maybe that's where those patients should be going for that procedure, okay? As opposed to having every hospital doing the same thing at different costs. What's been the effect of introducing this system? Well, we have over 74 projects, I'd say probably close to 80 projects now over the past 7 years. We cover about 30% of the total costs, or 30% of the total costs and 25% of the caseload for the hospitals through this system. We've seen about a 12% improvement in clinical quality overall, and then we also have about a 10 million Singapore dollars in total cost avoidance, not cost savings. The people who are saving money in this system up to date has been the insurance companies and the government. The hospitals aren't saving money by doing this. They're avoiding cost by doing this. And we've progressed from looking at, you might say, relatively simple, straightforward projects to having multiple episodes within a hospital, expanding across our entire regional health system, looking at primary care, so we have diabetes, hypertension, hyperlipidemia that we're looking at, and ultimately we're looking at things like diabetes. So using the data that we now have, we can actually track our diabetics, not in some sort of Orwellian way, but what we can do is we can see how many diabetics are within our region, how many are we treating, when's the last time we saw them, when's the last time they had their screening done or their HbA1c done. And if they haven't had their HbA1c done in the past 6 months, we can send them a reminder, it's time to get it done. So trying to prevent patients from going from one level of disease to a more chronic or more disabling level of disease. As we know, we can see that our diabetic patients, their mean stay in hospital during the year was 11 days. The mortality rate is 15%. And from a diabetic-related cost burden to this is just to NUHS, we can see it's 838 in 2021 and it was 915 million in 2022. So this is something sizable that we're looking at. As Prof also mentioned, we're looking at things like end of life, but I'll speak about that very shortly. So this is the idea, is that we can intervene early, whether it's through screening or through increased surveillance, monitoring, that we can prevent patients going from mild to severe forms of the disease. Ministry of Health, we had established this in NUH. We then presented it to the Ministry, and Ministry took it on board about a year later, and then they have actually pushed it across the nation to about 17 projects. But each of the individual clusters, as I say, the other 2 clusters, are already doing their own projects on top of the Ministry projects, because it's the first time people are looking at the data, looking at the costs and putting the 2 of them together to look at the value that they're giving to patients. The Ministry supplies the same sort of demographic information as we do. And again, they've shown improvements in readmission rates and reduced readmission rate within 30 days of discharge. And again, they've improved the balloon to a door-to-balloon time for both stroke and heart attack since this came on board. As Prof. Craig alluded to, the Ministry has introduced a number of different policies. The first one in 2016, the 3 Beyonds. So you can see move beyond hospital to community. So we're pushing the value-based healthcare agenda. Move beyond quality to value. So it's not just access to care, it was producing quality of care. And move beyond healthcare to health. So no longer, he was the Minister of Health, he wasn't the Minister of Healthcare. So he wants us to be more proactive in managing our own health. And then we had the Healthier SG. Of note, in the Healthier SG, they had an increase in network in elder care centres for seniors. And the reason behind this is that we know that one of the big costs in healthcare is dementia in elderly patients. And this can be attributed to elderly patients in isolation. And they're a deadly combination if you, when you're looking at dementia. By having patients go to elder care centres on a daily or twice every other day basis, then they are involved in healthy aging. They're with other people. It reduces the onset of dementia. So for quite a simple sort of system, you can have a great effect on the overall care of our elderly patients. Capitation has come into play this year. So each of the clusters is given money to treat the subsidized patients based on the number of people living in that region. And then it's up to the cluster to distribute that money appropriately throughout the system. Next steps for us is appropriate care. So it's going to be appropriate value-based healthcare. Okay? So the same thing, the system goals, healthy population, right care and quality, sustainable cost. We want to improve the outcomes without raising costs, or lowering costs without compromising outcomes, or improving outcomes commensurate with the costs. So we're looking at all the time, this is a quality improvement or maintenance system. It's not a cost containment system. And it does it through regulation, resource planning, performance management, information technology and professional standards. So my role really is in the performance management, which is measuring health outcomes and costs to drive improvements in the areas in line with the national policies. And we do that. This is similar to what we have in mind in NUHS. So appropriate care, we want to reduce unnecessary interventions, so which are investigations, consultations, treatment, and we focus on tertiary prevention and reduce consequences of disease complications. So things like reducing length of stay, reducing unnecessary medications, reducing unnecessary tests. Not every diabetic needs to get a point of care glucose test 3 times a day. Okay, so we're reducing tests that are not required for patients or for all patients at the hospital, and trying to give them what's appropriate. For end-of-life deprescribing, this is patients that who have been, they're in palliative care. Do they need to be on their statins? Do they need to be on their bisphosphonates? Do they need to be on calcium and so forth that they've been on for years? So all these things can be reduced. The same as regards some of their cancer treatments. They were being given large quantities of medications on discharge, and these essentially were wasted when the patient would pass on or would die. And they would then bring all these drugs back to us that we cannot use and we must dispose of. So can we introduce a system where the patients have their medications but don't get them in bulk, so that we can reduce the amount of wastage, you might say, in the system? Finally, I suppose we're going to be talking about bundled payments. This is going to come in. This is where for elective procedures we will have a fixed amount. So this will deal with something like what Bruce was talking about, whereby if you go to have a procedure or something done, you pay X amount. If there is, unfortunately, a complication, you don't pay anything else. The hospital must bear the brunt of that. So the cost will be the cost for the full cycle of care for that patient, including any untoward complications or additional treatments that they may require. It's worked in other countries. The main concern with this is that it may lead to cherry picking. So in other countries, what they've done is that they say if your ASA is 1 or 2, then you would be part of a bundle payment. But if it's higher, then you may need to be fee for service. Okay. So in summary then, what we're all aiming for is to improve the quality of health and sustainable healthcare within our nations. At the same time, we want to maintain or reduce the cost of that care to make it sustainable for both the individual and for the nation. And I'd like to thank my team. I have about 2 more. We have about 10 people in total that run this system for NUHS. Thank you.
What a great presentation, and indeed I think when we have all the data available, so it's much more easy to to take all these data-driven decisions. All right, so the last speaker I would like to invite here is Director General of Vilnius University Hospital, Santaros Klinikos, Professor Tomas Jovaiša.
Thank you. A bit tricky to talk after the previous speakers, but I'll try to probably fill in a few more details that might be relevant or interesting for us. Maybe even give a recipe for Lithuania, or at least something to think about. So as a healthcare manager, probably the two things that we get asked all the time is, can we improve the outcomes, and can we improve the access to our services? That's, if I would rank the questions, these are the two that I'm asked all the time. And talking of which, you know, I just picked up cancer as an example. We can look at the sort of last 40 years, and these graphs represent our neighbors here: Latvia, Estonia, Poland, and sort of slightly further away neighbor of Germany. And as you can see, cancer death rates are going everywhere up, and we know that cancer is generally the disease of the elderly. So we've talked already a lot about the aging society. So one would say, well, that is expected, especially when we know that the majority of the cancer deaths come in the elderly population. Having said that, so the larger graph is Lithuania, the lower one is European averages. One can note that our death rates in the 50 to 69 population is slightly higher. So what we can do when we combine the two graphs, when we know how our demographics looked like back in the 1980s, 40 years ago, and what it looked like now, we can do some age adjustment, and maybe that will give us a better answer. Are we winning the battle with cancer, or are we on the way there, or whether it's the other way around? So when we look at the age-standardized cancer death rates, it's very clear that, for example, Germans did really well in the last 40 years, more than 20% reduction in age-standardized cancer death rate. Pretty much everyone else did quite okay, but us. So the age-standardized death rate in Lithuania is still higher than it was back in the 80s. So somehow we have not dealt with that question as well as our neighbors or European averages. And as most of the healthcare managers in Lithuania are doctors by trade, thought that we should probably ask ourselves what we're very used to read clinical trials. We know that if we prescribe a drug, that is likely to improve the outcome. But what can clinical trials teach us about management? And I just picked up a few random examples, nothing specific about these trials, but just to think about the CRASH-2 trial. Tranexamic acid, basically, we give a drug to a trauma patient, and if we give that drug, the patients bleed less and they're likely to survive better. International multi-center trial, positive outcome, definitely patients do better if we give them the drug. But when we look at the actual outcomes in each of the participating centers, we will see that with the same drug being administered, the actual odds of dying can vary several-fold. So the best centers, somewhere down in the bottom, the odds ratio of death is very, very low. It's less than 1, which means that if you had a trauma and you won in those centers, even without the drug, you'll probably do better than with the drug in some of the centers that are there at the top. And if we look through many other studies, we may start finding exactly the same pattern. So, for example, a USO study that looked at the emergency surgery outcomes in European Union countries, there is clearly a significant variance. And the variance does not depend on the GDP, on the healthcare spend, because you can see that, for example, Estonia, which has got pretty much the same GDP as us and very similar healthcare system, is up there near the Iceland and Finland with the top performers, and Latvia, which is another neighbor of ours, with exactly the same GDP and exactly the same similar healthcare system, is at the very bottom, whereas we are somewhere in the middle. So there's something more than just the money and just the drugs and just the sort of the clinical evidence that drives the outcome. We also have an array of negative clinical trials. So the trials where we tried some drugs and the trial told us the drug doesn't work. So there are a couple of trials, one in severe lung injury, the other one in delirium, and the drugs didn't work. But the patients in those trials had better outcomes than the cohorts before. And that was simply because there was some sort of standardized care, standardized assessments that were used. So the way we run our systems looks like they may have as important effect on the patient outcome as actually what we do. And what's fascinating from the previous talk, that if we are serious about addressing the system, is very, very complex. So just looking at the averages of the country doesn't really tell you anything of what we should be doing to improve it. So I'm intensivist by trade, so hence the intensive care example here. Outcomes in the most severely ill patients. As already been mentioned, if my patients die more often, that's because they are sicker. So, the 22% mortality rate, is that good, bad, neutral? So we do need to standardize. So there are methodologies where we can assess the severity of the critical illness, and then we can standardize that, and then we can say that we know we're not comparing apples and pears, we are comparing apples, and the better, the tastier, and what have you. So if we look at the Netherlands, so this graph represents a standardized mortality ratio. So if the ratio is higher than 1, that means there is a higher risk of dying in that unit than what would be expected by the prediction model. And if the standardized mortality ratio is less than 1, then the outcomes are better than predicted. So the ones who are, the units, each dot is intensive care unit in Netherlands. And basically, if your outcome is below 1, you're doing well. If your end result is above 1, you're not doing so well. And as you can see, the scatter is quite high. And we're not just talking about 5 or 10% difference. The scatter is between 0.5 to 1.5. So there's from the line of 1, there's a 50% variance in risk of death. So if we're talking about, let's say, an average risk of dying in intensive care of about 20%, that means the variance is up and down 50% from that. So it's a huge difference. And in Netherlands, one would expect, one of the biggest economies in European Union, money is not a problem, staff is not a problem, and facilities and treatment options aren't a problem. So if we look at the United Kingdom, we see exactly the same picture, surprisingly. Maybe a slightly narrower band of scatter, but the risk-adjusted hospital mortality for ICU patients as well. And I'm really grateful to our colleagues in the National Healthcare Fund, because we embarked on a similar project there, and this is a very, very, very first sort of trial data from us, and you can see that obviously we're a small country, we have fewer intensive care units, but we are no different. Yeah, we do get exactly the same result with pretty much the same type of scatter of our results. So simply by doing this, we're already doing something. We are aware of the challenges, and when we look at the international data, simply by measuring this and by making this data public, that standard SMR tends to go down on the time. So as a system, we are getting better. However, the scatter is still there, and that's a worry. In my previous life, I had an opportunity for some years to lead the peer review program for the North East and North Central London for the critical care network, and I had a unique opportunity to visit and assess every single intensive care in the region, covering probably about 5 or so million people. And we would spend a day or 2 days in each of the ICUs evaluating the processes, the staffing levels, doing a lot of homework on the data available on the outcomes, and also surveying the colleagues on how they see the colleagues inside of intensive care units and outside of the intensive care units, on how they see the function of that unit. And we produced quite a few reports, quite a few detailed reports, including the 360s, on what worked well and what worked not so well in those units. And But one of the most interesting insights is that there was no obvious link between staffing levels, funding, availability of support services like such as physiotherapy, rehab, and so on and so forth, and standardized mortality ratio. Obviously, there was some minimal standard there, and there was some maximum. So, it doesn't mean that the resource doesn't matter at all, but resource was not a decisive thing. You could not say that this unit, which is the best staffed unit, produces the best result in the region. And then we're talking about a fairly small region, so the standards of care are fairly similar. And this observation is not unique. Nearly, 15 years ago, Rowan et al. Published data from a survey on 275 intensive care units worldwide. This is a slightly more complex graph, but it resembles a lot of what was presented already. So in this case, the SMR, the standardized mortality ratio, is the one line in the middle, a vertical line. So all the units that are to your left of that in the quadrant A, they have mortality less than 1, which means they are providing a very good care. And the units that are to the right of that line, where the quadrants C and D are, they're performing not so well. Their mortality is higher than predicted. But what's most interesting is the horizontal line, the horizontal one, which with the abbreviation SRU, which is the standardized resource utilization. So they calculated based on the staffing levels, on the purchasing power, on the purchasing power parity, or how much you would spend on treating these patients. So any unit which is below the horizontal line would spend less, and any unit that would be above the horizontal line would spend more. So as you can see, some units actually do produce very good result with a reasonable expense. But there's a huge number of intensive care units worldwide that produce fairly limited results but spend a lot of money on that. And obviously, as a manager, you would say, fine, fair enough. You just, guys, off you go there, visit the units in the quadrant A and do exactly as they do. We did a bit of that, so I think that we're quite happy to have, I think, a fairly advanced automated quality monitoring system, and some of the guys who delivered that are here in the audience. So quality monitoring system now in Vilnius University Hospital. And we can already measure some effects of that. For example, readmission rates to intensive care reduced by 50% over the last 2 years. But that's not all. When we talk about the complexities that Dr. Murphy presented, everyone just goes, oh my God, how do we implement that? All of those graphs, all of those analytics. Can we have something that is a lot more simpler? And that's where the danger is. And I would like to give you another example that is from United Kingdom on a 4-hour accident and emergency department target. So back in 2004, politicians said enough. Patients wait for too long. Their patients are not happy. They wait for very long times in emergency departments. We need to fix that. So we give everyone a target of 4 hours. So every patient needs to go in, be treated, discharged from A&E, or admitted into the hospital within 4 hours, full stop. And we give you a 98% target to achieve. Not only the target, we're also going to give you money. So over a 10-year period, there was 25% increase in healthcare spend in UK. So that's nearly double of what there was an increase in GDP over the same period of time. But they've spent 50%. There was a 50% increase in funding for emergency use. That delivered 80% more emergency medicine doctors, more emergency medicine trainees, and they actually even created a wholly new subspecialty of internal medicine, which is called the acute internal medicine, to help drive the emergency targets better. As you can see in the graph on your right, at the bottom, the blue lines is the number of doctors in acute internal medicine. And starting in 2011, there wasn't a single one. So a brand new specialty just to deliver the target. So one would think that with such an investment, with such a growth in the workforce, we will do better. Somehow we will get a better result, but actually everything is to the contrary. So while the target was 98% in 2004. The next target was lowered down to 95% in 2010. It was further lowered down to, if I remember correctly, 90% in 2018, and the interim target currently is 76%. And as you can see in the graph on the right, it's not that a few hospitals aren't doing well and driving everyone down. It's actually every single hospital is doing worse. And not only the 4-hour early period, actually what's been unheard of in the past is the 12-hour wait in emergency departments. So the number of patients that would wait for more than 12 hours to get the treatments or get the onward care. So the problem seems to be like a Gordian knot, unresolvable. And what is interesting on the graph on the right, the very top is the annual growth in attendances, which is just over 1%. So you cannot explain the deterioration in the performance by the number of patients that are attending EDs. What is interesting in the blues and the reds, that actually there's a lot more resource to deliver care. But what happens when you put doctors and nurses and resource in place, they start doing stuff, whether that's necessary or not, and that's where we are going back to the value-based healthcare. Does it really produce the result that we need? So we have more doctors, we have more nurses, more cubicles, and we do a lot more investigations, and we do a lot more treatments, but still everything seems to be falling apart. And the interesting bit is that this Gordian knot, it cannot be untied because the problem is not in emergency department. So whatever we do in those emergency departments ain't going to work because we have other two big issues. So one of those is the primary care, and the other one of those is the social care of the rapidly aging society. So in the primary care, if there is not enough access to it, patients would, or population would go to emergency department. And also there's another very interesting bit, and that's example of my daughters who are in their sort of early 30s now. They use online GP. Online general practitioner. Because that is how the current generation see it. Majority of patients would not be happy to just go to see the general practitioner after 2 weeks and get a generic advice on something, and then maybe an investigation, blood test 2 weeks later, and another investigation, another 2 weeks later, and then a decision a month later. So it doesn't work like that. Everyone expects it in one-stop shop, hence ED seems to be the answer to that problem. And the other bit is the exponential increase in social care needs, and that's where we also, as any other society, need to think very seriously about it, because, and as an example, in the UK, at any point in time, about 20% of hospital beds are filled with patients whose treatment has finished. They don't need to be in the hospital, but they have nowhere to go. And unless we here in Lithuania plan for this and address this, we will be in a very similar situation. So in sort of an interim summary is that patient and system outcomes, I believe, they depend as much on the way we run our hospitals and we run our system as it does on the actual treatments and interventions. And we have not invested enough yet into understanding how our management decisions influence this. So really, once again, referring to the previous presentations, there's no simple way of answering these questions. Healthcare is definitely the most complex system in our societies. Whichever way, if we take education, if we take social care, it's way simpler than healthcare. Everyone was very excited about the process mapping 10 years ago, and everyone stopped doing it because it just makes no more sense in healthcare. Simple sort of policy targets, oversimplified policy targets, they're likely to do more harm. And if we are serious about improving it, there are no two ways about it. It's a complex system. Complex decisions, and if we want a data-driven decisions for the value-based healthcare, we need very complex data analytics. And I believe here in Lithuania we have a unique opportunity because we are small, and what we have now is we have a very progressive legislation on secondary use of healthcare data. I think we need to be ambitious enough to say that we're going to be the first in the world that can deliver this on an automated daily basis. But by being a small country, we have a feasibility of a single centralized data analysis point, which we already have as state data agency. We have an ability to integrate the multi-source data. So, mortality, employment, needs for social care, new diagnoses, new drugs that are related or non-related to the previous treatment. So if we already have all the ingredients for a truly learning healthcare system. The scheme, we can draw a lot of schemes, but the general idea is that, for any hospital admission or any outpatient admission or health cluster episode, we can combine that data at an individual patient level with things like, did this person work before the index episode? Did they go back to work after it? A half a year later, maybe a year later? Did they pay the same amount of tax a year later as they did in the past? So we don't need to phone the patient and ask how they're doing, or are they back to work? We know that already by combining all this data. So we can assess their, even though a surrogate, but we can assess the quality of life, the health status, or as simple things as whether they are alive 12 months later. And that can be fed back to decision makers at every level. To the head of the department to decide, a personalized care for each individual patient. Well, would these modalities work for my patients or not? And that can inform the decisions at the very top, at the ministry, at the government, on what we're going to fund, which systems we're going to fund, and how we want to run those systems. So this theory that the best examples that we heard from other countries, and the theories that we read about, I think we are now in Lithuania, we have all the ingredients to make that theory a reality, to have a truly learning healthcare system by measuring everything, every bit that we do, by analyzing that, by informing our new decisions, and then measuring again on what we do, and just live in that continuous cycle of improvement. So thank you very much.
So many thanks. Finally, we're coming to the end of the first session. You all did well and deserve some break. So be prepared for the discussion after the coffee break, and please list your questions and you will be available to ask it. And so really encouraged to discuss. So by a break, coffee break for half an hour. So we're coming back in 11:45. Thank you.
Tas meu.
Right. Hope you hear me all right. So, welcome again to the second session, and this time around, no presentations and a lot of discussion, I hope. A part of the audience now moved on to the stage. It looks a bit emptier in the room. You already met the speakers, and you've already met Dr. Šimaitis in the earlier presentation. And for those who don't know, I present a gentleman sitting in the middle, Gytis Benders. He's relatively new head of our National Health Insurance Fund, so I'm really grateful for you taking part here in this discussion. And to open the debate, I have a question to the US and Singaporean colleagues. Here in Lithuania, we still base our healthcare funding on the DRG. So we are pretty much still on the fee-for-service scheme, whereas it looks like both in US, at least in the Kaiser Permanente scheme, and in Singapore, you've tried another 3 different systems beyond that and settling on something completely different. So could you comment on your views on why we need, or do we need to move away from the fee-for-service? Why, and what are the pitfalls in trying to make those steps?
Well, some years ago, we did have fee-for-service, but we think that fee-for-service sometimes incentivizes perverse behavior. And I think that Dr. Bruce already mentioned why this is so. The more you do, the more you get. So even if it's unnecessary, if it's avoidable, you might want to do it for the wrong reasons. And therefore, we moved out of the fee-for-service. But we need to also understand that there are some components of each payment model that might be useful. And fee-for-service looks into the different levels of a procedure or surgery. And from that standpoint, it does distinguish between the levels of complexity as well. I think that there's no one perfect model. And for the model to be good, it has got to be adapted to each healthcare system. And I don't know whether you might agree that there are other models like the bundled payment, the capitation, and all of these address behavior, and how healthcare systems might react to it is something that we need to be very mindful of.
Yeah, I agree 100%. I'm a big fan of human nature. And so human nature, you know, if what will put more money in a doctor's pocket, that doctor will do. And so the best example I have for that is I oversee radiation oncology. And a common disease, breast cancer, the standard number of treatments a woman will go in for radiation oncology is maybe 35, 40 treatments. So she's taking 35, 40 days off of work, she's going in. But it turns out that there's data, objective data, that says the outcomes for breast cancer can be the same if you give different dosing, but 12 to 14 treatments versus 35. But nobody on the outside is giving 12 to 14 treatments. You know, I always joke because they have boat payments they need to make. The radiation oncologists have a boat on loan that they want to fund. But we in Kaiser Permanente, you know, it's better for the patients to only come in 12, 14 times. It's better for, if the outcomes are exactly the same, to have a salary or a capitation. I'm a big fan of what's best for the patient should be what's best for the doctor. And in general, for us, that's the case.
Thanks, Lawton. Would anyone else have any comments?
So we've started on capitation, but we've only just started on our capitation route. So it'll take a few years for us to establish how that's working. Capitation is not for all the patients. Capitation is, again, depending on what the quantity or quality of care that you're requiring. So transplant patients won't be capitated. Trauma patients won't be capitated. So within capitation, there's going to be distinguishing features for that. The capitation is still based on what we were being subvented before. That was based on DRG codes. But from when we're looking at the cost from the quality and cost point of view, DRG is quite a big bundle of conditions that are lumped together under a single code. So when you're looking at variation in DRG, you may be just looking at variation of treatment for the various different conditions that are within that DRG code. And there's other systems, as we would say, that whether ICD-10 codes or whether surgical procedure codes might be better suited for value-based healthcare purposes to differentiate the cost portion of those conditions.
I have a follow-on question in regards to capitation and in regards to member, which is in a way membership fee in Kaiser Permanente. How do you decide the amount you allocate in these schemes? Because fee for service in a way is quite clear. You know, you calculate the costs and etc. But usually the governments, they put the cap on the total amount they will pay the institution. But how do you decide what is the capitation value or the how much you pay for capitation and membership fee in Kaiser Permanente case?
Yeah, that's the tricky part. And I think in terms of how much the physicians get paid, we have a good sense of out in the community how much does a radiation oncology on average make, or a surgeon or a pediatrician. And so we're able to keep our salaries competitive by doing a market analysis. In terms of how much do we charge the government or to take care of a patient population, quite frankly, it's interesting. So Kaiser Permanente is actually two different organizations. One is Permanente, the physician side, but completely different is the Kaiser, the insurance side. And I'm fortunate in that, at least on the physician side, I don't have much oversight on the insurance side. So I think it's actuarial. There's a lot of complex math that go into how much they're charging. And that's an art probably as much as a science. And I wish I had a better answer, but that's the reality of it.
And just a comment to the audience, but please free to ask questions at any point in time. This is a discussion. It's not just discussion here on the panel, it's discussion with the audience. So any moment you have a question, just raise the hand and go for it. Just follow-up question, because, well, we're talking a lot about money, because money buys people, people provide services, and then, so it does go around the money. But the question then is productivity. So it's a very simplistic in pay or fee for service. You do something, you get paid. The more you do, the more you get paid, and it's a very clear incentive for productivity. So if the system moves away from that, we still need those services. We still need knee replacements, and we still need all of that done. And if we want to keep the cost low, we need efficient service. So we still want the surgeons to perform more and more operations in a shorter period of time, in a fewer days, in a week. So how can that be achieved? Because that seems to be a very sort of opposing philosophies.
Well, I think a good example is sharing the data openly. And there's a good example. Let's say a knee replacement surgery. If one doctor is doing, making the number up, 5 knee replacements in a day, and another doctor is doing 6, you sort of want to open that data up and say, how come your colleague is able to do more knee surgeries in a day than you? And it's not punitive. It's a learning opportunity. And I think that's by opening up the data, by making things transparent, I think most doctors are competitive, as a systems, you want to utilize that competition to maximize patient care.
We do look at peer pressure to a certain extent in trying to raise productivity. So if physician A or surgeon A can do so much, we would expect, of course there are outliers that do a lot more and there are few that don't do as many, but we would expect that a possible median is this many. And then people who do a lot more probably would get a better bonus if the outcomes are equally good. And I think that this may be a possible way to go. Productivity is relative. And I feel that it's not easy, but it's also not impossible to come up with some form of a gauge or recommendation as to how many per session. And then we base on that bit of it.
So you still work on some financial incentives for the healthcare professionals.
Well, yes and no.
That
yes.
looks quite a dangerous path a little bit. And we used to incentivize a lot of things through health insurance fund, but it looks like the pride of your profession and this comparison with peers works even better than a few dollars more.
So for example, if, let's say, and we take the example of a radiologist, if one radiologist can read 10 MRIs in a session, and then there's another radiologist that reads only 2, then obviously there is a bit of a problem. If the average median is about 10. I'm just highlighting that as an example. At the end of the day, we also need to look at performance appraisal. And what does performance appraisal comprise? It's not just, of course, about the quantity of the work that's produced, but also the quality of the work that's produced. And if the quality is comparable, then the person who does more needs to be recognized.
So within Singapore, we've just gone from a fee-for-service system to this, say, new capitation system. But we do have a system of performance-based bonus. So that's at a national level. So that also can be applied at the institutional levels. If you have set KPIs or you've set certain targets for quality and you hit those quality targets, then you will get an additional bonus to your regular sort of remuneration. So things like that can be built in. That's been done in other countries. Sweden, I think, has done one where if you take a contract for doing total knees, then they kept about 3% of the contract, which they would pay if you hit your targets. And they found that the quality of the care improved tremendously, but also the cost of the care was also decreased within that system. And that was one of the systems that segregated the patients and saying SA 1 and 2 will be part of this system, and anything else then would be a fee-for-service system.
I think that's a great point, is the quality. You want to make sure you're incentivizing what's best for patient outcomes. So for instance, like for bonus, we can incentivize a primary care physician. We know what percentage of their patients have their diabetic blood sugar under control, or what percentage of the women get their mammogram screening. And so you can incentivize that in terms of a small bonus at the end of the year. And every doctor will say, well, my patients are different. But as long as you can compare, like we say, apples to apples, you can, a patient, one provider who has a better mammogram screening rate compared to their colleague down the hall, you could say, Dr. X, why don't you talk to Dr. Y and learn how they do it for a similar patient population for, anything of objective high quality.
So setting targets is an important part of appraisal, and every year we would do this with every staff member. Setting targets not just in terms of quantity, but also the quality outcomes.
And that's, I guess, one of the most interesting questions. 'Cause, it's very easy to incentivize quantity. It's very easy to measure. Which quality indicators do you use, for example, as the national bonus scheme or a local hospital bonus scheme? Quantity is fine. Whether you could give some particular examples
Also,
in
it
a
depends
specialty.
on the specialty based.
Yeah. So, any examples of how quality is integrated into?
So currently, okay, so far most of them have been done at a national level. And because we were only transitioning now to this new form of financing. So again, a lot of the incentivization was still fee-for-service within the institutions. But at the national level, they bring in things like hip fracture. Hip fractures patients should be operated on within 48 hours. So there'll be certain national guidelines such as that would be, the onus then would be on the hospital to ensure that this was happening for the patients. And they would have a gamut of indicators right across all the various medical specialties, including MRSA rates, things like that, that you have reduced MRSA rates, improved hand hygiene, things of that nature. All that would be taken into consideration for the national pay for performance system.
So for example, a surgeon will be surgical complications, surgical site infections, surgical readmissions. Yeah. All of these could be examples.
Professor Quick, in your presentation, sorry, maybe somebody else.
Professor Thomas Poškus. Well, I'll be the runner then.
Sorry, I just wanted to, as a surgeon, I wanted to ask a question on, it was mentioned cherry picking in surgery, and in Lithuania we have a big problem of internal competition between government and private hospitals, and private hospitals take elective cases, they're better cases, they're financed to the same level as government hospitals, but when difficult patients come up, ASA 3 or more, they are sent to university. What is the practice to even that out, and maybe some inputs into that?
That is an excellent point. So for us, for example, in the private sector, the doctors would take care of the more common run-of-the-mill type cases, and then the complicated cases will be channeled into the tertiary hospitals, the public tertiary hospitals, because the team is bigger, it's more sophisticated, and possibly the care is more intensive, and therefore there are more people around to look after the patient. In a way, that is the calling of a tertiary quaternary center, for example. An academic medical center, we want to do complex stuff, difficult things, right? We are challenged to do those things. Why would we want to do run-of-the-mill stuff that we're not practicing at the top of the license? But for the private healthcare specialists, that's a little bit different because they're working on their own, and our government does not provide subsidy or does not subvent the care. So it's a little bit different. I don't know about the States.
That's a great question. I mean, in general, for a true fee-for-service model, yes, you want to have the bread and butter, the easy cases that you can do quickly. But when you're sort of capitated or taking care of a patient population, there will be hard cases, there will be easy cases. If you're reading MRI, there will be a hard MRI, there will be an easy MRI. But I think looking at it sort of overall, if you're taking care of a large population, not looking at any one particular surgical case or any one particular patient, on average, things are average. And so I think that's why the benefit of looking at a big population, a big perspective, the individual exceptions sort of get diluted by what's common.
Well, just following up on this, I guess the averaging works provided a system, a healthcare system, let's say National University Hospital System or Kaiser Permanente. I understand you provide every level for a fixed population. So within that fixed population, everything averages out somehow, and it's fine. Now, if the population isn't fixed, if the population is free to move and choose the provider, and chooses the, let's say, the private provider for a run-of-the-mill, profitable, low complication rate, short length of stay stuff, and chooses university hospital for emergency, complex, transplant, whatever, then the averaging no longer works. And would you have any ideas or suggestions on how to live in a sort of more open system where the patients, the end user, can freely choose any provider, and the provider doesn't get sort of the whole bag, they just get the fraction of it?
That's exactly what's happening now in Singapore, where our private specialists look after the more common, big volume, run-of-the-mill type cases. But the complex cases are channeled into the public tertiary quaternary centers. To begin with, the government has decided that for capitation model, it would adapt and exclude things like patients with multi-trauma, for example, transplant patients, for example. Transplant patients, because obviously this is high-end and very expensive care. Cancer patients, because obviously these patients are, again, a vulnerable group at high risk, and starting out, they don't want to put these patients at risk. But clearly, too, I think that for oncologic patients, that a lot can be said about the capitation model. So we take precautions in excluding these first as we trial out the capitation model. And in future, we might make tweaks to the system.
The second part then, as regards, you need granularity in your costing. And that way, you have a true idea of the cost of care for your patient. And then this is what you need to be paid by the government or the insurers for treating that particular condition. But unless you know exactly how much it's costing per patient, then you're back to averages again. And you may not be actually meeting the cost of care for what you're charging the patient or what you're being paid for by the government for that particular episode of care.
Yep. That's very true today. We have, let's say, elective knee surgery. We have just one amount, and we pay everybody the same. And that looks like it's not very fair. So more granularity, more precise pricing would be one solution, or another solution could be exclude private hospitals totally out of the system. But then we need a kind of insurance surety that, yep, our government hospitals can provide sufficient number of elective surgery, and we can cover everything ourselves. But which gives me another question about when we move to capitation, how to ensure that there is no overconsumption. Because let's say in logistics, it's a very known fact that if you have traffic in the city, you build a bigger road, you have more traffic, because it's easier to travel by car. So the proper response is to improve the sidewalk and then make a road more narrow, and then the traffic goes down. So it looks like overconsumption, you improve, let's say like in emergency care rooms, they provide better service. Then there is an influx of the patients who say, okay, this is a nice place to get a healthcare service. And when this emergency department is again down on the service level. And our neighbors in Latvia, Estonia, we have very small co-payments, symbolic, 5-10 euros per visit. Is there any way to,
I agree.
to limit this consumption?
This is a very complex problem and a very good question indeed. And so we are just starting out in Singapore, and Singapore, as you have heard, is divided into 3 clusters. And the government has agreed that if the residents of one cluster goes to another cluster in seeking treatment, then back end, that funding flows that way. So that that cluster where the patient has gone for treatment is not being shortchanged. So if you're very good in doing one condition and your reputation is very good, you attract a lot of patients, that funding will flow to you if the patients go to you.
Yes, but also as regards overconsumption, the problem there is that you have a fixed budget, and then if you have overconsumption, then you blow the budget. So what the government has done in Singapore has put the onus on the clusters to provide the care within this fixed amount. And that fixed amount was determined by previous year's subvention that they were paying. So with that in mind, then the regional hospital or the cluster has to divide out the money between primary health care, community hospitals, and the acute hospitals, with the idea that if we can keep patients out of hospital or we can treat them in the community, it is better for the patient, but also better financially for the acute hospitals, because treating patients in acute hospitals is expensive. And if we can do the same in a day surgery center or in the community, then we're actually reducing our outflow. So it allows for, it's not so you're changing your consumption. You're changing where the patients are having their treatment, as opposed to over-consuming at the most expensive part of the healthcare spectrum.
And I think it reminds me of a saying I like. It's, if as a systems base, you want to make the right thing to do the easy thing to do. For a patient's perspective, from a doctor's perspective. So a good example of that is we have the ability to literally almost FaceTime with a doctor, schedule an appointment, FaceTime with an urgent care doctor within 30 minutes. So my daughter had has frequent ear infections. She had another ear infection. I asked her, does it feel like it did last time? Yeah. So yes, we could have taken her to the emergency department. We could have taken her to a clinic, but it could have a whole thing. But with a couple clicks of an iPhone, we were able to, in half an hour, get her to have a video visit with the doctor. She can explain, yes, it hurts here. It feels exactly how it has before. The medical record, the doctor's able to see what antibiotics she was on before, able to confirm it, and put in an order for the antibiotic, which I could go and pick up at my leisure. So it was easier for us as a patient. It's better for the medical system, no clinic visit, no emergency room, but it takes foresight, it takes effort to put a system in place that is easy to use. And that's something that I think would be incumbent on any population-built healthcare to put the effort into making the right thing to do, the easy thing to do.
But was it really easier for the doctor to make a decision? Because it looks like telemedicine really saves time for the patient. There is no need to transport the body to the emergency room. But for the doctor, it looks like it's easier to look at the patient and make a decision than try to make them to explain. So it looks like most of the telemedicine systems are not designed to save doctors' time and effort. They are much more convenient for the patient.
Well, it depends on the condition. So I agree. In a trauma, you wouldn't want to have telemedicine for a trauma patient, but for basic conditions, for a skin rash that you could hold up to the camera, for a condition that you've had, a chronic condition that you've had multiple times that are documented, that the doctor can see, it was easy for the doctor because he didn't have to bring her in and get her blood pressure and look in her ear. She was able to say, this is the same symptoms I have had multiple times. It's always gotten better with antibiotic X. And it was very easy for the doctor to say, okay, but if it doesn't get better, come in and see us. So it's not perfect for everything, but for certain conditions, it keeps patients out of the emergency room, out of the doctor's clinic, when going into the emergency room, going into the clinic visit would not have been a benefit for her.
In a capitation system, there has got to be checks and balances. So for example, in much the same way as we do appraisal with each staff every year, the Ministry of Health also appraises staff, each healthcare institution on a yearly basis. So they look at our quality matrix, our quality outcomes, they inspect the hospital, there's accreditation, there's licensing, and they actually do require us to show evidence of quality practice.
Thanks. So following up on this, we on the telemedicine and the quality. What we know from, let's say, the statistics of our emergency attendances at our emergency departments, at least 40% are non-urgent cases. So patients choose to come. I guess if there was a reasonable alternative, they might have chosen something different. But that consumes an awful lot of a tertiary and secondary hospital resource. And that leads me to the next question, which is probably quite contentious. In the system that were let's say a healthcare system, let's say Vilnius University Hospital with all sorts of other subsidiaries, can look after entirety of the population, so including primary care, emergency treatments, outpatients, electives. If we were to provide everything, then yes, it's in your own hands, and you can say, fine, I can see that we need a few more, I don't know, 24-hour primary health centers, and you can open those because that would be cheaper than running a big, massive emergency department, and probably better for the patients. But we are very separate, so the primary health care is a system in its own, and other hospitals and the care homes and societies, let's say, choosing where to provide the care, that would be another institution with its own agenda. So in your view, what do you think on having a more unified ownership of entirety of the system? There's a lot of scare of integrating primary and secondary care, because the feeling is that if we were to integrate, we will push more patients towards the secondary care or tertiary care, where some of us would probably feel that it's the other way around, that integration would actually lead to more patients being treated more in the primary. So what's your take from your experiences in Singapore and in the US on splitting versus integration?
I mean, personally, I'm a big fan of integration. The more you can have taking care of a population, the more everything will sort of average out, and you can incent the patients to do the right thing for the system. But it requires foresight. It requires planning and effort. And the argument or the concept of, well, we have this, the hospital system, the primary care, and this and that. I think a point could be made that by putting it all together, and then again, for instance, for us, that video visit is free. I didn't even have to pay for a copay. Whereas if I had went to the clinic, it would have been a $20 copay. So it's easier for me, and it's cheaper for me. And by incenting, again, by making it easy to do the right thing, you're going to get more people doing the right thing. And it requires effort. It requires a system, putting the time and energy to make it. It's not easy to put that together. It's very easy to say, this is how we've always done it in the past, therefore this is how we'll keep doing it. But I think there's data to suggest it may be in everyone's best interest, not least the patient, to put the effort into making the system better at the outset.
Sorry, in Singapore, then we have a fairly integrated system. So the university hospital and our sister hospitals, we work together as a sort of single group. But also then we have attached to those hospitals, community hospitals, we have a network of GPs that would be in partnership with us. But we also have our National University polyclinics, which are essentially primary care facilities that would have, like, you might say, mega GP clinics where you have a number of GPs, physios, etc., that will be able to do primary healthcare. They are jammed. The polyclinics are already full to the brim. So we have to see a way of maybe educating population as well, so as to get them to use the services, I suppose, more efficiently or properly, rather than filling ED, filling the polyclinics, etc.
To continue that theme, as Professor Quick showed in the presentation, you moved away from the bundle payments to the capitation. I thought that bundle payment to a degree was some kind of solution between the primary care and secondary or tertiary care. So this, I'm just curious.
Yes, so for example, in bundle care, it would encourage appropriate, and when we talk about patients, whether they're seen in the community or whether they're seen in the tertiary hospital, ER, is not so much about pushing the patient around, it's about the appropriate side. So for example, the bundled payment, and one example is a patient with, let's say, a hip fracture. After being operated on, he goes on to a nursing home community care for rehab. That's part of the payment model, bundled payment model. A patient who's had a stroke and then has had an acute intervention, and after that goes out quickly, either at home or to a nursing home or community set up for rehab. That's part of that bundled payment. So I think it's about trying to establish the best model of care and the right site for that appropriate care to happen. It obviously depends on the capability of the community, the nursing home, and so on and so forth. And therefore, this whole system needs to evolve. The training, the education, the development of the site of care also needs to be involved in the appropriate care for being the appropriate site.
So, what strikes me then is that the choice of the best financing system is not merely just the choice of how we finance it, but it's also what sort of system is financed by that model. So I guess where we are now, the capitation probably would be no different from the DRG or whatever else, because we just don't run that integrated system that would allow a part of the system to benefit from the capitation. Which I think leaves us in a very difficult place, where probably we end up in a situation where we need to make a decision on what sort of system we want to run, and then the next thing is how we finance that.
I think it will be difficult to switch from one model to another model completely overnight, and it may be that you might need to take small steps or changes or phases in order to move from one to another. And it may not be a complete change, it may be an adaptation of a change. So for example, if you're guided by what do you think is the best for the patient in the country, and does fee-for-service encourage perverse behavior? I don't know, maybe it's not happening here at all.
Well,
but if it doesn't,
it happens everywhere.
If it doesn't, then the discussion is at a different level. If it does, to what extent, and that may decide how fast you need to change.
Yeah, but we started our program in a fee-for-service system, and we found that by driving quality, we got reductions in cost. And the second part was, if you go to a clinician and say, we want to do cost containment or we want to cut costs, you've lost the battle already. Because no clinician is interested in cutting costs or containing costs. If you go to them and you say, we want to improve quality of care for your patients, then you'll get them on board. And by having improved quality, reducing their length of stay of patients, reducing their readmissions, reducing complications, you're driving down the cost, even though you're not doing it directly. These are the indirect results of driving quality.
So that's really encouraging to hear that too much focus on the results could ruin the very results we're trying to achieve. And sometimes it's better to focus on quality, on efforts, on qualification, attitudes of the medical staff. instead of pure results like stopping smoking or survival rates of after the stroke. And for me, it's really somewhat scary to see how much financing models could influence patient outcomes. So my perception was that it's doctors who take care of the patients, and of course the way that the hospitals are run, they have major impact on the patient outcomes. But looks like even financing systems can influence patient outcomes. And of course, and here we come very much to the medical data. And we start to understand that medical data costs. It costs time of the professionals, it costs money. We have to keep up with the systems. And data, if we set up wrong incentives, then the data becomes distorted. Because if we pay for appendectomy 1,400 euros, and for the complicated one, 2,400, somehow there is an increase in complications. Are they actual complications, or are just financial incentives for that? Or it might be that our 1,400 is too low amount for the hospital to survive. They are forced to upcode just to survive. So my question would be on medical data and how to ensure that the data, but we pay for that data, or include at least in our payments sufficient amount that hospitals get money for the data to be included, and the data is not distorted by wrong incentives.
Right. I think that's a good example of, again, human nature. If you're going to pay more for something to be coded in a certain way, you're going to get more of that being coded. It's that simple. And I think, therefore, you need to. But the question of quality, I think, is good. If doctors in general don't care about cost because we don't, that's the insurance, that's the help plan. We don't see it, but to frame everything as quality, doctors will care about quality. Doctors will care about the outcomes of their patients. And if you say, again, even from a finance point of view, the more you appropriately screen for cancer, the fewer advanced cancers you'll have, and the system will save money. And so I think, opening the data, how well are your patients being screened for colon cancer or breast cancer? I think that data is easy to understand. Again, did your patient get a mammogram? Yes or no? It's a simple, but it requires the thought ahead of time. How are we going to define what we're measuring? Making sure it's defined in a way that's easy to understand, that doctors will approve of the measurement. I think it's very hard to put a simple process in place. It's very easy to put a complicated process in place. It's hard to put a simple process in place, but I think it's in everybody's best interest to put that effort in at the outset.
I think it comes down to leadership. You need to set the tone from on high, and the leadership has to be behind all these incentives and efforts to improve quality and reduce cost. And if you have the backing of the leadership, well, then it opens doors further down the line, you might say. And then from the leadership is developing the culture. So you're trying to develop a culture where people aren't abusing the system, that they aren't coding for more complex surgery than they might actually be performing. And finally, then there's people like me, who's the group chief value officer. It's my job then to interrogate the data. So if I see that there's an increase in complex operations in a particular hospital, I have the wherewithal to go and ask them, how come your patients are now more complex, and challenge them to show me the data that these patients are indeed more complex. And having that sort of, I don't know, for want of a better word, guard dog or supervision to not try and play games, okay? Not to have incentivize them to do the wrong thing, but rather that they would do the correct thing for the patient.
So, because I guess systems are fairly similar in size. So I think at Kaiser Permanente you have about 800,000?
800,000 in the Washington, D.C. area. It's, I think, 12 million nationwide.
So the National University Hospital System serves about
1.2 million.
1.2 million. So broadly in Lithuania we have the 5 regions, and say the bigger regions would be broadly about 1 million, give or take. And so systems, while the countries are very different systems in size, they are comparable. So talking about the data and data control, what did strike me in your presentation, is that the number of sort of dashboards, number of quality indicators and various sort of individual markers is astronomical. And so what sort of workforce does it take on how, I mean, we can produce, especially these days with automated data gathering, we can produce endless amount of dashboards, but we need someone to look at that data and action it somehow. So how do we turn the data into the actual action on the ground?
So you're quite correct. If you want to hide data, you put it on a dashboard, because no one will look at that dashboard, okay? So we actually have to push the data. So we have dashboards where we actually push data to the clinicians on the ground, to the HODs clinicians, and then we meet regularly with them to go through the data with them. We didn't start off with this. This is a combination of 7 years, and we're continuing developing our systems. We started off with some very simple projects: elective surgery, AMI, and community-acquired pneumonia. We had about 5 projects starting off. And that was just to hone our systems to see that we could pull the data, that we could get accurate costs, and that we could get the clinicians on board, that they would believe what we were telling them. And that was a major part in the first couple of years, is getting clinicians to believe the data that we would show them. Any one of our projects would take 6 months to develop before we would show them the initial data, their historical data from the year before. And that was in developing a relationship with the individual specialists, but also developing the clinical indicators, ensuring that we were getting accurate cost data, etc. And we would do 1 or 2, generally 3 reiterations of the data before it was up to the standard that we could then publish as a dashboard and then send down to the clinicians. By having the leadership part, we're sending the data, we're presenting the data to the leadership. They are also then asking the heads of department, why is this? Why is the costs are going up, or why is the cost of the implants increasing, etc. So you still have that on board, okay? And as I say, it's generally peer we see at that level. But once we were able to do the simple things, then we went and we looked at more complex things like stringing modes of treatment. So it would be medical and surgical. It would be breast cancer, which would be chemotherapy, radiotherapy, surgery. Looking at that across the board. Then we were looking at, can we do this at the polyclinic level? And then we looked at, can we do it from community all the way, right the way through to hospitals? And that's where we're looking at things like diabetes, where we can follow the population from the community through their journey, you might say, through the various different stages in hospital, etc. And trying to see where we need to do interventions to try and prevent them from going from one level of severity to another level of severity.
This last example, I think, is the most striking in what can be achieved. A population that we see in our emergency departments some of them are frequent flyers.
Yeah.
So we know that this particular patient will come with diabetic ketoacidosis and end up on intensive care unit 3 or 4 times a year. And if there was better control, or even that habit of coming to ED rather than going to the GP, means that the patients just get a quick fix rather than continuous treatment. And stringing that from the primary care through the follow-ups can have massive impact in individuals' quality of life and in the general burden on the system.
Yeah. And I mean, this is the advantage of having this technology platform where you can actually pull information to help guide your services. So again, with diabetes in the community, we're able to identify the patients that have the worst HbA1c, and they tended to be elderly patients in single-room flats, rented single-room flats, who generally would mean that they have low resources, and they were making decisions as regards buying their medications or paying the rent. And then we're able to get the community services to come in and help them out as regards sorting out the rent for them, or at least getting their medication at a much reduced cost.
Yeah, in the United States, it's called social determinants of health. That there are a lot of, patients who their particular financial situation means, they may live in a community where there's no supermarkets with fresh food, and those individuals are at a much higher risk for end-stage diabetes and all the complications of that. And for better or worse, that's something that the medical system is not well positioned to fix. But the hope is that if the medical system can provide, cost-effective, evidence-based care for the patient population as a whole, that will allow the government to better provide for the, citizens who are less able to provide for themselves. But that's a very legitimate fear. But I don't think that's something that we're able to fix.
For the VDOs, the quality indicators, and for that set of maybe 5 to 10, it's not the hospital leadership that asks of those indicators. We ask the clinicians as a profession, as a specialist, what do you see are the quality indicators for this particular treatment? And you tell us, and we will use that. So it becomes evidence-based, as I mentioned in the talk, rather than a top-down approach telling people what to do, what to expect. They tell us from a professional standpoint that these are the indicators that they want to look at for good outcomes.
And using the opportunity, I wanted to ask the audience, and if anyone would have an opinion on. We've discussed a lot about the systems and the data, and it does look like integration is probably the future in one way or another. So what does the audience think of further integration of primary, secondary, tertiary care into those bigger regional systems that could manage the patient's flows or the patient journey from the A to Z? Would anyone have any opinions? Yes, no, disagree, completely disagree?
Thank you. In the final part of the Dr. Keksuchi, you were speaking about the integration of innovations, and one of the components is genome medicine and personalized healthcare. I really want to ask you, I fully agree, the integration of the genetic risk or genome medicine to the clinical medicine will change the future direction of the medicine toward the early diagnosis, early intervention, and will change the scene. So may I ask your opinion? How the integration of genome analysis or genetic risk into the clinical medicine will change the management of the healthcare? Because in Singapore, this is not the faraway future because of the precise initiative, your country will soon move to the genome medicine implementation to the society. So may I ask how they manage the genome medicine or the integration of personalized healthcare will change the management of the healthcare?
Sure, I think that's a fantastic question. At least in the United States, the concept of personalized medicine to repeat the question, how will personalized medicine, genetics in healthcare, how will that affect healthcare systems in general. And I can think of a couple ways, at least in our system, where we're using genetics, personalized medicine. One is, so when let's say breast cancer, if you get, in general, you can, get a biopsy or a lumpectomy, get the breast cancer, look at it under the microscope, and we can say, yep, looks like breast cancer, there's abnormal cells, and there's good data. Well, for breast cancer, for these conditions, we should give this chemotherapy. But actually, you can do breast cancer genomics, and to determine not just, yes, this is breast cancer, but this is, Mrs. Smith's breast cancer, and looking at the genomics of this particular cancer, you can actually target it with specific chemotherapy to better treat that cancer. And it turns out that financially, well, from the patient's perspective, given that you can target with the chemotherapy this particular person's cancer, it's better for the patient. They're not having chemotherapy that, in general will work, but for her will not work. And so she has unnecessary side effects and cost to and for the system. Again, we're giving the single chemotherapy that's best for this patient. So we're not having chemotherapy treatments that are, not helpful. It's wasted spend to give a medicine that isn't going to work. And so that's a good example of genomics, genetic medicine, that's better for the patient and better for the system. And I think that's a great question. The flip side to genetics is, genetic risk. Again, there are certain genetic mutations that'll give you predisposed to a certain kind of cancer. BRCA for breast cancer, there are certain patients at risk for that. We actually, so I oversee our medical genetics. So if you have a certain first degree or multiple first degree relatives with, let's say, breast cancer or other cancers, you can be seen by our medical genetics service, and we can assess your risk for that particular cancer, in which case the screening, it's not just mammography screening for everybody every year or two starting at 45. It's if you have this specific genetic risk for breast cancer, it's this specific screening protocol for you. And it's in our best interest as a systems perspective. If we can catch that cancer earlier, it's cheaper to treat. And for the patient, it's in their best interest because most patients want to have an early cancer detected than a later one. So definitely genetics is the way of the future, even for integrated healthcare delivery systems, because it's in everyone's best interest.
Thank you very much. And I just want to ask the situation of the Singapore.
Yeah, so
Yeah.
I agree completely. And if you think about it, even whole genome sequencing is very cheap today, right, compared to what it was. And if we can get the correct treatment with better outcome for the patient, that's all that makes a difference. So I also explained about technology. Technology is not cheap. Technology is very expensive and it will get worse. But the idea is, can we use this and harness its potential to detect early and to predict response to treatment better? I think that's key and that's game-changing. Again, I also agree with you that we shouldn't overdo things. It's about the appropriateness of it. So just because we can do whole genome sequencing at a cheap rate doesn't mean we go around diagnosing everybody. And then, there is the risk of what do you do with the variants of unknown significance? Is this patient that, for example, Dr. Bruce talked about going to worry for the rest of her life, whether she's going to get cancer? And all these unnecessary risks that will come with it. So it's about using it appropriately. I think that's key.
Need progress in that research. I agree. Thank you very much.
Thanks a lot for the question and comments. And yeah, we do have another one.
Hello, I'm Thomas from Republican Cholet Hospital. The question I have is actually, we are dealing with a constant change here in a very complex environment. And so far we talk a lot about fees, finance, costs, bonuses for great doctors who do a great job. But what about the other, that's a transactional part. I want to ask about the emotional part, and Dermot mentioned the leadership and culture, corporate culture. I would like to ask colleagues from overseas what they think, what's the role of the leadership across the all organization, and about the corporate culture, and how important it is to move the change forward, to engage the employees. And do you do anything specific to encourage it? Thank you.
I think that's a fantastic question. And when it comes to leadership, I sort of have three rules of leadership. And that is, no employee is going to work harder than their leader. No employee is going to care more than their leader cares. And sort of on a humorous note, no employee is going to dress better than their leader. And they're all aligned. If the leader is just there because, they got appointed to that and they want a few extra euros a month, that's not going to set the culture for transformation. And again, leadership is critical. And that's why, come from the United States, we have our own leadership problems, but, I'll stay politics aside. Leadership is absolutely critical because, and one of the most important things that I do is pick the leaders in the departments under me. And the departments that aren't doing well, I've needed to change the leaders. And it's because, everybody will follow what their leader does. They will care, almost as much as the leader cares. They will work almost as hard as their leader cares. And it's critical to make those decisions. And doctors know who are good leaders and who aren't good leaders. Doctors know who works hard, who's lazy. And correct me if I'm wrong, but that's why it's critical to, as a senior leader, to pick junior leaders and develop junior leaders and make sure that they have opportunity for advancement and for education, for learning, because that's what's going to fix a healthcare system, is having good leaders at every level. And I think that's a great question. Thank you.
Three important points. One is that an organizational values system is very important. What are the values that we stand for? And everybody in the organization, from the top to the bottom, must follow those values, because this is why we're here. This is what the organization stands for, and this underpins all that we do day in and day out. So values, and we must all subscribe to the same values. Two is the importance of a teamwork, and no one is more important than the other person in the team. So we talked about in the past there was a hierarchy that the doctor is always the most important person. No longer. All right, it's about everybody else. The nurse, the allied health, the pharmacist, even the porter, the cleaner. They are important because we can only be as strong as our weakest link. And so the team is critical. And if there are major changes that are coming the way, it's about change management. So for example, if you want an integrated system that looks at combining primary community healthcare services with tertiary, that change management is so important to articulate the comms in order for that to be successful. So I think three key ingredients: the values that underpin all that we do, the importance of each and every team member, and the importance of a change management.
Just to follow up on that, I'll tell you one thing: doctors don't like change, and so that's why I think the change management is critical. But doctors want to take care of patients, so the change management has to be framed in a certain way. The changes we're rolling out, it's better for the patients. It has to always be like that because doctors don't like change, but it has to, it needs to be at a higher level. It's better for the patients. And explain why.
Yeah.
Yes, thank you. I'm Neringa Chikienė from Lithuanian Cancer Patient Coalition, a patient voice. So there is one more very important aspect or layer in the healthcare future. It's patient empowerment and also empowerment of their caregivers. Can I ask to share your observations about this aspect?
That's a fantastic point. And sort of to follow up on that is, I'm a firm believer that we have a lot of data, and data is meant to be free, like easily accessible. So for instance, for our breast cancer, or for our screening mammography, screening mammogram, and that's a whole nother talk we can give another time. We found women are worried about breast cancer. So we put a system in place where for our digital mammograms, we treat them almost like emergency room CAT scans for appendicitis. So we read all of our screening mammograms, 100,000 screening mammograms a year, digitally within 30 minutes. And the results of that mammogram are instantly sent to the woman's phone. So in 30 minutes, by the time she finishes her mammogram, gets her dressed, gets back to her car, she has her results on her phone. And so 80% of the time, she knows everything's fine by the time she gets home. And so that's, again, from a quality perspective, is that going to decrease breast cancer fatality rate? No. But from a patient empowerment, we found that to be gold. And to be able to provide patients their laboratory results instantly, it comes to their phone. Their pathology results, biopsy comes instantly to their phone. Doctors also historically are very patriarchal. Our patient, my patients don't want to get their results, they want to hear it from me. But it turns out that in general, patients want their results and they want it right away. And if we can get it to them right away, again, the results aren't always positive, but the patients want the data. They want to be empowered to know what's going on with their body, and we give it to them 100%.
Okay. From a Singaporean point of view, we have incorporated the patient voice from the patient-reported outcome measures system. And we're still a work in progress as regards getting the patient voice as part of the clinical pathway and developing clinical pathways. That's what we're working on still. So we have a bit of a way to go yet to fully incorporate the patient voice and make it truly patient-centric. But we have started along that road as well.
Maybe I'll just end by talking about three things on the patients. One is on patient empowerment and family engagement. And I feel that patient empowerment is very important, family engagement. So for example, in Singapore, we have visiting hours for our patients. And I ask our nurses, why do you impose visiting hours? Shouldn't you encourage the family to be with the patient so they can help look after the patient? And then our nurses are freed up to do other things. So that's ongoing discussion. I don't know whether you have visiting hours here in Lithuania. Okay, so that's one example, that patient empowerment, family engagement. Two is patient education. And I think that we must do a lot more in terms of patient education, which we don't. So we have come up with an app, and in the app, there are various different conditions where the patients can learn and can read about it. But clearly, we must do a lot more. And thirdly, we do look at patient experience. But we look at it from, in my mind, a very corporate way, and we look at the percentage and see whether the curve goes up in the right direction from month to month. And whilst, in a way, this is good and it is a surrogate of how satisfied the patients are and the willingness to, for example, recommend us, all these funny questions we ask. Yet, is it really the type of experience that we're talking about? We have patient focus groups, and I think that that's probably the way to go, to hear them verbatim and to hear how we can do better. Bearing in mind that we are not with unlimited resources. We need to be mindful that everything is limited, manpower, finances, and so on and so forth. But to what extent can we improve the experience without hurting us too much financially and costing an arm and leg? These are the things I would imagine are low-hanging fruits that we can do and should and must do a lot better in.
Well, thank you very much, and our session is coming to an end, and it's great that we ended up where we pretty much started, about the fact that everything starts with the patient, and whatever we do for the patient ends up being well for the system and for the finances at the end of the day. So I know we could probably use another minute or two for any closing remarks from our panelists, if you have any final bit of advice for us looking into the bright future.
Well, I think you have an incredible opportunity. You're a relatively small country, a relatively like-minded country. You have the ability to put a population healthcare system in place that really could be world-class. And I think it's always nice to have an improvement opportunity. It's always nice to be able to see what you can do better. And you're doing fantastic now. I had a great visit at the Kaunas Clinic yesterday. But I think, there's always improvement for anybody. And I think you have the ability to do amazing things for your amazing patients.
I'd like to add that being a relatively small population, that you are therefore more nimble. You can do a lot of things, pick it up and run with it. You have the ability, access to a lot of data sources from what I've heard, and I think that this reduces the barriers to transparency and to information. Kid you not, we do have our own problems with those barriers, but I think that you are in a better state. But most importantly, I think that I see the will and the ambition of the team to move fast and to excel. And for this, I wish you well and would like to congratulate you.
So from my point of view, I think you're in a much better position than we were when we were starting off. When we started on our road of value-driven outcome projects, it was 3 people in one hospital with senior management backing doing it. Here we have a whole of nation sitting in this room with the minister involved, who can help drive this forward, whereas we were doing it by ourselves with the idea that this was going to be a benefit to our patients, and then it subsequently developed across the nation. So I think you have the right people in the right place at the right time in order to help drive this for the future. Thank you.
I'm very glad that patient centricity was mentioned, because we should not forget that there are no just government funds. There are only taxpayers' funds. So patients paid their taxes, and that's why we have money to pay for the services. So this patient centricity is extremely important in all the decisions we're making.
Yeah, I would like to thank all the lecturers for fantastic presentations and for fantastic debate, as well as the audience. I think recently, over the last 4 or 5 years, Lithuania healthcare system underwent quite significant structural changes. And I believe that this discussion and these deliberations today, how we go forward, right on the time. And yeah, I would like to hope, and I'm sure that we will move forward with further changes in the system.
So once again, thank you very much for your time, your thoughts. I hope audience found the discussion informative and interesting, and we'll see you after lunch, and I'll hand the mic over to Thomas for any further.
So many thanks for the panel discussion. Participants, indeed, a lot of things has been said, and I think the silence in the audience was a good sign that everyone was listening and thinking, what are you gonna do tomorrow?
when I will come back to my institution. So now I invite you to the lunch. It will be downstairs. Just go to the registration desk and we will guide you where to go. And remember that good dressing is only 1/3 of good leader. So we see each other at 2 in the afternoon. Good lunch.
Hello, testing one.
All right, ladies and gentlemen, welcome back. I hope you had good lunch and will not be too sleepy during the next panel session, which will be dedicated for the data integration and utilization. And here we will have two speakers. One will be also from Singapore, light, Mr. Peter Forbes, and I hope we do have him online. So he will provide us a presentation about the digital transformation. And afterwards, we'll have a Vice Minister, and he will go on and speak also about the importance of data in the decision-making process. So welcome back, and please, let's connect to Singapore. Hello. Good afternoon, Mr. Forbes.
Hello, good afternoon.
So, stage is yours. There's a huge, not too huge audience that is waiting for your presentation.
Thank you very much. I'm very pleased to be here this afternoon. Thank you to the Ministry of Health, Republic of Lithuania, Vilnius University Hospital Santaros Klinikos, Hospital of Lithuanian University of Health Sciences Kaunas Klinikos, Klaipėda University Hospital, and National Cancer Institute Lithuania. It's an honor to be able to take you through NUHS digital transformation today. National University Health System is an integrated academic health system and regional health system in the western region of Singapore. We have 3 acute hospitals: National University Hospital, Alexandra Hospital, and Ung Tung Fong General Hospital. 3 national centers: cancer, oral health, and heart. We also have a network of family medicine clinics, primary care networks, and a regional health system. We're affiliated with 3 medical schools of the National University of Singapore: the Yong Lu Lin School of Medicine, the Sol Swee Hock School of Public Health, and the Faculty of Dentistry. We also run 7 polyclinics, 2 community hospitals, and we manage over 2,600 beds. We have over 16,000 staff and over 6,000 students. Well, I'm the one with the privilege of being able to present to you today. The digital transformation of NUHS was a whole of NUHS effort, and so all of the leaders who contributed to the transformation, beginning with Deputy Chief Executive Mr. Fu Hee Jug, who led the overall transformation, followed by Clara Singh, Chief Operating Officer, who led the implementation of the NUHS app, our Chief Medical Informatics Officers, Associate Professor James Yip, Associate Professor Gamaliel Tan, and Dr. Lim Erluen, who implemented the electronic medical records system. Associate Professor Thomas Lowe, Group Chief Medical Board, Professor Kwek Sui Chai, our Chairman of the Medical Board at National University Hospital, Ms. Nell van den Ende, who implemented the referral harmonization, Ms. Eun Bi Ling, who implemented our single contact center, Mr. Xia Han Yong, who leads all of our IT, Adjunct Professor Nyan Ki Yuan, who heads our academic informatics office, and last but not least, our technology partner Synapse, who implemented many of the systems behind our digital transformation. 6 pillars support NUHS digital transformation. Those are our One NUHS mobile app, teleconsultation, the next generation electronic medical record system, NGMR, which is built upon EPIC, our One NUHS contact center, referral harmonization, and our AI platform, Endeavour AI. Starting with the One NUHS app. The app is the digital front door into our services for patients and residents in the Western region of Singapore. It engages, powers, and enables patients with data about their health that allow them to self-manage. Since inception, it's been downloaded over 1.4 million times, and each day it's used by over 25,000 users. When we developed the app, we took a minimum viable product approach. This allowed us to reduce the time to value and roll out a number of features over time. It was first released to staff in December 2020, and then followed up with release to the public in April 2021. Those first two releases focused on transactional services such as appointments and payments. They were quickly followed up in August 2021 with new innovative features, which included teleconsultation and our signature screening service, My Healthman. In release 4, we added integration to the electronic medical record system with Epic MyChart. In release 5, we added Health Together, our community health initiative for residents in the West to help them stay connected and support them in managing their own health. In release 6, we added a rich set of test results enabled by MyChart. In release 7, we added the I Have Arrived button for registration and live chat, which allows a live text chat with our contact center. In release 8, we allowed patients to update their own particulars through the app. In release 9, we simplified the user interface. In release 10, we added MyChart Education. And in release 11, we added the I Have Arrived guide to make the registration process even simpler. With each release, the app adds features and becomes more and more powerful for our patients and residents in the West. One innovative feature which we released during COVID-19 was teleconsultation. While this was common in private practice in Singapore, this was in fact first for Singapore public health. Before the implementation of teleconsultation, there was no integration between the electronic medical record system and the Zoom video session, which the patient used to talk to the doctor. This led to a number of problems. The issue was that for the patient, they could not tell when the doctor was ready to enter the Zoom meeting, and they had to memorize their own Zoom meeting details to be able to enter the meeting with the doctor. On the provider side, what happened was that because there was no integration between the electronic medical record system and the Zoom system, the provider staff had to manually sync on paper between the appointment and the Zoom meeting. This was both inconvenient and time-consuming. After the implementation of teleconsultation in the One NUHS app, the journey for the patient was seamless, end-to-end, fully completed in the app. The patient would receive an SMS reminder about their appointment, enter the app where they could see the appointment details, register for the appointment, and upon registering, they could then see the queue and the number of patients ahead, so they knew when to expect the doctor to enter the Zoom meeting. When the doctor signaled they were ready, the Zoom meeting would start, the patient could then consult with the doctor, and having completed the consultation, the meeting will end. The patient would then receive an SMS reminder. They can go back into the app, order their medications, complete their payment, and finally receive their medications delivered to them in the comfort of their home. The next generation electronic medical record system, which is built on Epic, is really the backbone and the foundation to the digital transformation. It gives us one platform, one record per patient across the entire healthcare cluster, including both primary, secondary, and tertiary care. This common foundation enables the One NUHS app, One NUHS contact center, and provides the data for our AI capabilities. It tracks the entire patient journey from admission to discharge. It's also enabled on mobile through MyChart for patients, the Rover mobile app for nurses, and the Canto iPad app for doctors. It greatly reduces the needs for form filling and provides seamless data to downstream functions such as pharmacy and medical social work. In addition, it also provides for better clinical decision support, providing alerts for things such as allergies. We integrated Epic MyChart into the One NUHS app. This deep integration provides us with a number of benefits. The patients can get access to the rich set of data contained in Epic, such as test results. In addition, it allows patients to add data into the app, which then flows directly into the medical record system. This could be, for example, questionnaires before they attend their consultation, or it could be vital signs, which are then captured directly into the medical record system. In addition, it provides MyChart Care Companion, which empowers patients to play a more proactive role in management of their condition. Before the transformation, NUHS had 4 different contact centres, one at NUH, one at Kampong, one at Alexandra Hospital, and a further one for the polyclinics. In addition to that, and all those different numbers to call, we only allowed patients to contact us over 3 different channels: phone, email, and fax. So we wanted to improve upon this situation. We wanted to provide a single number to call. We wanted to be able to have our agents located in one location and to give them the ability to work remotely when required. And a number of our systems were also old, so we wanted to be able to replace those old systems with new modern systems. After the transformation, we have one contact center with one number to call. We have an integrated voice recognition system, which guides the patient to the right contact person. We have a CRM system, which captures details of previous interactions with patients, so we know when they last called and what it was about. We have a knowledge management system, which supports our agents in their use of our processes. And we have an SMS gateway, which sends reminders out to patients about their appointments once they've been made with the contact center. In addition to that, we have a series of performance management dashboards, which track the performance of the contact center. In addition to adding the contact center, we also added 3 new channels: the NUHS app, a chatbot, which can automatically answer queries, and live text chat with our agents. This enabled us to reduce the error rate in contact with patients down from 5 per month to 1 per month. And over the past year, our call abandon rate has been below 3%, which is very good and below industry standard. In order to make the contact center work, we had to harmonize our referral process. So before the transformation, what happened was the polyclinic doctor would call the institution directly. And having made that call, they would then start a series of to and fro between the polyclinic doctor and the various institutions until a slot could be found. The referral criteria and referral timeframes were also different for each institution, which further complicated the process. After the transformation, we've harmonized those referral criteria and also the timeframes. So we did this across all of our 35 specialties with a harmonized single form for each of the 35 specialties. What this enabled us to do then was reduce the time that it takes for a patient to get their first appointment. So unlike before the transformation, where there was that to and fro between polyclinic and institution, now it's managed one time by contact center, and the patient gets their appointment within 1 day, whereas before the transformation, it took up to 7 days to get their appointment. The system is also enabled by an algorithm which does the scheduling. That helps provide the shortest time to care. It helps to right site patient into the right location and helps us manage and load level workload across the cluster. When we first introduced the app, patients would still have to either call into contact center or physically go to one of our institutions to register their particulars if they were a new patient to NUHS. This led to a delay of up to 3 days because the service level on that particular transaction was 3 days to create the patient record. So after the transformation, we built this into the One NUHS app. The patient can go into the app. They can identify themselves via the government standard identity digital service SingPass. That then pulls their data from the standard trusted government service My Info, which contains information such as their address and their identification number. So having done that, the patient record is set up automatically in the medical record system, and the patient can then directly book their first polyclinic appointment directly through the app, entirely self-service, and they will get that appointment as soon as it's booked. Users can view, change their appointments on our app, but in a small number of cases, those appointments are too complex to change because of linkages between the appointment and diagnostic tests, for example. In those cases, the patient would still have to call the contact center. So one of the things that we implemented during the transformation was live chat with a contact center agent. What happens now is if the patient cannot complete the transaction through the One NUHS app themselves, they'll be redirected to a live text chat with a contact center agent. They can then chat with the contact center agent over text, just like a messaging or WhatsApp conversation, and then get the rescheduled appointment that they need. This has further benefits for our contact center agents because they can manage a number of sessions concurrently at the same time. Since rolling this out, we've also expanded its use dealing with email transactions. So we redirect email instead to live text chat, which has the benefit that the contact center can interact with the patient, ask questions, make clarifications, and support the patient's needs. So what's next for NUHS? Our future model of care is designed on a digital health plan, powered by automation and AI. We will empower patients and residents by providing nudges and data to enable them to manage their own health. This is enabled by 6 digital pillars. The One NUHS app, which provides the digital front door into our services. Teleconsultation, which enables care remote from our physical facilities. Next generation electronic medical records, which provides a single record which can be viewed across the whole cluster, enabling coordinated care across all of our institutions. The One NUHS contact center and referral harmonization make that care seamless across the cluster and provide consolidated points of contact into a single number. And finally, Endeavour AI uses the data from the electronic medical record system to enable our patients with AI capabilities. So within the One NUHS app, Epic MyChart provides the patient with detailed records and allows them to input their own patient data. Teleconsultation provides that remote care separate and free from our physical facilities. The electronic medical record system contains the health plan. It recommends relevant screening and vaccinations, and it captures patients' disease status. The One NUHS contact center and referral harmonization provide a consistent experience across both digital and human channels, and crucially, enable the earliest access to care across our institutions. And Endeavour AI enables patients with AI-enabled services, such as CHAMP, our AI support system for chronic disease management at population scale. That's empowering residents to manage their own health. All of this will enable us to manage population health across the 1.2 million residents in the Western region of Singapore, empower patients and residents to manage their own health, and help us to improve patient experience. That brings my presentation to a close. Thank you for listening.
Thank you very much for an interesting presentation. That's like reality of moving to the digital world. So as we will not have an opportunity to ask some questions, I will try to ask you. So what is the percentage of your digital consultation comparing with your conventional outpatient services?
Yes, so for teleconsultation, we manage and track the number of teleconsultations for repeat visits across the cluster. And as a whole, teleconsultation is running at around 5% of all repeat visits across the cluster.
And did you had the chance to compare the patient outcomes when you compare these digital services with conventional one? Because, you know, sometimes you can think there could be a high risk for medical errors when you cannot inspect your patient in a good way.
Yeah, so one of the things that we did when we implemented teleconsultation was that we talked to the group chief of each individual specialty, and those clinical group chiefs then identified which conditions would be suitable for teleconsultation and under which settings or which patient criteria. So we're very careful about what we refer to teleconsultation. It's only allowed for repeat visits, and it's only allowed in specific circumstances. And when it comes to patient-reported outcomes, that's something which we're currently in the process of enabling in the One NUHS app via Epic MyChart.
All right. Are there any questions in the audience? Yes, please.
Thanks a lot for the presentation. This seems like a fairly sophisticated technology, which is aimed at a very large population. What's your experience with the uptake of the app, especially, say, in the elderly population or maybe some other population groups? Do you find any challenges in rolling it out to over 1 million people that the NUHS serves?
Thank you for the question. Yes, so we do track penetration rate of the app, and we track that penetration rate across all of our institutions. And each institution, I believe they're all above 60% penetration rate. When it comes to the demographic of the patient, what we found is that even the more senior patients who may be 60 plus, for example, are often comfortable with using the app. And if they're not comfortable using the app, then they often get support from their caregivers. And one of the features in the app itself is caregiver support. So you can help manage your relatives' care through the app via the caregiver feature. So, for example, I could manage my son's care through the app. And so that often helps for those more senior patients too.
Thank you. One more.
3 years ago, Singaporean hospitals started to use single hospital information system. Yes, Epic. Yes. Could you evaluate the outcomes of this decision? 3 years passed, so maybe you have some results and comments on this.
Yes, so we have been live on the electronic medical record system for around 3 years now. NUHS cluster is the first cluster to be live across the whole of our healthcare system. Our partner cluster, National Healthcare Group, was the second to go live on the electronic medical record system. We have had quite a deal of success with the system. We do see a lot of benefits. In particular, having a single harmonized system does enable a lot of the digital capabilities that you see today. So that's one of the big benefits. And of course, having information all in one place then provides us with a lot of data which we can then analyze and use to support our patients as we move forward into the future.
Hi, Peter Dermot here. Just to reiterate, when we started our system of data collection, we didn't have Epic. We used multiple different data sources in different silos. But the quality of the data that we can get now is much improved. If I can give an example, say for cataract surgery, when we initially started off, the ophthalmologist wanted to know what the visual acuity was pre and post surgery. And we couldn't automate the collection of that data because we had to manually go through the case notes to find it. But with Epic, that's actually documented within the Epic system, so we can start pulling this additional data that we didn't have. As a user of Epic, it does take time to get used to. The other systems were a bit more user-friendly, but the more you use it, the better it gets. But it does take a bit of run-in time, you might say, for the entire ecosystem, so the entire cluster to get used to using the new NGMR.
More questions? If not, once again, thank you very much for your time. Of course, we would like to have you here on the stage discussing, but thanks, and I hope that the next time you will be able to attend this great event.
Thank you very much. Sorry, I can't.
All right, so we can move forward and welcome the next speaker. Is Vice Minister of the Ministry of Health, Oleg Snerkshu, and he will speak about of course, data as we have the session.
I'm playing too many micros.
Years ago, I had a very heated discussion with a colleague. I've just started my path to digital health, and my colleague was already in this business for quite some time. And I said to him that, healthcare domain is just like another domains. You can digitalize it with a proper engineering and proper approach. And he was saying, no, you see, healthcare is a little bit different. It's a little bit more complicated. So we had this heated debate. And now I'm standing here 30 years afterwards and really smiling at myself back then. Today I have the same discussions with very smart people, IT people coming from another domains who say, Olegas, we can fix it. It's just, a bit of engineering, a bit of other things. And I'm saying, healthcare a little bit more difficult. So, it's not about the land that Lithuania is not capable to do something. Here's a number of quotes for you. Like, if you go to Switzerland, Germany, UK, United States, Austria, and every country, just go to Google any newspaper and ask about national digital health or e-health, as it was called previously, and you'll see a lot of beautiful things, like Germany's digital health efforts are failing. In other fields, we're known for efficiency, but not true when it comes to digitalization of health systems. UK, we know the great failure of 11 billion pounds, right, for NHS digitalization initiative. Well, what I can say, in Lithuania, we say it much simpler. If you ask our media and Google our newspapers, then it will be simple. E-health doesn't work. So, So now to spell it out, for our guests, what not working e-health consists of in our country. So in our country, we do have working national EHR, which includes referrals, vaccinations, discharge summaries, death certificates. We have working national e-prescription totally. We do have certain certifications, like for drivers, fully digitalized COVID certificate, and we have some lousy laboratory tests data and some other pretty empty shelves not filled with data. So not bad for not working e-health, right? Yeah. If you ask about shelves, maybe it's just a framework, a carcass with no data. This is actual numbers. So National eHealth was created in somewhere 2016, 17, and this is amount of digitally signed formal clinical documentation, like visit summary, like discharge summary, like referral, e-prescription. So it goes up quite nicely, right? So we also cannot say that it's empty data-wise. So if we compare, for example, with the United States, it's not a number of documents, it's an amount of healthcare facilities using EHR or EMR systems. So we can see around 2017, 18, it's stabilized already close to the 90 or 100%. So we're on par with Western countries. We do have infrastructure, we do have documentation. But is quantity equals quality, right? So most probably here is the question. Here is the difficulty of health data and making use of that. Not as people of my education, IT guys trying to put things in digital and being happy with that, but rather in the shoes of clinician or medical informatics. It's not enough. Data should bring value, right? So today in my presentation, I decided there are many fields. Let's delve into one example of health data. What makes it useful, what not, and what is the global perspective here. So to begin with, I will start with this concept of digitalization. All of you heard this word. Who knows the difference between digitization, digitalization, and digital transformation? Hands up. Anybody feels like strong in that? Okay. Everything started from digitization. That's making paper, putting in a machine, and then you have file, right? A PDF or something. It's digital. You cannot make a lot of use of that, but you can send it to another doctor, right? He can read discharge summary or radiology report. So that's the beginning of the era, how PDF discharge summaries, referral letters being digitized, and move forward. For example, International IHE organization puts the standards which are established by EU as a recommendation for all member states, right? And that's the way how Austrian, Switzerland, and other national EHRs are made. So we're pushing a lot of PDFs. And last 10 years, we understood finally maybe it's not the right way. And some professors where we have disputes, now for doctor is enough. I can read it, that's okay for diagnostic. But then COVID came, and ooh la la, you cannot take any statistics out of PDF. So it's not good enough, right? So then we have second level. Then we speak about digitalization. We put data in. Help me with this XML visualization. I don't know. I find it funny. You cannot understand really, but somehow a little bit artful. So in essence, you can have your diagnosis, you can have your allergies in a semantic way, in essence, which allows you to extract data and basically maybe do some analysis. So that's a level 2, which is partially implemented in most of Western world, like in Lithuania, like in Germany not, but in Austria, for example. However, we find out that if we compare, it's not apples to apples. So if we have lab results, we have a value of hemoglobin of something, and it's not really clear which measurement method was used, which units, etc., etc. So again, you cannot compare. So we need even third level of semantic interoperability. So here we want to exchange on data field level. So now you start to understand where complexity is coming from, right? So it's not like so simple we exchange data. It's many granular levels. Now to make things where IT guys give up, if on that slide IT guy will say, okay, it's so doable, we can fix that. Here things start to be really, really funny. I like this example of sharing diagnosis on national EHR. So Lithuanian colleagues will start laughing because when we patient replication without status of actuality of this diagnosis or their validity. So for clinicians, it's understandable, even for a lay person, it's understandable something is not right here. But where is the problem? So the problem is that with diagnosis in clinical practice, we need to transfer that to a data. So if we have coding, if we have, in Lithuania it's simple, it's ICD-10 AM, right? In other countries, well, I see Dr. Pichalunas, he will say, no, legacy is not so simple, for oncology is not enough, right? And then somebody will say, no, wait, pathology, we want to have SNOMED CT. So here our brains start to melt a little bit, right? But it's only the beginning of the picture. Then we have generalization level. What level of ICD-10 we want to have? Generic, site-specific, right? Confirmed, not confirmed. Clinical status, verification status. Is it differential diagnosis? Is it active? Is it closed, relapsed, right? And context, if it's a diagnosis of this encounter or it's overall chronic disease. So I think for every clinician, when he sees their diagnosis, different information changes completely understanding of that. So if it's just differential, okay. If it's already confirmed active diagnosis, is a different picture. So all of that typically is not part of our hospital information systems or national systems. We're losing something here, something there. And it's okay if you're director of university hospital, you know how you want to do, and your IT guys will do how you want to do. But if we put all directors here sitting and ask their systems to communicate, then we'll find out that all of you decided a little bit differently, and it doesn't glue together. So here is the difficulty and the beauty of these medical informatics disciplines comes into the scene. If you want to have regional, like in Western Singapore, or you want to have national or uber-national, like in EU, it's a lot of clinical consensus and agreement. How we're going to put this data into action. So to make it just visible, this example, so you're getting from your EHR this clinical case. You have a patient, 62 years old, male single, and he has I-21.3, which is ST elevation STEMI, right? By the way, you see I've asked ChatGPT to give me 6 faces of different certainty. How many faces do you see? And I asked literally 6 faces. And that's illustration I put specifically. Then I asked, please put 6 doctors. And it's already 6, right? But I left the first one because some of very enthusiastic AI guys saying, Olegas, forget everything you do, just take ChatGPT, and it resolves all your problem in no time. Yes, it resolves all my problem, definitely. But in healthcare, regretfully, we cannot afford that way, shortcut way. All right, so in that case, if we add to this portal or whatever EMR system, you see this clinical case, and all of a sudden it's not I-21-free, which you think is a confirmed active diagnosis, it comes with differential. So you see already different situation. If it comes with a status that is active and confirmed, it's another case. And if it's resolved, it's the third case. So now, having our current present system without even possibility to pass that information, that really questions the validity and value of all entered clinical data. So this is quite important to understand that the exercise is not trivial to capture health data. And here what helps us, interoperability standards. So these standards help us to answer those questions. How to exchange data on a phone, on USB, or like in Central Asia, they make a photo with a telegram and send to another doctor, radiology image, very nice, and then another one is consulting based on that. So it's also a protocol, not evidence-based definitely, right? How not to lose meaning, context, how to enable secondary use, and how to map data. Then different university hospital has different classifiers to classify clinical data. So we do have a number of standards. Again, our friendly ChatGPT misspelled most of them. You can see ICD-10, but you cannot see SNOMED, FHIR, LOINC, and many, many others which enables us to share meaningful data. However, to make things even worse, every 7 to 10 years, technology changes, and we need to migrate. And what happens? We have Klaipėda University Hospital who will need to change system this year or latest next year. And we have Kaunas, for example, Kauno Klinikos perhaps in 3 years, I don't know. So in any case, then you're going to do that with your million of records, regardless if we dream about EPIC. If we don't dream about EPIC, you need to do data migration, which you will lose something, lose some data. So now imagine this fantastic idea, data from cradle to grave, right? So if we take 80 years, and every 10 years we're doing data migration, how much we preserve, how much meaning will change or not, who knows, right? So we need a solution here. We do have some theoretical solutions. Some of them, some people claim they work, other people say they don't, but I would present you my opinion, which is coherent with the opinion of many medical informatics experts, that certain standards do work. So imagine, to resolve that problem, you as clinicians don't rely on IT guys who tries to understand what is blood pressure. So it's quite easy to understand that you have systolic, diastolic, but it takes time to explain that it's not the same on a position of the patient, on a precondition of the patient, on comorbidities, protocol of measuring, etc., etc. Or medication prescription, that it's not just drug name dosage, but it's route of administration, its duration, side effects, etc., etc. And every concept, clinicians can put a model. However, clinicians are not informaticians to draw databases, and IT guys are not clinicians. So what is the answer? One of the answers is OpenEHR standard, which gives driving wheel to clinicians to model health data. And it looks like that. So there are many models which are open worldwide. You can download it in many languages. You can put your panel of endocrinologists, cardiologists, whatever specialty, and create your own models which will be plug and playable. Plug and playable, meaning that you can exchange between systems, regions, clusters in the future countries. This is one of the interesting ways which can contribute in resolution of this dispute, why it's so difficult, why we're stuck over time. So what is the benefit? Well, so far sounds like a lot of work and a lot of effort. For what? So one of the things that you get comparable data, which you can visualize and put in dynamics. So whatever you can take pediatrician growth charts, or you take lab data, lab results dynamics, right? Which are combined with medication and healthcare events. So if it's so comparable, now it's possible not only in your hospital information system, it's possible across the country, combining data from different labs, different facilities. And here comes the beauty of semantic data, which use standards, classifiers, and nomenclatures. So, second aspect, which is also quite unique to healthcare, we have multimodality of health data. It's not only structured data. It's images, sounds, videos, which requires different tool set, right? Different tool set how to process different systems and subsystems, which in the end should be integrated. So what we want integrated semantic multimodal health data. Putting it in technical terms to make such a platform which you can buy as a bunch like Epic or create yourself, you need all these building blocks: hospital information system, radiology, PACS, lab, portal, mobile, etc., etc. And then you have stack of interfaces. So all this complexity is very similar to your car. You don't care about that if you can drive a car, right? But I open up this internal parts of a car just to show you a little bit, starting from this diagnosis example and finishing with technological landscape of a system to create it in a way that it's usable and interoperable. So that gives quite obvious benefits. We have finally, with a such system, high-quality aggregated actual patient data at bedside. We can have, as I showed, the ability to see dynamics of data, lab results, and vitals. We can have alerts, real-time alerts on duplications, contraindication, critical values. We can have, finally, plugging in clinical decision support. So this is what Singapore is doing right now. If it's an expert system, if it's AI, ML, or any marketing term you prefer, but in the end, it's a clinical support to enhance productivity of clinicians. High quality research, definitely. We can export, anonymize data, and do research. And then finally, I should touch this topic, because when I don't touch it, audience criticize me that your ministry lives in previous century, you don't know what is AI. So to prove that I know what is AI, the funny thing, we had a discussion with Dr. Woman last time, and I was asking, how are you using it, Kaiser Permanent? And you said that we're quite conservative here. We're using it, but not to disturb the process, not to rely fully on that, right? So radiologist still needs to think. So I try to see what is proven and really used, not in advertising, but in reality, by different top hospitals and healthcare facilities in the world. So summarization of patient history according to your needs. So instead of going through documents, values, etc., you can filter out and say that I need this specialty or overall for this window, time window, right? Give me that report. Then report drafting and smart dictation, so we don't need to write with your hands. Radiology image pre-analysis, so something which boosts productivity, not replaces, but boosts, gives advice, a hint. I was happy to see, and we discussed, I don't see Professor Laurinaitis, pathology image pre-analysis. Just last month in the United States was launched the first large-scale product, which maybe will change the industry sooner or later. And then we have different analysis possibilities before sending patient. Analysis of ECG, ophthalmology images for retinopathy, dermatology images, and differential diagnosis based on symptoms and lab results. So all of that is advice to a doctor, not a replacement, of course. But this is something what is already proven, gives a boost of productivity when we speak about resources and raising costs, as in the first panel. So I want to finalize my presentation in that sense, what we're doing in Lithuania right now, which projects have been initiated. I didn't put it here, but reflecting to Peter's presentation, we launch our mobile app, hopefully, within a month. Why I say hopefully? Because it's already a third or fourth deadline. So we're also agile, as you see, the same as Singaporean. However, our release date is always somehow postponed. But hopefully we have our first version, first release of mobile app next month. But speaking from a larger perspective, we are in the process of building our next generation digital health platform, which is national next generation EHR in Singapore, which would be interoperable from one side and not rigid in terms of structure. Second thing we want to achieve is have high-value clinical data quality for introduction of clinical modeling. That's what I explained about open HR and putting clinicians in driving seat. So we have our pilot project, which will start in few spheres, I hope, in cardiology and endocrinology as the starting specialties, where clinicians will be creating themselves data models. And then we go to National Imaging Archive, telemedicine. Again, we saw it in Singapore. It was obviously very well used and giving a lot of benefit. Then we have preventive programs management solution, data management for our specialized clusters for stroke, myocardial infarction, trauma, oncology clusters, etc. And digital patient journey in emergency medical services. So this is our concentration for next 2 years. It's super ambitious plan, and we should wish all of us success, because it will be a very difficult journey for clinicians and IT guys as well. It will require consolidation of all our efforts. So, my final slide. To make digital health successful, it's quite obvious from European perspective. Money is not enough. Time is not enough. We need to build ecosystem where private, public, academia is invited all together. We need to have next generation semantic health information exchange, and only that helps us obtaining high value clinical patient data. So, having all this basis, we can speak and dream about all the beauties of next generation's IT, like prescribed digital health apps, diagnostic clinical decision support, seamless integration of AI. We just discussed during coffee break, a colleague asked, are we going to have this neurological stroke assessment? I said, yes, but where? Will I get it in 1 minute or in 4 minutes? Because in 4 minutes I don't need it. It's too late. So it's not a matter of just making a system. It's always in healthcare a matter how you make the system, what data, what time, and if it's usable and useful for end user. Thank you very much.
Very nice presentation. I really like delivery plan. So how can we help you to keep deadlines unchanged? So now we move for the panel discussion, and I would like to invite two chairmen. So Vice Minister Niakshu and Director for National Cancer Institute, Professor Pečeliūnas, and of course the panel discussants.
So, dear colleagues, we have exciting discussion on intersection of data and its usability and how it can help our healthcare. So as a starting point, I wanted to say that, look, in Lithuania we have, I think, around 15, 20 years of usage of hospital information systems in our biggest hospitals. We have more than 10 years, or almost 10 years, of national EHR. So that means we're digital teenagers, right? So we're not infants, we're not adults, but we already have problems of teenagers, which definitely are very specific and interesting, right? We have some data, we're not happy with the data, our systems are not robust enough. So I guess our discussion should somehow level to the situation where we're now, and also using opportunity learning from our guests who started their journey a little bit earlier. So to begin with, I would like to have a very simple question which starts from our Lithuanian participants, and especially participants from healthcare institutions. I want to, you to be a little bit unpredictable. So therefore my question will be not a systematic one. Imagine that you have unlimited funds and resources, and you need to fix your health data. What are the first initiatives for the first year you would do? What will be your biggest change with no limits of resources? So we have here representatives from Kauno clinics and Oncology University and Santariškė. So maybe Antanas, we'll start from you.
So I think the question is not that hard, maybe as expected, because this is something that I really think a lot. Of course, I'm not including the part where the resources are unlimited, because we live
That's the interesting part.
In an environment when we have quite limited resources. So I think if you look to the examples from the leading institutions, and if you need to kind of build some comprehensive solutions, from what you see, apparently Epic as kind of solution, plays well there, because it's a kind of EHR record which is very comprehensive from what we know, also very expensive, where you can integrate a lot of things. However, I would like to say that maybe it would not be the first thing I would like to, implement straight away. I would also need to understand how we're gonna organize our service as well, because it's important to understand your political landscape and where you are. Because currently, if you would like just to build another electronic health record, I believe it would not serve well even being Epic, because what we're going in Lithuania is going to be major transformation, integrating services. So from what I see, likely we will need to serve as a network hospital, because we're third level hospital, so we will need to be more integrated. So even if I buy Epic myself and would not integrate a national system or other institutions, so this basically would not solve most of my problem. So for me, it would be, first, it's important to understand how we're going to serve in the bigger healthcare system. So what kind of centers we're going to collaborate with, how we're going to provide our services, and then build on that. I think the two solutions for me would be, one, Epic, if resources are unlimited. Also, if I use Epic but other hospitals not using it, likely I will not be able to be very interoperable. So I might need to think as well what you're building on. So from what I know, you're also thinking about open EHR standard, which we're also investigating quite a lot in our hospital, in our institution. So just understanding, how we're going to serve and how we're going to create that data would be how we're going to build data infrastructure. So this would be the key focus for me. So just understanding how we're going to provide services, and then deciding, based on that, how we're gonna build our hospital information system.
Thank you very much. A disclaimer: this event is not financed by Epic, right?
No.
So important to note. Valdis, what's your take on that?
I think the main thing is what we want to achieve, our goals. And if the resources are unlimited, first of all, I would like to finalize digitization according to you? And second thing, I think we need to achieve data standardization. And the way we could achieve this standardization and interoperability, I think one way may be Singaporean way to buy just Epic for all, or the same hospital information system for all hospitals. Another way may be just to build infrastructure like data lakes for data curation and standardization and mapping to a MOP standard, maybe various solutions, but the goal I would like to achieve is data standardization and interoperability.
Very valid point, thank you. Daniel.
Yes, so we all understand the problems that we currently have, like data is not fully structured and not standardized. So if we would have unlimited amount of money, so I would make a work group who would work on different tasks. First of all, we need to fix the retrospective data. We have already tons of data, petabytes of data that should be standardized and structurized. It's at 50% already standardized, I would say, and usable, but we would need to fix that. Then we need to fix the prospective data that will be collected. And then I would use money for the education, obviously, and of doctors, and from the university level, so they will understand how important it is to not just copy-paste the data, but fill it correctly in structured and standardized way. And me, myself, as a scientist and biobanker, I would say also as a futurist also in personalized medicine, or precision medicine, more correctly. And we should have a database and for the genomic and other omic data. And if there would be unlimited amount of money, again, we would sequence definitely at least genomes of every Lithuanian person, that maybe also on RNA and protein levels and other metabolomics and other omics. And if we would have this kind of database, it's obviously very expensive, but if we have unlimited amount of money, that's where I would go also.
And just very quick thing to add. So the thing is maybe why we speak about or talk about Epic, for example, and interoperability is just what we know is one of the solutions that actually integrates all the international standards in one platform. We can definitely use these and build things cheaper and in an easier way. But I think just as a reference thing, it's not as a kind of silver bullet to anything, but just more or less where example of how you can use these more standardized approaches to collecting
as a comparison,
data.
Yeah. Great. I don't know, do you have a take on that as a secondary use expert, data analysis expert?
Yeah, for the context of our guests, we at the State Data Agency were functioning as the intermediary between the hospitals and the data holders and the scientists and other public persons who want to use this data. So yeah, we spend quite a lot of time staring at the, let's say, doctors' products, at what they do right actually in the HRs. And maybe one thing that I'd like to buy is, to buy many more hours of doctors' time so that they would have, sufficient time to fill out these forms in whichever system they are provided, whether Epic or free text or whatever. Just, be able to do it thoroughly and carefully and, having in mind that somebody will use this data and it's not, only filled for now, but it's filled for posterity and for research and for other purposes.
Just for context, they're using one of the best data analytics tools in the world, Palantir, so that's why they're not that dreamy as we are.
No, I think the most important, Julius just won so many points in the face of clinicians to pay for data. That's exactly what many of us would be like to achieve. So it's really compensated the effort to put high quality data, which needed not only for me for now for encounter, but for later use. I think, Mr. Murphy, you have your comments and your advice perhaps for us.
Well, okay, first of all, I'm not the tech person or the...
even better.
Even better. My children are more tech savvy than I ever will be, but there's a few things that I've noted. One is it doesn't really matter what NGMO system you have. Rubbish in, rubbish out. So how that system is being used is going to be the key to your future use of the data. We pay a lot of money, we have the top of the range Epic system. My interns will still cut and paste from to the discharge summary. So we said, okay, we will cut that out. We will now use AI. We developed our own AI system, Russell GPT, and it will scan through the system, the patient's notes and will produce a discharge summary. But it's like any GPT. How accurate is it? Okay, it's interpreting what's been put in. It will give you certain facts, and it still requires a doctor to go through and ensure the accuracy of that data before it's sent out to the GP or before it's sent elsewhere. So, yeah, accuracy of data is key. So whatever system you're going to do or use, you need to make sure that what you're putting in is good. And then what you're taking out is also of benefit to the end users. So from our point of view, we have matched the engineers and the analysts to the clinicians. So when Peter was showing you the flow diagram of all the people involved, the academic informatics office was Professor James Yip, it was Professor Nyam Ki-yoon, and he's now Professor Erloon. So they're all clinicians, and they're the ones that lead our academic informatics office, where we sort of store all the data. We have the data lakes, you might say, are created within the informatics department. But they are the people that are leading and are the link people between people who are analyzing and using the data and the clinicians that want to know how best to treat their patients.
So in other words, we can say that it's not all about money. Right?
Certainly not, no. And in fact, you can be throwing good money after bad by producing the same poor data because you have poor information actually being put into the system.
Exactly. So I think we came to the point when money cannot solve all the complexity of this issue. And you just told an example of clinical modeling and involvement of clinicians, yes, which is a key aspect, right? Colleagues from Lithuania, what your institutional or personal perspective of the main key challenges we have today? So what you would address, top maybe 3 things, what's on top of your mind? Who wants to start, Daniel?
Again, I think that I would start from the standardization, and sometimes even if you want to standardize, different hospitals, different departments want to standardize it different way. So it's usually people, human beings, are made like they want that somebody would say what is the best for them, and that, for example, for whole Lithuania or whole world, we would use the same standard. That would be definitely easier if we would know if there is the best standard for everything. We know that there is not.
If I may evolve your topic, you are speaking not only just we need standard, it's about clinical leadership, it's about clinical consensus, right? So this is one of the problems we need to solve, at least as we do experience in Lithuania, right?
Yeah, that's true. And also I would like maybe one point, unique maybe point, that sometimes people don't want to share data, and to whom belongs this data? It's also a huge problem in some of the institutions.
Let's park this question. I have it in my list. Let's park this question. It's an important one. All right.
I would like to emphasize coordination and maybe strategic planning, because many people put the efforts and sometimes don't have a sleep at night to improve the system, to improve the quality of the data. But when we all move to a different direction, the result will be not as good. So coordination and strategic planning is very important.
Yeah, I could not agree more. Like, standards is definitely what we already have as well. That over there in other countries, we also have our own, for example, SNOMED CT vocabulary that we don't use. So we need to kind of integrate something that's already available. Of course, the fragmentation thing, which could be basically solved by some of those coordination on agreeing on how we kind of collect and share data. Because sometimes we just feel that, it's maybe data agency, but data agency is doing completely different things. Maybe it's ministry, but ministry, they're doing kind of different things. So somebody please tell us how we collect that data. So this kind of thing, and also how kind of to address the fragmentation part, which is basically I cannot access data properly from other institutions. And for me as well, is that we oversee now quite a bit of innovations developers who wants to kind of bring these remote monitoring, all these things. How can I put data from different resources, not only from my
data silos problems,
yeah, so
right?
Data silos problems, this is what we really need to solve.
I'll maybe just add a bit more about, well, my agency can't fix the things that we discussed here, like standardization or, changing hospital information systems. But we see more of the secondary use projects and the ideas for reuse. And maybe I'll be a bit more optimistic and I'll say that we could tackle many more things over there already with existing data if we focus a bit more on maybe, let's say, education or maybe better statistical practices, bringing more data science practices into the clinics so that people would be more aware of what can be done with the existing data. I don't think it's entirely hopeless. I think we can also work with a mixture of standards. We can work with partially missing data, but we do need to bring some education, some good thinking from people who are already experienced with the clinical side of it.
Fantastic. Yeah, I would like to add one wish more. So I would like that every new functionality that comes to health system would receive proper testing phase. So because we usually get not mature products, and this results in high burden of loss of effectiveness. Maybe.
So I think that relates nicely to your picture. Cheap, good, and fast, right? So we're always returning back to the same triangle. Look, I think we had a very nice link where it would be interesting to see if Lithuanian and international Singapore perspective will be different here. So we heard about coordination, right? So here comes a very natural question. How do we see the role of a central government, of a ministry? Should it be quite, let's say, legislative regulation only, passive or active actor who creates solutions, gives, I don't know, national systems or even hospital information system, or creating monopoly, or it should be totally liberal? So there are quite different perspectives here. So it would be interesting to see what colleagues think, and maybe we'll start with you.
With Singapore. Just talking about coordination and having an overview of the data. As I stated, Singapore is divided into 3 health regions. We will all be on the single system within the next couple of years. But I won't have access to the other clusters' patients' data unless that patient is sitting in front of me and I'm the clinician. So we are ring-fencing the data. We do share the data at a ministerial level. So the Ministry of Health will have the same data and we will share across there. But we're not necessarily looking at other people's data who we're not providing care to. And it would be something similar, I think, here in Lithuania, where you may have 3 university hospitals. You'll all be on the same system, but you may not necessarily be sharing all the information at local level, but you may be doing it at a ministerial level. Again, the impetus for change comes from the ministry. And to have the single system that's been financed by ministry, ultimately, it's the ministry that is financing a single technological platform across the country. There are modifications within that platform for each of the different clusters. It's not a single system use. And then again, the ministry then will have access or will be able to look across. So there is a national system that they can actually pull their data from to get the overview of what's happening for the patients. So it's ministerial-led, financed, but implemented at a local level. So the ministry doesn't implement it, that's done at the cluster level. So the regional health facilities, the cluster will implement it throughout their system. So we had one hospital had it already implemented, then went to our hospital, 3rd hospital. So we did it piecemeal. We didn't do it all in one go. And then the next cluster have completed their implementation, and then the final cluster will do theirs in about 2 years' time.
But are you implementing the same technical solution? It's just
yes, it's the same platform as regards Epic. Some of the hospitals that started earlier have a different version. In fact, their version is probably better than our version. But that's just the nature of the contracts that they had already implemented.
All right, interesting. So it's quite, let's say, a huge mandate of the ministry in terms of financing, defining the pathway, and with certain freedom to every cluster to do implementation their own way.
I mean, even if the clusters are paying for it themselves, ultimately it's coming through money from the ministry.
Allocation from ministry. Yeah. All right, that's quite interesting. Not very much, let's say, European way. As in most of EU countries, we like to have more liberal solutions. There are definitely pros and cons, but let's hear the opinions of the panel.
Maybe I will be more European. And yeah, my question comes from highest ranked officer in healthcare digital transformation, actually, Vice Minister for Digital Transformation in Healthcare. My opinion, I think our government, the first task would be facilitation of discussion and facilitation of having some consensus decisions.
Thank you very much. Can we already say that this is a good step towards that, right? Daniel?
Yeah, again, the rules can be done like there is a system and then we write a law about the system, or we write a law and then adapt system to it. So I believe that the most important part is that before we write a law or regulation, we speak, like, again, as we are here, I completely agree with Valdas also, that even if there is a written regulation, it should be sent between the other stakeholders, and you should adapt to their comments.
All right, thank you.
I think one way or another, the quite extensive national involvement is basically impossible in our setting, because we mainly public sector, publicly funded healthcare system, and we need to share and understand about our data. And what we hear all morning, that integration and kind of this public health approach is inevitable. So one way or another, Ministry of Health will need to have this oversee, we'll need to have all this data involved, also work more maybe with the data agency, because for us, we can learn about our patients, but I think it's way more interesting for Ministry of Health when they're building policies to understand, what kind of population they serve. So I think it's also more on the ministry side to decide, how they're going to get that data. And if you believe that we as provider are capable of using funds or build our own, implement our own systems, and to provide you good quality data, then okay, we can do this on our own. But if you, as kind of, I would say the last point of the last data point where the old data will be going, so this is for you to decide basically, whether you trust and whether you think that kind of national system, one national system or cluster-based system might be more feasible solution.
So to wrap it up, we can say that a strong hand in regulation, setting the rules is important, is vital. Now the task of implementation can be done in different ways, like in Singapore or more liberal, but the thing is to have rules of the game, right? So it's quite equal position for everyone, and afterwards we don't need to glue all together. All right, I want to touch one more question which Daniel was touching. Whom data belongs to? So, there is a joke that hunters are already spreading the game before killing the animal, right? So that's what we're going to do. We don't have all the data, but let's decide whom it belongs to. Patient, doctors, facilities, public good? What's Singapore's opinion on that?
Okay, so when the patient enters the hospital, they will sign consent or give implied consent that their data may be used for audit purposes. So most of the work that I do is basically audit purposes. It's based on anonymized aggregated data. We have very strong laws. So any of the data, and you saw what I had presented earlier today, if that goes missing or gets hacked or ends up in the public domain, I am personally responsible for it. Under the governance within the hospital, I've signed up to, as chief of the Valio team, that if my data goes missing on my patients or on the vast numbers of patients, then I'm personally liable, and I'm liable for a hefty fine and imprisonment. So we have those laws in place. Part of the whole data thing is security. and it's become more and more prevalent over the past few years. So we have separation in our hospitals. None of our corporate systems are linked to the internet. And that's because one of our health systems got hacked. So the next day, no internet. You can have it on your phone, you can have it on your own laptop, and there's no interconnect. You cannot connect any outside device to a corporate laptop. So we're trying to secure the data because it's all flying around the place now. And the difficulty, I think, is that there's more and more players out there who are trying to get their hands on this.
All right, but this is aspect of liability and control. But what about ownership in terms of you want to do research, or you want to sell to pharma, or anonymize and preserve patient privacy, yes, but to reuse it?
So the data, we are consented for audit purposes. Okay, we're not consented to sell to outside interests. So we will not be selling it to outside interests. Can we use it for research? Yes, but it has to go through the ethics board. So if I'm using data from this that has got patient identifiers of any sort, then that has to have patient consent, okay? And has to go through the ethics board. If I'm using the data that I tend to use, which is anonymized aggregated data, I can apply to the ethics board for a waiver and still use that data for publication, provided that no patients can be identified from it. So we have a large research program that we've developed as well from this, as well as an education program that you were talking about, that we're now in the medical schools teaching them about the use of data and the use of value-based healthcare.
But let me heat up discussion a little bit.
Okay.
So I don't believe that pharma or Google or Microsoft is not asking facilities with high-quality data who are already capturing for years, decades. Could you sell us a portion of this diabetes type 1 patient, which were very interesting for our clinical research?
Well, the simple answer is no, we cannot. Legally and morally, we are not allowed to do so.
All right. Answer is taken. Colleagues, what is your opinion on that?
The broad answer may be the data could be to European health data space. European Parliament made a decision to create European health data space spring this year. And this space will have three main pillars. It's empowerment of patients to control the data, to enable physicians or healthcare specialists to access data of the patients, and to facilitate secondary use of the data. So I think, broadly speaking, it would be great if this health data will belong to a health data space.
Thank you, Daniel.
I believe that data still belongs to the patient, to the person, and as GDPR also says, still, if I want to delete my data, I should be able to do that. But my own opinion is we should be more liberal on the data overall. We are sharing our data on social media everywhere, we are accepting cookies everywhere, but we are scared to share some more our weight or hate, Overall, sorry, I lost my mind. Oh my goodness, I'm sorry.
No problem. So in essence, you speak about having common sense, right? Not to go to the extremes.
Yeah, exactly. So data should be, we have amazing regulation, to be honest, in Lithuania. We already have, for 30 years, biomedical research regulation, so we can get data from that. And data usually is standardized and structurized because people are collecting it by hands. We also received a new regulation for biobanking in 2016. And it also allows us to get data and samples also, which are also data. So we have that, and also we have a recent regulation on secondary health data usage. So we know how can we get data with consents, we can get waivers from consents through the bioethics committee, and we can get data without consents through the secondary health data usage. And I would say that ideally we should be more liberal and open this all data. I believe that in the future, all data will be open, and if Google wants it, everybody can take it and use it for a good thing. If we will be overprotective, we know that nobody is protected enough. Even like the most military, companies are not protected enough. It's just a matter of time when the cybernetic attacks will come, and we cannot defend us enough. So maybe we should just open everything.
So we hear again a little bit of socialistic approach, not capitalistic, in that sense. Now I want to ask Antanas, as a radiologist, you have a guy from this audience who is sitting literally on a bag of money, right? Because radiology images are really something what is have a price tag, right? As a radiologist, not as an employee of innovation, etc., what is your doctor perspective on that?
On AI or on a money bag?
No. On your personal interest, right, for data ownership.
No, so I think that data ownership is what has been discussed. I think it's kind of clear that we have GDPR, so there is a patient's data. We need, in order they ask, we need to kind of protect them, all these kind of legal things. But of course, we cannot say that there is no research and we're not using it for secondary purpose. And then there are also kind of discussions now on ethical, philosophical level that kind of this medical data is also kind of common good, more or less, because based on this use of data, especially maybe not for commercial services, you can make better decisions for population management. So it's a very tricky question. I think it's also maybe just to break the myths. It's not that kind of radiology sitting there and selling images and making money. No. Yeah, so basically just, it's, if you think that the kind of radiology is very kind of profession where you can make a lot of money of these AI tools, so most of them are already created, and the market is almost kind of finishing, so now we'll need to buy the solutions. So, but I think there are two ways and two parts of the answer. So there is still patient who is owning, and we need to protect their data, but it's also important to use that data for the purposes of improving health.
Yeah, my hospital were on TV yesterday with their AI model for measuring spinal stenosis and MRI scans. So they would have used the MRI scans, again, anonymized MRI scans for LLM to train up the AI. And now they have implemented its quicker diagnosis of on imaging of spinal stenosis.
That's fantastic. We just have a couple of minutes, so before answer of Julius, what the National Data Agency thinks of that, I just want to share my disappointment, because we're like a bunch of socialists here, and usually in Western Europe, I always have at least one voice who says, no. Image diagnosis, that belongs to the patient. But all my expertise findings, that's something I created, that's my intellectual property. So I don't reveal my position, as you see, I'm just playing the devil, but indeed the discussion is ongoing here, right? And we'll definitely face it when somebody will propose a price tag for your database, right? And then you start thinking already not theoretically, but practically. So interesting times ahead. Julius, what is your final, as a National Data Agency, point here?
So as others have said, the data in Europe definitely belongs to the data subject, but we can ask what should and what shouldn't we be allowed to do with that data, with or without consent, explicit. And I think the law that we have in Lithuania, kind of figured that out quite well. We have European health data space. We have it, 3 years ahead of the European Union. And we can, in most cases, use patients' data for, let's say, public good. Whether it is public good that comes from public institutions using that data, or whether it comes from the private sector that uses that data, we can use it, and we can use it, quite cheaply, let's put it this way. It's not a thing to be sold to the highest bidder. And I think that's a sensible solution, because if we did it another way around, how should we allocate the benefits? If one company develops a solution based on some patients' data, should those patients get exclusive rights to that solution? Should that hospital, which contributed to it, get exclusive rights to that solution? So if we don't want to go into that swamp, we should say, have a blanket permission to say, if it's public good, we can do it.
Thank you very much.
One more thing about the liberalization of everything, and if big companies are coming and they want data, and if, for example, in the European Union we are not allowed or it's harder to get those companies will still get this data from China or other countries. And it's not only bad that the money will go to China, it's not only bad that China will, like other countries, will first get this product, but it also will be adapted to their population. And we know that populations are different. We have different predispositions to different diseases. And sometimes if they will like have a cohort of one population, it won't be the same for the European population. So there is different, many bad levels.
Absolutely right. Thank you for this wonderful discussion. Maybe we have 2 minutes and any questions from the audience? If any.
Thank you. I am Maria Chaplinskina from Forensic State Medicine Center, and my question is for Vice Minister. I would like and we wish that you will put legal and forensic medicine data as well to your plans, because it's so important. Because we are in the same health system, and some investigation that we are doing in our center, it's not belong only to forensic or legal medicine. So it's more than 50% of our cases that we have investigated, we do autopsy cases. It's clinical cases, like medical malpractice and negligence and diagnostics of some cases that not performed during the clinical care system. So if you put this to your plans, so it will be great. Thank you.
Thank you very much. We must admit that certain fields of forensic or work medicine or other blind spots do exist. And here we need to continue discussion. So what I propose to elaborate the subject where and when we can add to that. Any other questions? If there are no questions, I will finalize it from my side and then ask others to finalize from your side. I have one question to the audience. I see many clinicians here, and I do have a question. You can answer now or during coffee break afterwards. When we speak about all that investment in data quality, which we were speaking, sometimes I get remarks that, you know, in terms of my patient treatment for my encounter, I don't need that really. I'm quite okay with some textual, you know, some scribble, which I do understand. And this data entry takes a lot of effort. It's a lot of effort for, yes, for good, etc. But I'm pressed. I don't have time. I don't have vitality for that. So sometimes I'm really interested, you know, in this feedback of reality, right? We speak like very good things, but sometimes maybe system pushes us another way. So if anybody is brave, please raise your hand. If not brave, then I expected so.
Okay, thank you. I'm Lanas Gushevicius, I'm a hematologist. And when you say about data quality, human people, doctors, physicians, nurses are entering that. And you want a standardized data entered by standardization for me and another person, and throughout the field, medical field is completely different. So you expect it standardized in your system according to rules that you create, but we will not be applying. We still are analog people. So how do you solve that? How do you solve that myself, Valdas, enters the same diagnosis, metadata on the same diagnosis in the same way?
I'll do a political trick. I'll ask Valdas to help me answer.
No. It's the same questions from me.
Well, good. Thank you, guys. So for the audience, we did have started this discussion, not today, obviously. And the beauty of this question that it doesn't have a straight answer, right? So we understand that this is a discussion going on. So basically, what is the practical aspect here? Practical aspect is that every standard application has its limitations, and there should be agreement in each field. I liked, I think it was your example, or anyway from Singapore, that we took about telemedicine, or Peter's, we took every specialty to agree what services can be provided using telemedicine, right? Not MOH, we're sitting in a room and deciding for endocrinologists, neurologists, etc. So with standardization, I think we have now a very beautiful example. When we have these clusters, neurologists, oncologists, cardiologists sitting together and trying to decide on KPIs, simple thing, even before standard. And we see it's sometimes impossible to agree because there are different schools of thought. And standard doesn't help here. It gives you guidance. So when we speak about clinical modeling, what Catalonia is doing now for 3 years, London is starting doing for a couple of years, Brazil is doing like 10 years, and other countries. When clinicians gather around hematologists and agree on clinical standards, at least for one country. So you can put this process, you can put it as a working group, you can put it as employed people, as an agency, but it's a process. There is no simple way or central way to decide it. I don't know if you accept my question, but this is the best I have.
Are you going to fund that? Are you going to fund that?
You're going to fund.
Me personally.
You need people to sit and spend the hour and agree on something. They also have to attend patients.
So now, yes, yes. Luckily I have positive answer because otherwise I would look really ashamed, right? So the good answer, that one of the first things I did, I put certain provision of amounts of EU money of IT project for clinical modeling. So this means that it's not free of charge exercise which doctors need to do after clinical practice. They can be employed and work. If it's enough, no at all. So in Catalonia, they employed 60 clinicians for initial phase. Now they have 6 and they want to have 10 clinical modelers full-time. We don't have these resources today at MOH. We don't have these resources at register centers, but we're going there. So what could be done with this financing period, we did it, and we have a kickstart, how budgeting and operation will go. We have here Director of National Insurance Fund. He's very active in these discussions, and I'm extremely happy that no, I'm not going to ask if you give money, that's okay. The idea was a little bit different, that we started this discussion that it's not separate topic of IT guys. This is all our topic, including payment.
In Singapore, we are very, we do what the government tells us. So if the government says we meet, we meet. What we tend to do, though, is for consensus, that there would be a provisional sort of ideas as regards what might be the standards. And these will be circulated to the different departments, say all hematology, for the different hospitals in the country. And then they would send their individual doctor to the meeting, where they will work out the final standardization for that particular condition. And then that would be what's used. But the person coming from the department has to have the voice of that department. In other words, they can't go back and everyone else say, we're not going to do that. So once it's decided at a national level, that's it. Everyone just follows same.
But Dr. Murphy, am I right that you have a system like in Commonwealth countries? You have a consultant for specialty, you have a chief, main authority, official authority for specialty, right?
Yeah, so we'll have a head of department and then you'll have all the other doctors working under that.
But on national level as well?
At national level, we have DMS who's in charge of the overall health system, but we don't have specific doctors that report directly for their specialty to the ministry. So what tends to happen is that the ministry will ask the hospitals to send for a representative, and it tends to be the heads of department or a senior doctor that will go. Yeah.
All right, thank you. Any comments? Any objections, I hope? So, ladies and gentlemen, thank you very much.
Thank you.
have a surprise for you. We will not have any coffee break. So you might have bio break, but it should be quite short one. And we directly go to the third panel, which is dedicated for the innovations. And not much left, only full speakers, full presentations, and then we go to the panel discussions with very, very interesting people. So we do have the online guest from Singapore. Can we get him on a screen? Is Nguyen Ki Huan from National University Health System in Singapore. Hello. So he will speak.
Hi, can you hear me?
Yeah, thank you. He will speak about implementing generative AI in clinical practice. So sorry for us for being a bit late. So now stage is yours.
Thank you very much. And thank you for the opportunity to share some of the work that we have done here in NUHS in Singapore. So we have my colleague, Dr. Duomenů, who was shared earlier on the value-driven outcomes, and I will be sharing about large language models. So all of you would have heard of large language models in the past 3 years with the introduction of ChatGPT since November 2022. And many industries have gone to adopt language models as part of their operating workflow and operating systems. So healthcare is likewise the same. First thing I want to say is that language models are a technology that no industry can ignore, not least the healthcare industry. So it is, in this chart, as you can see here, is the most quickly adopted technology in the history of mankind, right? So this is ChatGPT took 2 months to reach 100 million users, what took Google Translate 78 months. And to give you a sense of something that is more practical, right? The fridge took 7 to 8 years before it reached popular acceptance around the world. So that gives you a sense of how important this technology is, and it will start to affect, if it hasn't already affected, every aspect of our life. So whilst it's very transformational, we have also to be aware and to address the issues that come with the use of large language models, especially in healthcare. So there are 4 issues that are very important when we consider the use of large language models. That is the privacy concerns, the legal concerns, inaccuracies that may be generated by the model, as well as specifically what we call hallucinations, which is made up content that the model can generate. So just to very quickly address some of these points and how some potential solutions may exist. So the issue of privacy is really about not allowing private information to be used or processed by a large language model. I think this is an issue that can be addressed at the level of the institution or at the level of a country. So to give an example, in healthcare, we could not send identifiable information for processing by commercial large language models, precisely because the data will be sent outside of the country. So there are many ways to solve this problem. One way is to redact or remove this identifiable data, either manually or using some form of software, like data loss protection software. However, these methods are often laborious and they cause the models not to work efficiently. The other way, of course, is to have your own language model, either the commercial models being available in the country or using open source models such as Llama models that are provided by Meta. So there are ways to address privacy concerns. It comes down to the use case as well as the country prevailing laws in the country to solve these problems. Now, in regards to the legal issue, it's really centered around copyright. So there have been a number of provisional rulings surrounding the use of content that's generated by large language models. So I think in general, the agreement is that the content that's generated by the language model belongs to the human that initiated that content, but they must claim, they must acknowledge the use of a language model in generating such content. So the issue of copyright is going to be closely watched and closely fought over in the next few years, especially when it comes to creative content. So I think, at least in the healthcare space, perhaps the creative content generation is not yet as prominent, but it's something that is worth looking out for in the next few years. On inaccuracy, I think it's important to apply methods that we already know to reduce inaccuracies, such as using prompt methods to limit the content that is being used, or using something like an RAG or retrieval augmented generation to ensure that we only uses content from a specific corpus. Despite these technologies, it is not foolproof that the content that is generated is accurate, because precisely because the underlying language models were trained on global information and general information, right? So until we have more accurate or precise underlying models, then we might address this issue of inaccuracy. And finally, hallucination is something that is a unique characteristic of large language models, precisely because of its generative nature, and it can generate any kind of content, including false references and so on and so forth. This is not to be taken as a negative attribute of the large language model, because it is the way it's engineered to perform. Instead, it can be used in the context of generating novel content. I think that's really positive. But in the area of healthcare, where the requirement is for precision, then hallucination becomes a problem that we need to mitigate using a variety of methods. But none of these methods today are foolproof in terms of preventing hallucination. So in terms of strength of large language models, I think there are some of these things that I mentioned earlier. They can be trained, especially the open source models, on fine-tuning. Smaller models can be trained for more precise tasks, and it's possible to use prompting interfaces to define tasks for large language models. So you can use natural language to be able to instruct it to do specific things, right? So multiple capabilities are already present within language models, including reasoning capabilities, which is quite surprising and really quite innovative when it comes to its ability to reason specific tasks. However, there are many weaknesses of LLMs. I've already pointed out a number of them, and I just want to draw our attention to the last item here, which is the risk of abuse of its capabilities. So as with any technology, it can be used for good and bad. And I think much of the media representation of AI surrounds the risks and the downsides of what AI can do. But let's be very clear, many of these risks are driven by humans. And you can imagine that hackers today are using generative models to come up with more potent malware, for example. So that's an example of abuse of these capabilities. So I think worldwide as a community, we have to find a way to reduce or limit the risk of abuse of its capabilities. And this can be controlled through central companies who have central control over their commercial models to limit the use of such, or rather the abuse of such capabilities. So one often question they ask is, can ChatGPT replace doctors? So in this particular case, GPT-4. So I asked GPT-4 this question over half a year ago, and this is the response it gave. So this is very typical of a GPT-4 response, which it provides specific lists of things that it can do, and you will always have a qualifying statement to say, well, GPT can do all these things like, process vast amount of data, rapid diagnosis, 24/7, and availability and consistency. It is not able to replace the medical profession, and it's absolutely right. And we put this to the test. We made it answer a simple scenario-based MCQ question. It got the answer correct. In fact, it got the answer right hundreds of times. In fact, 100% of the questions that were asked, it got the MCQ question right. However, when it comes to the reasoning ability of this tool, it gets some of the things wrong. Like, for example, in this particular case, where the patient young patient has acute appendicitis, it says here that the lack of respiratory symptoms or lung findings makes option C, which is constipation, and E, which is right lower lobe pneumonia, which is correct. But option C does not make sense at all, right? In terms, because constipation has got nothing to do with respiratory symptoms in this particular case. So it's still not ready. It does make up some of these content. So if you are not a domain area specialist, you may take this as fact and interpret this answer wrongly. So what we've done in NUHS is to sort of combine a few of these language models to build our own customized generative pre-trained model or GPT model called Russell GPT. And what is it is that it is a combination of more than one model and fine-tuned GPT specific for healthcare. It aims to address the problem of security. So first thing is that privacy is ensured by the fact that the model is based in Singapore and the data is not sent outside of Singapore, and it's secured in the very, so it's at the national level of security where we prevent people from hacking into it. And this is secured centrally and not distributed in a distributed manner. We also use a number of other frameworks to ensure that the generated content is and the prompts are fully owned and tested by the developers. So this ensures that there's a certain level of quality when it comes to generating precise healthcare material. And we use a routing service. This is built on the AWS Kendra kind of service to route questions to the appropriate large language models. And it's held within our secured data centers to ensure that this system is not cannot be hacked from the outside. So to make some of these things possible, we have on-premise supercomputer that's made out of 5 of DGX and A100 GPUs. So this gives us the ability to fine-tune large language models and give us the performance that we desire when it comes to the accuracy and outputs that's produced by language models. So this is how the production LLM architecture looks like. I just want to draw your attention to this middle blue box here. So this is the heart of what Russell GPT is. It is a routing service. So it's able to route the queries from different incoming questions or sources to the correct RAG corpus and return the correct response to the patient or to the doctor. So for example, we have a patient-facing bot as well as a doctor-facing chatbot. So a patient, for example, can ask a question about, say, asthma, and this routing tool that we have will then route this question by adding a prefix called explain in layman terms the management of asthma, retrieve the correct content from the pediatric corpus, and then return the output back to the user by saying something like, oh, childhood asthma is really common, the typical triggers are this, and the treatments are so and so forth. Whereas if a junior doctor asks a question about what is the latest treatment guidelines for managing pediatric asthma, again, you will enter into the routing service, but this time around, it will return an evidence-based answer to the doctor, something along the lines of, according to the latest guidelines in Singapore, this is the current standards of treating asthma, for example. Then on the left here, we are already using this in production. All of this is done already currently being used throughout our healthcare cluster. We are using the secure English language task capabilities such as summarization, referral letter writing, and so on and so forth, and transcription. But really, we have achieved this state from about a couple of months ago. We launched this in March this year, and we have learned a lot about how language models work. Like, for example, we learned that users don't always appreciate some of these capabilities that are available to language models for a variety of reasons. And we have to spend some time understanding our users' requirement before we modify or alter the language models to suit the user's needs. Ultimately, we want to achieve the state that's on the bottom left here, which is we want to have event-driven language models, meaning that the language models will auto-process and pre-process all the usual hospital-level tasks before the event happens. So for example, in running a clinic, it's able to pre-clerk the patient, i.e. by taking past notes and extracting the correct information from the doctor for the doctor before it's presented to the doctor. So these are all capabilities that we are currently building, and hopefully we can roll them out in the coming year. So one of the key questions and something that have been discussed in the panel earlier is about safety and privacy. So there are a number of guardrails and compliances. So we are of course compliant to any of the Ministry of Health or the government's guidance on this large language models. We also have our own generative AI policies for internal users, as well as highlighting the strategic long-term view of how we want to ensure safety in the generative AI space. And all this is in compliance with the existing or prevailing cybersecurity measures of our IT systems. So just to show some use cases, we use currently primary and secondary capabilities of large language models such as the English language tasks like transcription, question answering, summarization, referrals. We also use the chatbot capabilities of the language model. Now, the secondary capabilities include reasoning, problem solving, learning on multi-domain tasks, so what I call agentic type use cases. And then we are going towards what I call tertiary capabilities, being able to creatively solve problems autonomously without needing prompting from humans in terms of complex tasks. So this is a very early version of our language model. So this is a diagnosis tool that can read the doctor's note and generate, or give a diagnosis suggestion, right, to the patient, to the doctor. So this is then seen by the doctor, and they can make a judgment. Again, it's still down to the doctor. It's not fully autonomous. The doctor needs to make a judgment on the diagnosis. And this final diagnosis, when the patient is discharged, is captured and is used as the basis to retrain the model. So this is the kind of output that you expect to see. So specific prediction of the risk, as well as specific words that are related to that prediction for that diagnosis. We have extended that capability, the same language model that I just shown earlier, to estimate length of stay. So what is estimated length of stay? So it is a free text tool that it reads the doctor's note, and based on its training with over 260,000 historic records, it is able to predict how long the patient is going to stay in the hospital on day one of admission for all diagnoses. So this is not specific to a diagnosis. This is for all diagnoses that are presenting to the hospital. So as I mentioned earlier, there are different already use cases for the clinical efficiency, so things like summarization, referral, and so on and so forth. We also have efforts to curate and build AI tumor boards. So AI tumor boards give us the ability to standardize the way we run tumor boards. We also use it for our mortality and morbidity rounds. So hopefully we can capture past learning points and use that as the basis for future suggestions when it comes to morbidity and mortality cases. Other use cases include pre-rounding. That means reading the note before the doctors go on their round in the morning for their patients. So we also use language models in education. So this is a board here. You can see here the use of large language models tuned with Socratic methods for medical students learning. So we ran a small randomized trial to show that a large language model trained on medical knowledge improves medical students' education outcomes compared to just using the clinical notes. So this is significant because it's the first time we have incorporated our medical teaching content into a large language model and shown that it is superior to just reading the notes themselves. So this is a Telegram interface that we use to interact with our students. So it will generate a vignette, and then the students are expected to answer a question. And the one feature of this particular board is that it's adaptive in nature. So it has adaptive questioning, meaning that if a student is able to answer a simple question, it will increase the difficulty of the question and continue to do so until they reach a difficult level of questioning. And conversely, if the student is doing poorly and is not answering questions, you will then reduce the difficulty of the questions according to the student's ability. If we can use it in clinical and in education, certainly we can use it in administrative track. So this is again deployed now in our multiple administrative use cases, from operations, task filling, form filling, finance, data analytics, call center, CRM integration, as well as medical legal, to write better summaries for our complaint cases. Yeah. So some of the other administrative use cases instead, such as long stay analyzer, writing assistance, contract writing assistance, HR assistance, writing minutes of the meetings, and so on and so forth. So to the patient, this is already implemented. We have language models that can have conversations like this with patients based on content that was trained. Now, I must concede that this is extremely difficult because we needed to ensure that the content that is returned to the patient is indeed accurate and not have any hallucination. So this required a lot of testing for this to work properly. So finally, language models are also used in the research domain, where we are, for example, we have an effort to train a foundational model specifically for healthcare. We use language models to search out inclusion and exclusion criteria for patients for clinical trials, and as well as many other research domains in the proteomic and genomic spaces. So finally, I just want to share with you that we are interested not just in language, but we wanted to look at models that can model genomics, images, as well as voxels. Voxels meaning three-dimensional objects. So these are all part of a program that we call an LXM program, where we want to include different models into one or multiple models that allow us to derive what we call emergent capabilities for our LXM program. So if I may just conclude at this point to say that I think language models are going to be integral to every industry, and especially in healthcare. We have developed a specific model called Russell GPT to help with that. And going forward, we would like to improve it to a point where it can serve as an accurate model for many of the healthcare use cases, and hopefully without any of the downsides that we have in using language models. Thank you very much for your attention.
And we will have more time just to interact with our patients. Do we have any question in the audience? No. Okay, so thanks once again, and we can move forward. And now I would like to invite Professor Yamamoto. And Professor Yamamoto is Executive Director of the Hoku University and the Hoku Medical Megabank Organization from Japan. Thank you.
First of all, I really thank the organizer for this opportunity. And I came here for the first time. And excuse me, can I use Command L for laser pointer?
For laser pointer?
No, laser pointer. No, you need to go to this screen, slideshow, and Command L. Oh, full screen, please. Okay, Command L. Oh, is that? Oh, no. Okay, sorry. That's fine. Thank you. Thank you very much, Thomas. Thank you very much. And this is my first opportunity, but your previous the minister Darkis and the ambassador the Zakas visited us this spring, and also many of these great scientists in this room. I can't specify the name, but of course you can specify the name. All right. So these delegates from the Lithuania visited us, and we've explained how we recruited the cohort, and also the genome cohort, and also we explained and shows how we stored more than 5 million samples within our biobank. So this afternoon, next minutes, I'm going to present our Tohoku Medical Megabank, a biobank, which is really modern idea, and it may be interesting for you. So the story begins at the Great Eastern Earthquake and Tsunami in Japan, and that is March 11, 2011. And this was really a tough one. So tsunami attacked devastatingly at the northeast coast of Japan, and our university, Tohoku University, Sendai, just like there, and the closest university to the epicenter. So the numbers of the dead and missing persons around our university area is 18,000, more than 18,000. And emergency support, we send many young doctors to the coastal area to support the hospital. But at that moment, I was a dean of the School of Medicine. You can identify in the middle. I'm smiling, yeah. And at the faculty meeting, almost 2 weeks after, so we survived. So no food, no gas, no electricity. Anyway, we survived, and our patients survived. So we get together at the faculty meeting and discussed, and we wish to create an attractive center of innovation leading to the fast-track recovery of this area. So we've discussed, and we wish to deliver the most advanced medicine to the people who suffered from earthquake and tsunami. And we believe the most advanced medicine is the personalized medicine and healthcare. So we decided to make a biobank. So what we wanted to work on is a genome cohorts, genome cohort and the integrated biobank, which I'm going to explain, leading to the personal medicine and the healthcare. And what we want to work on is attract the healthy people, general population, healthy people in the tsunami suffered area, and various data collection at the baseline. Then follow up. This is very important, follow up for a long time, and collect the samples, information in the integrated biobank. So the cohort studies with genome analysis are referred to as genome cohorts. So our base is genome cohort, and genome cohort studies and the integrated biobank are necessary to approach common disease. So common disease, which is the causes caused by the interplay between genetic and environmental factors. So we decided to make 2 cohorts strategically, and one is community-based cohort. This is general people in the tsunami suffered area, and we recruited 84,000 people. As you see, the pink shirts is our genome medical research coordinator. So they are recruiting the general people. And another one is a birth and 3-generation cohort. In this case, we first recruited the pregnant lady in the OB hospital. So in our province, almost 2.5 million people living, just the size of the Lithuania, and almost 50 OB hospitals or clinic all affiliated to our university. So we asked the one room in the OB clinic and recruited the pregnant ladies, pregnant mothers. Then baby will come for sure. And sometimes twins. So the number of the babies, we call this kid megabank kids, and in short, mega kids. Okay, mega kids are the 23,000, and the elder sister or elder brother will come anyway. The mother will bring them. So we recruited the elder brother sister, and originally we planned to recruit 20,000 pregnant mother, assuming 10,000 husband or partner will join us. As you see, the Japanese husband are hopeless. This is a joke, so please laugh. Okay. We expanded 10% of the recruit of the pregnant mother. Still, never goes to 10,000. The reason this husband is important is we try to analyze the trio. We try to make the trio analysis, and the number of the trios restricted by the partners number. So our goal of the 10,000 trios can't make at this point. All right. Anyway, we've recruited 73,000 total in this birth and three generations, grandpa, grandma. So birth and three generation cohort. As you may know, the NIH started the National Children's Program almost at the same timing, but they couldn't recruit, so they failed. And the London MRC started the massive London UK baby study. Also, they couldn't recruit. So this is the only one large-scale birth and three generation cohort. The reason of our success will be answered if you asked me sometime in the coffee break, okay? So, upon establishing the Togo Medical Megabank, we considered the following things. One is sharing both data and samples are important. Not only sample, biobank sample, but also data is important for the modern biobank serving publicly to the society. So we are declared we are public biobank, not the private biobank or the serving for the only big pharmaceutical companies or so. We are public biobank. And the integrated biobank should be established. Integrated biobank should be established, which equips analytical center actively determining genomics big data in-house. This is the one big difference of us, okay? And the genome data alone cannot provide sufficient information toward the realization of personal healthcare and genome medicine. So we are thinking like this way. The Medical Megabank, TMM, decided to conduct extensive follow-up survey to acquire elaborate longitudinal health-related data. So follow-up is important. And also conduct large-scale genomics analysis in-house. This is we decided to go like this way. So genome data accompanied with abundant real-world data plus omics big data are precious in modern biobank. Not only determining the whole genome sequence, the computing the number or size of the whole genome sequencing, we are not going that direction, okay? So follow-up is important. In this area, a little bit smaller than, much smaller than Lithuania, but almost 2.5 million people living. And we set up 7 community support centers. And there we are working on the follow-up survey. So various physiological examinations and another the questionnaires. And these are we asked our participants 157,000 participants we asked to come every 5 years to hear. Of course, not everybody come, as you know. So in our biobank, we collected blood and also the urine, oral plaque, saliva, and from the pregnant mom, we asked them to give us some breast milk also. And the lifestyle information questionnaires, this is very detailed, and also physical examinations and oral, examination, dental examinations here, and also the follow-up survey. We have a strong informed consent to work on the follow-up survey, also genome and omics analysis. We are also taking the MRI, magnetic resonance imaging. But this takes another day of our participants, so we asked the volunteer, and 12,000 volunteers agreed to come. And MRI data, the individual difference is very big. So we decided to go longitudinal way, repeated imaging, the second stage, and right now we are working on the third stage. So the same person taking the aging effect, okay? And for this, the MRI, one big reason is we really want to address the dementia. So the physiological, the psychological examination or cognition examinations accompanied with this. And please see this demographic data. Usually, cohort study, the senile people, they are keen to the health issues. So senile people are predominant. But in our case, because of the birth and regeneration cohort, 30s, in the 30s and 40s also participate quite a lot. So we can take the relatively young generations data, okay? And one extra things, we call this one linkage. So in Japan, we have many public data, like the maternal and child health handbook. This is a really unique handbook. Mothers, all the mothers in Japan are writing this when they are pregnant. So this one, the medical prescription data, which is the payment, the health insurance payment data, and all these data we are getting and integrating in our biobank. So, as I told you, we decided to be the integrated biobank. We decided to establish integrated biobank, which is a biobank equipped with large-scale genomics analytical center. We're going to do in-house, and it consists of biospecimens and genomics data linked to the health and clinical information of our cohort participants. So we collected more than 5 million samples and stored. Some of you see that our storage, and also the 30 petabyte information, 30 petabyte, which is the large size is whole genome sequence data, but other imaging data, and so on. And the most recent ISO or biobank, ISO 387, we've been certified by this biobank ISO. The previous speaker discussed about the AI study. But as you know, the AI, if we feed the quality information, they will become smart. But we do not feed the quality information, they will be very stupid, as you know. And our biobank, we are taking the data in-house, means large scale, good quality data coming to us. 500 in one hospital, 500 in the other research institute. Then the standard operation protocol, SOP different. then you can't feed such data easily to AI. This is what we are working on. Then we made the database Talk Medical Megabank, DBTMM. This is an integrated database. And in our case, we have a cohort data, which is real-world data. And also we have an analytical center data, which is the big data. And the big data and the real-world data should be combined and can be seen at once through the portal site, which is the DBTMM. Sometimes I'm claiming like this way, our DBTMM is much better than Amazon. Well, please laugh. Anyway, the Talk Medical Megabank integrated database, DBTMM, for everybody's use. So our client users can use the questionnaire. The main part is the lifestyle, and sometimes the disaster information, and also the detailed biochemical physiological examinations and the cognitive psychological assessment, MRI plus dental assessment. The cell resource, we've been making the motorized cells from some of our participants. Right now, more than 5,500 EB virus transformed B lymphocyte, LCL, and also the stimulated T cell, IL-2 stimulated T cell. And also from whole blood and the urine, metabolome proteome, and genomic DNA, RNA, genome, transcriptome, plus metagenome and the epigenome, which is we are challenging. And these data are all incorporated into the site, the Japanese multi-omics reference panel site called JMOB. Here's the address. Please visit. English version is available, and you'll enjoy. You can play around one day long. Now, why we are examining cohort scale genome data, this is an important point. And I'm thinking like this way. So the genome is quite flexible, and you have a base substitution. Some people have a base substitution or base deletion. So the minor base changes generate difference of individuals. This is the reasons, and this difference makes the disease susceptibility or resilience. These are attributable to the difference of the genome sequence. So that's the reason why we challenge the genome sequence analysis. And in 2013-14, when we started the project, we've challenged the whole genome sequence of our participants. And at that moment, the machine, next generation sequencer is just like the Stone Age machine compared to the current one. So only one person, one day, a machine. So one machine can determine all 200, at best 200 in a year. Anyway, we've determined 1,000 and published in that paper, the Nature Communication paper. Then Craig Venter read our paper, and he praised us in his paper. Ours is the most good quality for genome sequence data at that moment. Anyway, and also we made then every year we are doing, and the machine is getting better. So last year we finished 69,000, and also we finished the microarray analysis of all our participants. Then this past April, we finished 100,000 whole genome sequencing, and the data will be soon, or will be open soon. And this 69,000, we exclude the relatives. So the 54,000 individuals, and we made the whole genome sequence reference panel. This is the reference panel is the information about the position and also frequency of the SNVs. And this panel is available from all over the world, as you see here. This is the upper one is all over the world. So Europeans on the top, and Africans on down, and Asians around there. So as you see, Japanese, among the Asians, Japanese are quite unique ethnic, and not much overlap. The Korean, Beijing Chinese, Southern Chinese, and Vietnamese, well, we have a hybrid, but totally different. This means genome medicine should be performed based on the ethnic specific whole genome sequence data. The reference panel should be ethnic specific. So this reference panel is valuable for clinical sequence operation. If you find the disease kit, only the trio sequence, mother, father, the proband sequence is not enough. You can't find the causative mutation. Huge, large-scale general population needs as a control. And also the drug development. Because of the time constraint, I can't explain all this drug development stuff today. And also the personalized healthcare and medicine. So the prospective cohort and the whole genome sequence come of age, and all the people, the advanced or such countries are challenging this. Importance of whole genome sequence analysis of prospective, not patient, prospective cohort studies have been widely recognized. So here, I just show the representative one. We've been benchmarking the UK Biobank, and also all of us USA, huge number. We are 100,000, and Singapore, precise, will come maybe next year, 100,000. But the number itself is important, but the difference is in here. So the UK Biobank, 500,000 of whole genome sequence, and they have a very detailed baseline study. But because of 500,000, they can't do the follow-up. So essentially no follow-up in the UK Biobank. All of us, USA, NIH, they are actively following up, but they didn't do the strong, detailed baseline study or the follow-up examinations. So this is only the e-consent, electronic health record, and the smartphone information. While we're doing the quite the abundant, quite intimate the baseline analysis, follow-up analysis, and taking data. So that's a difference of the style. So challenge of Tokyo Medical Megabank. For the first time in Japan, one of the first in the world, we've been challenging. We don't have time to, I don't have time to explain you all of them down. The establishment of the data visiting system we've been constructed, that is quite unique, and we are not working on the data sharing. We are working on the data visiting. So everybody visit us. Data is only in our supercomputer. Nobody can download our data. Well, the reference genome sequence data, I really want to show you how we made the reference sequence, not the panel, okay, sequence, but don't have time. So return of genomic results, I will explain you this this afternoon. So I've been saying the cohort study participant, whole genome sequence, and such integrated biobank, external researchers. So this is only emphasizing the research, the service to the research world. But I feel like we can use this data for our participant and eventually for the general society people. So pathologic variant carriers of actionable hereditary diseases. We are going to return this one. return of genomic result, ROGR, to medical institute, and the genetic risk, such and such, we've been working on this direction. So we've been working whole genome sequencing and made the reference panel, which is important. And also, we can work on the genetic risk of a monogenic sequence variant, which I'm going to explain you. But another approach, so two approaches. Another approach is ethnic-specific microarray and genotype imputation. Using the computer, we can expand the microarray data utilizing the reference panel. And the genome-wide association study plus polygenic risk score. This approach, low cost, and covers many people, showing the polygenic risk score, moderate risk. So this one is also important, especially for the lower or middle income countries, like the Asian, the Southeast Asia, Asian countries. I really want to, help them this model. Anyway, we've conducted a series of return of the genetic result, and first we challenged hypercholesterolemia, familiar, because these people know that already they have high cholesterol value, so we returned them. When we finished 3,500 whole genome sequence, we started this return. Then the pilot study too, we returned the pharmacogenomics, and when we finished almost 5,000, the pharmacogenomics, and better not to take this drug. You have a gene mutation, so not to take this drug, that type of the. And finally, study 3, hereditary breast and ovarian cancers, HBOC. So the HBOC, when we finished 8,000, we started to return this one, and we selected only 6 participants because we are really anxious about returning this result to the people. This is not the patient, this is ordinary people, and we've returned the genetic risk. Anyway, then finally, when we finished 50,000 whole genome sequencing, we challenged HBOC, hereditary breast and ovarian cancers, and Lynch syndrome, colon cancer. HBOC, of course, you know the case of Angelina Jolie. Angelina Jolie removed the breast and the ovary because of this genetic risk. Why not our participant? So the number of participants, of course, more than 200 pathologic variants, but almost 60% of the participants said, yes, I want to know. But the rest of the participants told us they do not want to know. So the right do not want to know should be appreciated. So we returned 111 HBOC and Lynch syndrome. So our talk, Medical Megabank project, genome sequencing, we really want to contribute to the implementation of genetic risk to the society. So actionable monogenic hereditary disease, and we are now preparing returning the polygenic risk score for lifestyle-related disease. And those are general population outside of the cohort participant. Why not we can do this? Social implementation is our goal. So one dream, our future model. Okay, this is a future model, not now. Future model is in the clinic, the voluntary health checkup, genetic counseling, and taking a strong consent, informed consent. Then genetic test, either whole genome sequence or the microarray-based one, and return of genetic result. And of course, monogenic one, we can return only handful one. But of course, there are many. So every year, we want to expand this and continuous update. So the last slide, 2 slides now. health in a longevity society. What do you think? In my organization, there are my colleagues working with ovarian cancer in the cancer treatment. So what I'm thinking is personalized prevention, early diagnosis, early intervention therapy is very important. So knowing genetic risk and the challenge to the healthy longevity, this is the goal we are pursuing in the modern society, modern advanced society. So summary, we have established Tokyo Medical Megabank to realize personalized healthcare and medicine. We set up 2 cohorts strategically, COM cohort and battery cohort. We have established the integrated biobank and are conducting the genomics analysis in-house. And Tokyo Medical Megabank is contributing to the development of data visiting system and integrated database, DBTMM. TMM works toward the realization of personalized healthcare and genomic medicine. So almost 320 people working with us, and this year, more than 12 years, they do not dump me. Much better than my girlfriend, our previous girlfriend. So anyway, these people working together. And thank you very much.
So many thanks, Professor Yamamoto, and we leave questions for the discussion part. So I'd like to, so later when we'll sit here, so we'll keep for the discussion. All right, so let's move forward, and I would like to invite Professor Laimonas Griškevičius, Head of Hematology, Oncology and Transfusion Center in Vilnius University Hospital, and the speech about the advanced therapies.
Yes, correct. It's not here, it's on the desktop.
I put it here.
Okay. Not showing. Not used to Microsoft machines.
Let me try.
Yeah, let's try, but I don't know. Okay, you almost successful. Okay.
Ar palikti šitą, ar padaryti pilną vaizdą?
Man reikia, man tas pats iš esmės. Sekundę, aš pasidarysiu. Okay. I would like to thank the organizers for the opportunity to present some of our work, and I would like to switch gears and talk about advanced therapies. Just a few words, a reminder. Advanced therapies deal with cells and tissues and modified cells and tissues as medications, as drugs that are that are used to treat many various diseases. And by far, CAR T cell therapy that is shown on your right-hand side are by far the most commonly used advanced therapies, especially in hematology, in treatment of lymphomas and leukemias. And briefly, how those drugs are produced. We take the immune cells from the patient. We take those immune cells to the lab. They are gene modified to recognize the tumor, and then they are brought back to the clinic and infused in the patient. And then what happens? There you see a small cartoon. The T cells are in green and the cancer cells in red, so they attack the cancer cells. These are the living cells. So this treatment has been a breakthrough. This is a very famous patient, at least in our field. This patient was dying from acute leukemia now 12 years ago, and was the first patient to be infused with CAR T cells in a phase 1 clinical trial, and now she's a survivor without any further therapy for 12 years, and serves as a role model of transformational advanced therapy CAR T cells. So, of course, many drugs
commercially available drugs followed. These are at least 6 drugs that are approved by in the European Union. So it seems that those advanced therapies should be available to each and everyone. However, a very recent study from the Spanish group that was just published in 2024 showed that the availability of advanced CAR T-cell therapies is not that good. In red, you see the countries that do not have these CAR T-cells or commercial drugs accessible, and in green, accessible. And you see there is a clear disconnect. Bigger countries with stronger economies do have access, and it's a clear difference from the smaller countries where there is essentially no access to commercial medications. So this is one of the reasons. The price tag is 300,000 euro per treatment. And that was very expensive when it was introduced. Nowadays we have even more expensive medication, but this is only part of the story. This is the pathway to have this treatment done. As you can see, first of all, there is a qualification period for any hospital from pharma industry to have those cells available in your hospital. So 6 drugs, 6 qualifications. But after that, when you have a patient who needs the treatment, you have to plan it. And the problem is there, again, in the centralized manufacturing. You have to manage the logistics, have the slot allocated for the production of that specific, for the CAR Ts for that specific patient, because those are produced for each specific patient, their own immune cells that are gene modified. And then after you have all this logistics done, you have to evaluate the patient, take the cells, then transport the cells to centralized manufacturing facility, which is usually in a different country. And then the cells are produced for at least 2 weeks, and they are brought back to your clinic, and then you infuse the patient, and then the treatment starts. So all of this process, as you can see, is quite problematic. And we should understand that we're usually dealing with a cancer patient who has a very aggressive and progressive disease. So if that process takes long, you have to keep the patient alive by different therapy, and they're usually not responsive to any therapy. So again, very recent reviews, analysis say that it takes, this is real-world evidence, it takes from 27 to 130 days in real world to have the CAR T cells infused. So 3 or 4 months for the patient who is essentially dying from the leukemia or lymphoma to have their treatment done. And that comes to another analysis from 4 largest European countries, France, Germany, Italy, and Spain, who have the commercial CAR Ts accessible. They say that, as you can see, more than half of the patients who were eligible per indication were not treated with CAR T cells. In Austria, a small and wealthy country, the same story. Less than 40% of lymphoma patients who were supposed to get this therapy, were eligible, did not get it because of for the reasons that I showed you. So again, an analysis from EBMT, European Bone Marrow Transplantation Group, from 21. As you can see, there is, for Lithuania, it's in a circle. It's not accessible. Baltic states not accessible. And there is a clear divide of accessibility in Western Europe. The darker, the more accessible, the lighter colors, the less accessible than the Eastern Europe. So again, the CAR T cells are cell therapy. And there are cell therapies that are available in many countries, like bone marrow transplantation. We've been doing bone marrow transplants for over 20 years. It's 25 years this year that we've been doing that. And if you look at the activity of bone marrow transplants in 2022, Lithuania and Western Europe, essentially there is no difference. So we're used to this. So the clear question was whether can we produce the CAR T cells and use those for the patients? Are there technologies available? So what would that do and how would that benefit the patient? Of course, if we have a patient and manufacturing in our own hands, there is flexible patient scheduling, simple logistics, faster production time. What is important? Fresh cells, because the cells that we get from commercial manufacturers are frozen, and of course the lower price. So in 2022, we actually started, after it was a preparation essentially of more than 3 years, to establish the CAR T cell production in-house, in our hospital. So we used the Multeni platform and MB-Cart 9.1 as a basis. This technology was available and was published. The results were published. They were quite good at that point. And we established this manufacturing, GMP manufacturing in our hospital, got the Drug Control Agency permit under EU regulation of hospital exemption. And the patients that were treated were lymphoma leukemia patients with no alternative treatment options. And now from this year, this treatment is reimbursed by the public health insurance in this country. So I will show you. So the question, and everyone is asking when you go to different meetings, especially for EMA, is asking whether decentralized production is feasible, whether we can produce with quality as actually in the same way as industry can produce. So you can see these are, we've now treated around 40 patients. These are 32 patients, the results from 32 patients that I will show you with at least 2 months of follow-up. And you can see that the specification conformant and released for infusion product means the product that is ready to use without any reservations. We got that in each and every patient. How does it compare to the real world evidence from centralized commercial manufacturing? And you can see here that the manufacturer failure non-conformity rate was around 10%. So of course, numbers are different, 32 versus 200, 300, but there is a tendency. It's not a, so I think that having all the products to specification was just a proof of principle that is doable. Another important thing is how fast we could do that compared to the commercially available CAR T cells. And you can see that our production cycle was 12-day production cycle, which is, so here you see that from clinical decision to CAR T infusion, we needed only 20 days compared to median 60 days with commercial manufacturing. And also from collecting the cells to infusion, 13 days. Our production cycle is 12 days, which means that we got all the cells fresh compared to 30 days, 3 times more with centralized manufacturing. So it's another advantage. And we treated very heavily pretreated patients. Essentially, you see it's 88% refractory to the last line of therapy, which means that these are the patients who did not respond to their previous line of therapy. They were refractory, means that they have no treatment options. And coming to the results, you see that the response, the complete response was in 80%. And if you focus on the first 13 patients, we have at least 12 months of follow-up. We have all those bars are individual patients. And in green, you have complete remissions, and in red, you have progressive disease. So you see that 3 patients had remission and progressive disease, and the remaining 10 patients are progression-free, and some of them, the first patients, you see, is nearly 26 to 2.5 years. The first patient was treated in June 22. They are still in remission without any further therapy, leading normal life. So we were quite happy with the clinical results. And as it comes to toxicity, I don't have a slide. We do not have, in hematology, it's very important, treatment-related mortality, the mortality from treatment. This is unavoidable, unfortunately, in many of our treatments. And patients die of transplant, of chemotherapy, other things. We did not have any treatment-related mortality up to date. We had complications, which are usual in this time, but all patients, no treatment-related mortality, which means that the clinical staff was sufficient in managing the complications. And also, the patients are all in long-term study. As per regulation, we have to follow the patients for at least 10 years after advanced therapy, for gene-modified advanced therapy. And also, they are all we are biobanking the samples for further research. So what happened? You remember in 21, where Lithuania was white, no CAR Ts. Now we're on the map, 22. It's the most recent analysis from the BMT. But also I put the red dot of in-hospital CAR T manufacturing at scale in routine practice. So you can see only 2 countries in Europe are doing that at scale, not on occasional patient, for autoimmune disease, but at scale, treating the patients. And of course, the world-famous Barcelona group, who have their CAR T cell program, and they're treating, they just wrote, I think a week ago, that they treated 360 patients in a population of nearly 50 million. We treated 40 in a population of 2.8 million over 2.5 years. But those are two proofs of principle. The other countries these are countries are CAR-Ts from either from clinical trials or from centralized manufacturing. So only 2 countries are doing this. So, and that's why the elephant in the room is the regulation. We're doing, and Barcelona group was doing that under hospital exemption, which means that no alternative treatment for patients. You can do advanced therapies. Others have regulations that prevent them from doing that. That's a European problem. Sorry, I'm European, but that's a huge European problem, which is going to get worse with the new regulation. So, actually, what are we going to do next? Of course, we are going to optimize the production. We don't need 12 days, we'll do it in 5 days, and which means that the turnaround will be around 1 week for the patient. We now see a problem that we have many patients, we need to do it outpatient service, add new indications, start clinical trials in collaboration of in-hospital produced CAR-T cells, and also we're building GMP facilities to allow for this, because we cannot do it in the conditions that we have. The construction is going to start this week, I'm sorry, and it says the center is Biomedicum Santara. Will be operational early 26, and we will have GMP manufacturing facilities there. We'll have tissue bank, biobank, SOHO, this is a new regulation for the European Union from sources of human origin, so SOHO facilities and research laboratories there. And to conclude, I think this in-hospital CAR-T manufacturing program has made the life-saving treatment available for Lithuanian patients. Otherwise, it would not have been available by now. It proves that high quality and affordable. The price for health insurance is 1/3 from the price of the commercial manufacturing. So it's a huge saving for the healthcare system. So it's a proof of principle that this is possible, and this is also lays ground for decentralized ATMP clinical trials. And I would like to acknowledge many people who are involved in this, from GMP lab, biobank, apheresis unit, nurses, physicians, coordinators, of course our patients. So this is one of our first patients. He's a policeman. This is his service dog, who was refractory with 3 lines of therapy, and it took the CAR-T cells and then allogeneic transplant to have him cured of disease. And I'd like to thank the audience for attention.
So many thanks. Very interesting presentation. We keep questions for the discussion. And now we move to the last presentation. I would like to invite Professor Donatas Vajauskas, and he will speak about the advanced diagnostics.
Good afternoon. It's my big pleasure to speak here, and despite the fact that I'm the last speaker, I hope your attention for a few more minutes. And today I'm going to talk about the cyclotron infrastructure, contribution to advanced diagnostic imaging in Lithuania. First of all, I'd like to clarify that cyclotron infrastructure itself does not provide any diagnostic imaging. It's actually the production laboratory to produce radiopharmaceuticals, which further on will be used for the PET-CT imaging. And when we talk about PET-CT imaging, I think that this is the main topic I'd like to cover at the beginning. So where we stand with the PET-CT in Lithuania, and later on I will talk about why it is important for us to have this PET-CT. So back in 2022, counting machinery, we're here. We're still here on 2024. The situation hasn't changed if we try to look at the scanned patients. We are still here. Hopefully this year, with the implementation of new machinery in Santaros Klinikos, maybe these numbers will increase a bit, but it won't change our situation in European Union. And the history of the PET-CT in Lithuania looks like this. The first installation back in 2012 in Kauno Klinikos, second installation in 2014, Santaros Klinikos, and this year update of the machine, but we are still counting 2 machineries. For the long period of time, up until now, we have accessibility for the FDG as radiopharmaceutical. This is the main radiopharmaceutical for many indications, oncology, cardiology, neurology. And this year we have started new kind of imaging with the gallium-labeled radiopharmaceuticals. So this is, I could say that this is big progress. And when we talk about the scan patients, one important factor is not only the machines here, but indications which we are able to use, the covered indications which we are able to use to scan our patients. And you see the numbers are here, not so big for the FDG indications, although this year, or maybe next year, we are expecting confirmation of more indications here, despite the fact that this bar, this green one, looks at least twice the size. I need to clarify that here is not related so much on the new indication, but on clarifying the existing indications. And we do not think about the twice as much patients just with these indications. They might give us a few additional hundreds of patients, but this is it. And of course, non-FDG PET-CT. So why we are talking about such a small numbers, and what does it, what is the cause? We have limiting factors which affects us very much, and one of those limited factors is, of course, limited logistics of these radiopharmaceuticals. For now, the single radiopharmaceutical which available with some kind of proper logistics is FDG, fluorodeoxyglucose, which we can bring from other country, from production facilities for our imaging. If we talk about the gallium, which we started this year, just you cannot make a logistics of such pharmaceuticals. You have to produce it on site. And this is what Kauno Klinikos has started this year. Another factor which is also related to the logistic is non-delivery. If we just count non-delivery due to the production, I mean cyclotron, QC lab, logistics, we have like 15% of non-delivery, and this is a huge amount. And the problem here is if we do not get those in the morning, when the patients are prepared, we cannot order on the same day, please make us another dose and deliver us. No, it's too long period of time, too long waiting for our team, for the patient, for the next dose. So we need to reschedule the patient for the next day for the imaging. And this is actually not so good if we are speaking about oncology patients, because these patients need the imaging quite fast for proper decision making. And another shortage, of course, is machinery and scanning capacity. We're still talking about the old-fashioned machinery with the limited scanning capacity. So on average, on single day, we might do 9 patients. Maybe these numbers will increase a bit with modern machinery which Santaros Klinikos has installed. So why PET-CT? Why we are talking about the PET-CT? If you look at the papers, you can read the sensitivity, specificity of this imaging modality. Of course, it's expensive imaging modality, but the main question here lies what optimization of the patient's treatment pathway and what impact on economic efficiency could make this kind of, let's say, not so cheap imaging modality. So what I did, I actually looked at the major cancers we're dealing with and tried to look randomly for the publication, and of course try to play with the ChatGPT and asking, please look for the patient management and the cost efficiency inside these publications. So this is what I get. If we decide to go more in detail in each of the cancer types, we have to spend at least half a day on each cancer types, looking at many papers which are published. My experience with the economic impact came from 2007, when I first on a Congress, European Congress of Radiology, heard a presentation from Switzerland about the PET-CT in lymphoma and how it's cost effective. At that time I thought, okay, this is a rich country, we're not compared to that, so maybe we're not in the same line with them. But afterwards, many more publications came which showed us that PET-CT, despite the fact that it's expensive, it still gives us economic effect. So if we look at the novel therapy types for the lung cancer, as here, the hypofractionated radiotherapy and PD-L1 therapies, so we have like statements like essential for early response assessment after neoadjuvant therapy, and PET-CT provides accurate staging and therapy monitoring. Of course, optimizes surgery and radiotherapy decisions based on response, and all this gives us, prevents overtreatment, reducing healthcare costs. Quite the same situation with the breast cancer. PET-CT helps to predict response to neoadjuvant chemotherapy, guides adjustment in therapy, optimizing outcomes of the patient, high accuracy in detecting residual disease, minimizes unnecessary surgery. In other terms, I could say that if we have limited disease, maybe we could apply minimally invasive therapies for that patient, also reducing the cost, and early detection and treatment adjustment as well reduces the cost. Colorectal cancer, the same story here, evaluates treatment response in oligometastatic colorectal cancer, and this is common situation, clinical situation, that we're dealing with the patient with the liver metastasis, with the lung metastasis when we want to treat those patients. Differentiates metabolic response to guide further therapy choices, optimizes surgical and ablative interventions, and again, prevents unnecessary interventions, reducing hospital costs. So when we talk about the price of these modern technologies like PET-CT applied for the diagnostics, we cannot just look at the single imaging modality and saying, okay, MRI is not so expensive, PET-CT is expensive. No, no, no. We have to look at whole patient pathway and what impact makes that kind of imaging for the managing the patient, and therefore we could reduce the cost. Same situation with the lymphoma. There are more publications here. PET-CT allows early and accurate monitoring of metabolic changes during lymphoma treatment, enabling personalized treatment decisions, interim early after 1 or 3 cycles of chemotherapy, predict progression-free survival and overall survival. And this is the single imaging which gives us such a results. No CT, no MRI can give us. Aids in identifying patients for less aggressive treatments or early therapeutical shifts, increasing treatment success rates. PET-CT-driven treatment adjustments reduce unnecessary or ineffective therapy, again leading to the cost savings. Early detection of non-responders to chemotherapy helps to avoid futile therapies, lowering both direct and indirect cost, and response-adopted therapy can reduce treatment-related morbidity, leading to fewer complications and hospitalization, further enhancing economic efficiency. So all this was about the FDG. Now what is about the non-FDG radiopharmaceuticals, which we are entering right now into this field. So one of the most common cancer type in male is prostate cancer, and what can we do with the prostate-specific membrane antigen PET-CT here. And this is a very interesting publication with the 3 messages. This publication was made on 200 patients the patients is the same group of patients which were selected for the Spartan, Prosper, and Aramis study. And what is interesting here, just for you who do not know about the prostate cancer, so these are studies for the androgen receptor inhibitors, which could be applied for the patient with non-metastatic, castrate-resistant prostate cancer. And what a surprise when we get, after performing for same cohort of the patient, performing PET-CT with a PSMA, 98% of the patient has metastasis. So what information does this gives us? First of all, the big probability that for the Aramis, Prosper, and Spartan studies, the patients already had the metastatic disease. Secondly, is that despite the fact that they had metastatic disease, the therapy works for those patients as well. And the third most important part, without PSMA PET-CT, we cannot get such a data. So this is very important for us. So summarizing about the PET-CT in oncology, prevents overtreatment, optimizing surgery, radiotherapy decision, allows early treatment adjustment, prevents unnecessary surgical intervention, early detection of non-responders, helps to avoid futile therapies, enhanced treatment precision leads to more effective care, and personalized and adjusted therapy improves patient outcome and reduces hospital stays. So overall leads to direct and indirect cost saving, despite the fact that it's quite expensive imaging modality. So let's continue with the cyclotron infrastructure, and let's see, does this infrastructure helps us to overcome those limiting factors that we are talking about, because our patients actually need more access to these kind of imaging. And when we talk about the logistics of the radiopharmaceuticals, we're talking about the on-site production and with the opportunity to deliver these pharmaceuticals to other hospitals. And we can talk about the on-site production of the radiopharmaceuticals with the short-lived isotopes, which are not suitable for any logistics. It means now on, we are able to produce the pharmaceuticals which we are not able to get otherwise. Non-delivery, production on demand. If we fail quality control of that in the morning, we can do in the afternoon. We can repeat it, yes? Easy. And again, short logistics. Please remember, we are not a big country, and delivery to Vilnius University is just 100 kilometers away. So it's much shorter delivery time, less loss of the pharmaceutical here. And the pharmaceutical is the most expensive part that we're spending, not machinery. The pharmaceutical actually is the most expensive part if we calculate for 10 years or 5 years. And of course, machinery scanning capacity. We have limited by the machinery, and we need the number of the CT scanners. As long as we do not have the integrated all these parts together with the cyclotron infrastructure, we cannot expect better results here. So what does EA say about the cyclotron? Do we get some efficiency here? Yes, establishing cyclotron infrastructure significantly boosts the production of radiopharmaceuticals, increasing the capacity of PET-CT imaging, obvious. Locally produced short-lived isotopes ensure more consistent and reliable supply for medical facilities, again, reducing dependency on external suppliers. And this increased accessibility enhances the throughput of the PET-CT imaging, allowed more patients to be scanned, more patients to be in a proper therapy management. And data back from 2012 from the US. So again, from an economic standpoint, local production via cyclotron leads to considerable cost savings. Importing radiopharmaceutical often involves high logistical costs and risk due to the short half-life. By having a cyclotron on site, hospitals can minimize the costs, reducing overall expenses in nuclear medicine, and furthermore, having local control over production enables facilities to produce a broader variety of radioisotopes, enhancing the versatility of PET imaging in both diagnostics and therapy, because right now we are shifting not only with the in nuclear medicine, not only diagnostics, but we are shifting to the theranostics, where we are talking about the further expansion of the usage of radionuclides into the therapy. And summarizing in numbers what we could expect, of course, cost reduction. Establishing cyclotron facilities can reduce pharmaceutical costs by 40%. Increased capacity, PET imaging capacity can increase up to 50%. Economical saving, this is interesting data, from $1.5 million to $2 million by minimizing procurement and transportation expenses. And if we combine next to the cyclotron infrastructure, modern PET units, and having as a solution, a whole solution, so patient throughput. We can have enhanced infrastructure, which leads to an increase in the patient throughput, improving overall service efficiency and revenue, and of course, improving the patient's outcomes. So this is it. Thank you very much.
So many thanks, Donatas. So we are coming to the end. Only the last panel discussion left, so I invite here speakers and panelists from the end of the auditorium. And I know that we are a bit late, but be sure that we will finish on time, because Grand Dukes, they're coming back to their palace, and we should go away. Just take seats. So, first of all, I see some smiles appearing. Thanks for that. And I see some of you are tired. And so half of the speakers you already know from the presentations. So I would like to present the rest. And is Elius Čivilis on my right. He's General Manager at Invest Lithuania. We also have here Paulius Petrauskas. He's Director of the Innovation Development Department at the Innovation Agency of Lithuania. We also have lady with us, Aurelia Rutkauskaitė. She's a lawyer and head of the Data Protection Practice Group at Trinity Urix. Yes, that's correct. And also we do have here Martynas Kanzeras. He's a founding and board member at Lithuanian Business Angel Network. So I wanted to have the persons from the different parts of the ecosystem. Elius, the question to you: what you are doing at Invest Lithuania? How you see your role in the ecosystem?
Well, that's a great question. What Invest Lithuania does in this very interesting conference. Well, in short, we are trying to invite international businesses to choose Lithuania to do their business. And so on one hand, we are doing pure sales. On the other hand, we are looking back at the country and see how successful and what we can provide to our potential investors as a benefit to establish in Lithuania. Because businesses are quite pragmatic. I mean, they do business out of the locations which fits best their business needs. So, and you have to have this, competitive advantage. Nobody nowadays compete on subsidies or even talents are now, so to speak, commodities. Now everyone plays on those cutting edge angles. And actually the healthcare and the data access, this is something which is very much demanded, and this is something Lithuania can really break through compared to the competition.
Thank you. I would like to ask Professor Laimonas, so you said that Lithuania is becoming more green on the map, right? And the main problems you face is access and regulations, right? So, but how you overcome all these challenges, because you providing some treatment?
These are not easy, maybe easy questions, not easy answers. We have to comply with the regulations. I need to add, unfortunately, sometimes. We do comply with the regulations. So I showed an example where the country, a small country, has a regulation that is balanced. That's why we have a success compared to other countries. Other countries in this specific field with regards to advanced therapies and hospital exemptions are over-regulated. And they cannot do what we do because of a simple thing. They are not allowed. Other countries put a specific number of patients to be treated on a hospital exemption, let's say 5, and that's it. If they put a number 5 patients to be treated, we cannot treat the 6th patient who needs that. And this is what it is. So actually, that regulation was also written by me, but more than 20 years ago. We did not, or not 20, it was 15 years ago, I think. But at that point, we did not know much about advanced therapies, but now it served us well. So the first lesson would be that when regulators regulate, they need to understand that over-regulating they may prevent innovation, that patients may not get innovation because they over-regulate. So this is one thing. Another thing that what we do, we use extensively clinical trials and compassionate use programs to get our patients treated with a different targeted advanced therapies. And there are a huge number. This is how we fill the gap. But of course, the problem is that we cannot fill the gap completely. So if there is no normally functioning access system through reimbursement, we cannot serve every patient. That's a problem in many countries, and this is a problem in Lithuania as well.
Thank you. I would like to ask Professor Yamamoto. We know that biobanking also has some key ethical and privacy concerns. So the biobanking has some ethical and privacy concerns when you collect the data from the patient. So when you invite the healthy population to give the samples for the biobank, how just to convince them to do that?
Yeah. Good question. Thank you very much. So usually biobank, if you start in a big city or urban area, it's very difficult to get the consent. While our province, where metropolitan cities and but the people are not so the urban culture. That's important. And another point is we started after the big earthquake and tsunami, and many people passed away. So the people are keen to maintain their health condition. That may be the point. So our when we asked, almost 60% of the people agreed to give us consent. 60% is really an important number because it covers a wide range of the people. While if you go to like the UK biobank style, so admission center, why don't you come and join? Then those who are really interested in their health condition will come, but not ordinary people will come. So we go to the on-site of the various activity point and recruited. So we went there. We went to the health examination event site and actively recruited. That's one reason we got success. And so multiple reasons, but set the approval rate or the consent rate is an important point for the. I'm sure the Lithuanian people are nice people, so you will have a big success of making.
I hope. Really, how do you see the current regulations about the patient and the data protection?
Well, I do work with data protection a lot, and what I wanted to share here is this thought that we always think about data protection as limitation. Let's think about that as an opportunity, because actually the general data protection regulation is about sharing of the data, just doing it in a transparent and legal way. So despite that businesses are always complaining that we are having like terrible amount of limitations, here I see opportunities. You just need a good advisor, privacy advisor with an open mind and willingness to actually achieve the goal that is set. So, yeah.
May I challenge you?
For sure.
Not only businesses complain about that. I think everyone, sorry that I'm speaking for everyone, but we have a lot of interaction with our partners, Europe and also United States, which is the third country for Europe. And when we have contracts with them, it's very easy to negotiate on everything except but the data protection part, which takes huge amount of time and also a heavy burden and a loss of a lot of time in this part. So
well, we still need some education on that.
Sorry. When you look at the outcome of this, when you look at the United States that does not have that hard data protection, and European Union, we're lagging behind. And one of the major reasons of that is GDPR. Sorry to be maybe provocative in this reason. They do not protect the data that much, and they have faster development. And we protect every letter and all the personal data with paperwork. And this is a red tape for many institutions, especially in the academic world. And we have to face it. So my wish would be, unfortunately we don't have EU bureaucrats here, that they relax those things. Relax. We have experience. We need to relax that regulation.
Well, it's just a different approach, but yeah, somebody has to do this huge amount of work, and if we do have enough specialists that are specializing in privacy, that is done easily. Because, well, you just say that you need lots of contracts, but it's doable in the end. An exchange happens.
What I see that we just trying to find a new way, because sometimes it's a bit conflicting opinions, right? Because what I hear from the Singapore, they are not allowing to get data for the huge pharma companies, right?
We don't give data to the pharma companies or radiology.
Yeah, and even from the mega bank, they have this data visiting, but not just taking the data and using for their own purposes.
That's very important. So we promised our participant is not patient, it's general people. So the security of their data is the first priority. So we promised our participant, we're gonna keep the data within us. So our supercomputer have that data, but the users can connect our supercomputer and we'll give them access right to access the data. And this way, our users do not have the data, raw data itself, which makes them safe. If they downloaded and lost the data or be hacked the data, then they're very guilty. So the very high security of a supercomputer and only the access right will protect our user from the leaking the data. So I think the data visiting system will be the world standard. IHCC strongly recommended the data visiting system.
So when you have the, for example, external company that would like to validate prognostic AI model on your data, do you allow them just to work in your own environment?
Yes, so we are quite okay them to bring in their software, or you can even produce. They can even produce the software within our supercomputer. Our supercomputer, the storage is 55 petabyte, and also the certain amount of the calculation power. So they can do these number of things within our supercomputer.
Thank you. Paulus, what are you doing at Innovation Agency? Grab one. How do you see your role in the ecosystem?
Oh, thank you. Thank you for the question. So we do the same as Elius told you, but in a different approach. So we are dealing with internal companies. We are supporting, helping our national Lithuanian companies to grow. And according to this approach, it's very important to understand why innovative businesses are essential for country's growth. So the innovative businesses are important because especially those who are deep tech, technology-based, technology-driven companies, they are not only creating added value to the businesses they serve, but they also create new jobs, pay taxes, develops new markets. In other words, such companies determines what will be created, produced, or demanded in the future. So if not having such companies, we're starting to depend on other countries or other companies who are foreign companies, and for that it's essential and could lead to the low economic competitiveness. So what we do, so we're trying to help Lithuanian companies to grow here, to make the businesses, and to become new worldwide trends. So shortly, that's it.
Okay, so how you connect with the healthcare? May I ask, Martinez, when you have your fund, right? And what is your
Not
relationship?
Really fund, So, I'm an entrepreneur and investor and also educator. So I have quite a lot of hats. But today you ask me to put this investor hat. So I'm founding and board member at Lithuanian Business Angel Network. And Lithuanian Business Angel Network unites more than 350 individuals who invest in early stage startups. So what we're trying, what we're doing, so we are helping people or innovators to turn their ideas into reality. Because especially at the beginning, you need financial support, you need human support, and you need a social support. For a lot of people, I'm saying that you need three capitals if you want to turn idea into reality. So social capital, human capital, and financial capital. So Business Angel Network, which I represent today, so could help with this. And for sure, we're investing in health tech startups as well. Or
right.
Our members. Maybe it's better to say like this. Because Business Angel, usually they invest in syndicates. So if you have an idea, so usually you attract 5 or 10 business angels who share their financials, who share their social capital, and will help this idea to turn into reality.
Are there any key factors how you attract, how you select where you would like to invest, your investors where you would like to go?
Yeah, I think there is no difference, if you are talking about health tech or you're talking about, the application which choose their dog's or cat's name. So we're looking for criteria and focus, first of all, is market need. So what you need to understand, is it really the need in the market? So because there are a lot of innovators and entrepreneurs when they are coming with an idea and they're saying, oh, I will create something, and then we're looking to the market and nobody is buying this product. So first of all, you need to understand, is it really the need in the market? Second thing, is it big enough? Because for angel investors or the venture capital, it's quite important to know scalability. So I meet quite a lot of entrepreneurs in Lithuania, and they are solving the Lithuanian-based problems. And it's okay, they are solving the problem in the hospital, but then you could not attract the investors or outside investors. Maybe you could go to the government, or maybe you could go to the local, I don't know, investor. But if you want to attract business angels, so you need to create the product which could be scalable in other countries. So for example, for myself, I'm also asking, could this product could be sold in another country, in Poland, in Germany, or maybe even outside of Europe. Thirdly, about the defensibility, because especially in health tech, there are some IP involved or patents involved. So when we are going to Aurelia asking here, is it, could we defend it or not? If she's saying that they could defend it, so yeah, then the value of the site is increasing. And the most important is the team. Because I think when you're investing in early stage startups, so the team, I think, is the most important value. And usually if we are going to the health tech startups, so usually we are meeting bright people as you, so scientists who are quite understand the product, understand the problem, but sometimes what they are lacking, so they're lacking the knowledge of the market, so the commercial competencies. So what we're looking, especially in health tech, there are some people who understand how to go to the market, how to sell this product, and etc. Simple market need, scalability, defendability, and team.
Thank you. Helios, how do you see, is healthcare innovating enough?
Yeah, well, maybe I'll step back a little bit and then I'll come to the answer. So first question is about how countries can compete worldwide. And there are three options. Either you are very cheap, we are not. You are based in a very good location like Singapore or Ireland, or you compete on competence. So Lithuania has no other option than compete on competence. Now, on our national progression plan, we defined where exactly we want to compete. And life science being set as one of the priorities. And it's supposed to generate 5% of our GDP by 2030. So what that means? That means that all of a sudden, from zero, we have to be a global level competitive nation with all the green colors and all of the possible, maps. However, this is not true because there are many of those small actions that needs to be taken back home to set this as firstly as an ambition. I mean, I hear those discussions about the privacy, it's regulation, it's favorable, it's unfavorable. We can fund systems for healthcare. We cannot fund. No, it's not the conversation. The conversation, if we really want to set this ambition, life science to be a driving force of this country. And if yes, then everything is possible because it's about, building the future, not arguing how the past looked like. So with this in mind, I just want to say that with all the respect, there's a big pressure also from the social capital on the healthcare sector because everyone wants to live healthy and for a long. And you see many sectors being transformed with digital. Now we get the financial services all over so easily. Why cannot I get exactly the same health services? Why cannot get the best possible technologies employed in the healthcare? I mean, very soon people will be on strike demanding that those sectors which are critical for survival, they are as productive when it comes to innovation as the rest of the sectors. But my personal take is that there is nothing, so to speak, unique that other sectors have not experienced. So it's just a matter of ambition and then commitment, to follow the same plan.
It's amazing. From the patient perspective, they don't care what you want. They want to have access to the treatment or to the diagnostics. So how we should convince people just to share their data and allow to use for the other purposes?
To be transparent and to think of your invention or innovation with a privacy perspective from the very beginning. We have this principle of privacy by design and default. And if you have a strategy on privacy from the very beginning, then it's easy to convince. And that was a good example. They chosen the path that they would not share their data externally. They would only allow to analyze this data inside. And that was a good strategy, I guess, because it helped them to convince the participants of the bank to give their data. So yeah, thinking about the privacy from the very beginning would really help here.
So we definitely need some patient education.
So why do we have a secondary use of data law then?
When we talk about secondary use of data, we usually talk about the anonymized data, which is not personal data anymore.
But yeah, we don't need personal data, but we still have secondary use of data law, which is a way to go around GDPR.
Yeah,
so why do we need it? And just a moment. This secondary data use law, for everyone to know, was passed during the heat of pandemic, COVID-19, when the authorities could not get the data. So the necessity brought it about. And I'm very happy about that. No one knew about that. Usually that would have caused a huge uproar, a data like that. But it's there, and it's functioning, and everyone is using that. And the world has not collapsed, and privacy is still there. So still coming back to the relaxing of the rules of the data protection.
Yeah.
Yes, please.
The secondary use of the data is the critical point to maintain the biobank. Biobank means we've collected and our data, secondary use of that data. But we've been working on the opt-out. So some companies, our participant doesn't like. So for the rest of the use, it's okay. But this company's use, I don't want. So we usually make the opt-out in our homepage. This client, this user, want to use our biobank data. So if you do not want your data to be used for that project, you can withdraw the use of your data or information or sample. So by combining the opt-out strategy, probably we can maintain the biobank. Biobank has a much bigger benefit for the society. Because of the biobank, the academic research will develop, or drug development will facilitate. So we need to realize the power of the biobank. But we also need to appreciate the participants' will. And I think that's a balance.
Thank you. Let's allow audiences to ask questions. Otherwise, I will never stop.
Well, it's probably more of a comment this time around, because I was listening to the previous session and now to this one, and I think I'll still go back to the point I made in my presentation earlier in the day, is we are small. We are small, and that is a huge opportunity, because we can be a lot more agile with what we do, how we legislate, and how we solve the problems. And in the big global world, it's not such a big issue, because as we discussed, the healthcare systems, whether you live in the country of 3 million or whether you live in a country of 100 million, it doesn't matter, because healthcare systems, they are still split into small subsections and regions. And so if you design a system that works for Lithuania, that is something that can be scalable straight away into any other country. UK is split in, say, healthcare regions serving about 2 and a bit million. Singapore about 1.5 million. In US, they're sort of similar sizes. So I think by being small, we shouldn't be less ambitious. You know, we can produce systems and ideas that would be scalable and work. Now, but the issue we do have, though, and I'm sort of in the middle on the opinion of the GDPR. I think, yeah, personally identifiable data must be protected at all costs, but talking about how do we implement the data protection in a small system is what we've done incorrectly, is we replicated the experience of the big countries and the big companies and the big systems into a small one. So there are only 2 hospitals in this country that can develop IT systems. So, and the individuals, the number of individuals in those services that can contribute to data protection is very limited. So there isn't just, within the way we set up at the moment with very fractionated IT systems, is that we just don't have the capacity to do it properly. And taking this back now to how we fund our IT, for example, 0.5% of our annual health insurance fund would pretty much double the annual investment into IT services that we do today. So if we were to think a bit more ambitiously, if we do have an ambition of delivering 5% of our GDP being biotech, then we need to be as ambitious with our sort of IT systems and say, fine, fair enough, maybe we need to just say 0.5% of healthcare budget goes to a central IT system with very clearly defined data protection and data sharing and data anonymization services that everyone can use. Yes, that would be a stepwise progression rather than linear slow, what we're trying to achieve at the moment.
Many thanks. Any other questions? No? Yes?
Just a quick comment as regards innovation. Again, just from the experience in Singapore, Singaporeans are spoiled. We're very spoiled by what we have, and we know it. But one of the things that the government did about 20 years ago was say we want to be big in biotechnology, and they brought in, they set up a system, they set up A-STAR, which is where they bring in experts in biotechnology to set up their labs and help develop the system and grow the system by bringing in experts from all over the world to seed biotechnology in the country. Second thing is that we combine our basic scientists with our clinician scientists. So we have a collaboration between the two. So we have the basic science doctors who are working away on the lab, doing all the various different testings, and then we have clinicians with problems, and by putting them together, they come together to try and solve them. Similar to CAR-T. In Singapore, they developed a novel CAR-T where they're using normal T cells and they're using this for refractory leukemias, etc. And then using a local company to manufacture. So they don't manufacture within the own hospital, but they have that wherewithal now to manufacture and to use those novel CAR-T cells in pediatrics. So that's where we're trying to get from the bench to the bedside, getting between the basic science and the clinicians, and there you develop your innovative technologies that the companies will come in and invest, and you have your spin-off products from that.
Many thanks. Yes, we are out of time, so I need just to thank you, everyone. It was too short from my side. Sorry for being late, and I think that was the first touch, and we will need to come back again at the one table if you want to be high rocket. To have good ambitions, I think it's okay. We just need to make it in a safe way. So please give us applauses, and then we are going to the closing remarks.
Africa,